Good morning everyone and welcome to Paediatric Emergencies 2021. I'm Chris Flannigan and you're very welcome to our live stream today. So we do have an action-packed programme ahead for you, but before I get into that I wanted to give you a quick update on the Paediatric Emergencies conferences and the various aspects of them, because we do get quite a lot of emails about them and what our plans are. So 2 years ago in 2019 we ran our first lecture day entitled Waiting for the Paediatric Retrieval Team, where we dealt with the basics of resuscitation and stabilisation of the critically ill child. Now that day was a physical event in Belfast and we know a lot of you travel from around the world to be at that event. We had a great day's learning and we recorded all the lectures and put them up online on the Paediatric Emergencies website and also on the Paediatric Emergencies podcast, and that day was really well received. Last year we had plans to do something similar, but unfortunately with everything that was going on in the world we weren't able to host a physical event. That actually turned out to be a blessing in disguise because we changed things over to a live stream and that actually worked much better. We were able to reach a much wider audience from all around the world, and the big advantage for you guys is you didn't have to leave your living room to watch the event. And again, that was put on completely for free. So that worked so well that in future years we are going to hold this once a year, but we're going to stick with the live stream for our lecture day because we think it works out much better and is much more convenient for you guys rather than having to come to Belfast. In terms of our intubation course, unfortunately over the last 2 years we haven't been able to run the course. It's a fairly physical day, fairly hands-on, and with the restrictions in place we haven't been able to do that. Next year in 2022 we are hoping to get that course up and going again. I don't have any firm dates for that just yet, but once I do they'll be up on the Paediatric Emergencies website. I'll also share them on social media, so if you're not currently subscribed to Paediatric Emergencies, make sure you subscribe on YouTube, Facebook and Twitter to be notified of those course dates once they are available. Okay, so getting back to today, hopefully you have seen our programme. It's over on the Paediatric Emergencies website. So that is paediatricemergencies.com, with paediatric spelt the UK way with an A in it. So at the top of the page, you'll see a conference tab. If you click on that and then select Paediatric Emergencies 2021, that's our conference homepage for today. And that's where you're going to find a lot of the information you're going to need, including our programme. So if we take a look at the programme, we've got 8 talks over the course of the day. Between each 2 of the talks, we're going to have a break, 2 breaks for coffee, and then a break in the middle for lunch. Obviously, it's a fairly long day, and we have quite a range of speakers talking about a whole variety of different topics. So there's a great deal of learning to be had over the course of the day. Some of the talks, we've actually got 2 speakers speaking, and they'll be dealing with different aspects of the same cases. Also, in some of the cases, the diagnosis on the screen is a complete lie. So don't be fooled by the label your patient comes with. We have tried to make our cases like that as well. So make sure you stay on your toes during those particular cases. We're keen to make the day interactive and we're wanting to answer your questions. So at the end of each of the talks, the speaker is going to be available with a panel of other experts in dealing with paediatric emergencies to deal with any questions that have come up. What we're asking you to do is over in the YouTube chat, which is to the right of the video, we want you to leave your questions as the speaker is giving their talk, and we'll try and get those in the panel discussion at the end of each of the talks. We did this last year and it worked fairly well. There was just one issue with it. We're tending to pick out the questions as the speaker is giving their talk. So if you wait till the end until we're actually discussing things, we probably won't get to your question. So please keep your questions in nice and early. If you have any questions, put them in at that stage and we're more likely to be able to get to your particular question. In terms of you running this on YouTube, one of the reasons we did it was because we want you not to need to sign in. Just type the address into any web browser or mobile device and to be able to watch this conference for free. The only bit where you do need to sign in is you need to be signed in to YouTube to interact with us in the chat. So we'd recommend you get signed in early in the day. And in particular, the last talk of the day is going to be a pro-con debate where you're going to be able to vote. We've got a poll over in the YouTube chat and you can vote for who is the winner. So get yourself signed in first thing this morning so you can interact with us over the course of the day. Next thing I want to do is to thank our course sponsors, and you can see the various companies that have sponsored us on the screen. Obviously, this event costs a considerable amount of money to put on. There's quite a lot of equipment that we need to do it, and a big thank you to these companies for supporting us. The other thing I'm going to do is over the tea and coffee breaks, I'm going to be showing you some videos from these particular companies demonstrating their products. So I would encourage you not to switch off during those videos. Please do take a look at the company's products. Normally an event like today would cost you quite a bit of money to come along to see, but because of these companies, we have been able to put it on for free. So please do look at their products. And again, thank you to these companies for supporting us. The reason we run these events is we're hoping that some of the knowledge that we share with you, somewhere along the line, you're going to use to make a difference to a critically ill child. As well as that, we're hoping to do some good for the critically ill children in Belfast in the Children's Hospital through our local hospital charity, Helping Hand. These guys have donated a lot of equipment to our paediatric intensive care unit, and I have personally used that equipment to save the lives of a number of children together with the team in Belfast. So they do a great deal of work, and actually with last year's live stream, we were able to raise £1,500 for the charity. We're hoping to do something similar, and obviously as this is a free event, the reason we did it for free is we are hoping that instead of a course fee, you will consider making a small donation if you had a good day to Helping Hand, and hopefully they'll be able to use that donation to make a difference to the children in Belfast. So again, over on that conference page, you'll find a link that is going to let you get to our Just Giving page to make your donation to Helping Hand. And thank you in advance for supporting us with that. The other thing that you're going to want is your certificate of attendance. Tudor Oman has done quite a lot of work on getting the system set up for you to hopefully improve the system by which you give feedback and get your certificate. So you'll find a link to get your certificate in the video description and also on the Paediatric Emergencies Conference homepage. If you fill in that and give us a bit of feedback, we'll use that feedback to modify our future events. And by selecting what sessions you've been involved in and giving feedback on those, you'll get the appropriate certificate emailed through to you. So hopefully you'll find that a bit better than the system we had last year. Final thing to mention is, as I've said, we've ran this event on 2 previous years. So if this is your first year attending, there's going to be quite a lot of videos from the previous events that you won't have seen and a whole lot of great learning. You'll find those videos over on the Paediatric Emergencies website and also in the Paediatric Emergencies podcast as audio versions. And again, eventually all the talks from today will make themselves over to the website and also into the Paediatric Emergencies podcast. Okay, so I think that's enough for me from now, and I think we should get on with our first talk. So our first speaker is Dr. Jeremy Lyons. He's one of my colleagues in PICU in the Royal Belfast Hospital for Sick Children, and Jeremy is a paediatric anaesthetist and paediatric intensivist, and he's talking today about the difficult paediatric airway.
So today we're here to chat about a child arriving into a district general hospital with a history of a known difficult airway. In general, you can think of a difficult airway defined as a situation where a clinician has experienced difficulty with face mask ventilation, laryngoscopy, or intubation. The failure to manage an airway is one of the primary causes of morbidity and mortality in both theatre in paediatrics and in A&E in paediatrics. So we have to think of what we want to preliminarily look at as we're preparing for this situation. The most urgent thing to look at is how urgent is the case. Is this an emergency? Do we have time to consider what we're going to do? Have we time to gather all the right equipment and personnel together? And it's hugely important to gather the right information from the history. This is a known difficult intubation, so there must be a history involved. And the history is either in the DGH that the patient has arrived into, or maybe with a specialist hospital down the road, for instance, in Belfast in our situation. So you need to get a hold of the notes, have a look at the history, You need to speak to people that may have been involved in it before. Somebody will have obviously declared this to be a difficult intubation or a difficult airway, as it's a known difficult airway. And if it's possible to find out from the notes and from people involved what the exact problems were, it makes life a lot easier. So the key with all of these type of situations is about your preparation. Preliminary preparation involves assessing the situation, trying to get a hold of the history involved and get as much information from that history and from the chart as possible. It is very important to gather information from other hospitals if that's where the problem has been, for instance in a specialist paediatric hospital. The key is to find out what is the difficulty. Was the difficulty with bag mask ventilation? Was the difficulty with an intubation? Or is it an assumed difficulty due to the anatomy of the patient? And once you've gathered that together, then you can proceed to the next bit of the preparation. So if the situation is difficult bag mask ventilation, this is by far the most difficult situation because you can get into trouble as soon as the child goes off to sleep. In an adult situation, you can look at awake intubation and awake procedures. This is obviously much more difficult in children, and it's very rarely possible except in the older, very cooperative teenager. The key again is looking at the history. Does the history specify exactly what the problem was, whether they were able to cope with the mask ventilation at all, who was involved in it? Was it inexperienced people? Was it very experienced people? Did you need more than one person to hold the mask? And were they able to sort the problem out with some simple maneuvers, or was it very difficult? And at this point, it should be in your head, should you be doing this at all? Is there some way that you can involve people who would be more experienced along this line, and whether you could transfer the case? If the situation is safe mask ventilation but difficult intubation, that's a much easier in some ways situation to deal with, because while the patient is asleep, you can maintain the airway and you can take your time organising things for an intubation. So, review the medical records, particularly thinking of intubation in this case. The grade of the laryngoscopy, grade 1 obviously full view of the glottis, grade 2 just the posterior commissure visible, grade 3 tip of the epiglottis, grade 4 no glottic structures are visible. In general, anaesthetists tend to think of grade 2A and B, and grade 2 you can see a reasonable amount of the cords, and grade 2B is just the very back tip of the cords. Then in your examination, things you're looking for are facial symmetry, mouth opening, presence of oral pathology, and neck flexion extension. And these can be difficult to assess in children because you may not have any cooperation at all. So facial symmetry you should be able to get the hold of, but mouth opening and neck flexion extension you may just have to sit and watch the patient for a while to see if if you can gather that information rather than asking them to do it. The Mullen-Patty score may work in very cooperative children, and we'll go through that in a second. But it's much more useful in adults, and again, you're looking more at the teenager that's very cooperative for it to be of any use. So the physical features that you might want to look for, upper incisor length, and again a child who has recently got their big teeth but is still not very large themselves, that can be a significant issue. The alignment of the incisors themselves, protrusion of the mandible, mouth opening, the palate if it's high arched or narrow, submandibular space, thyromental distance, and always remember to use the kids, if you're talking about finger breadths, it's the children's own fingers that you're involved. The length of neck, if it's too short. The neck size, increased circumference, in adults that is something that does lead you towards thinking there would be a difficult intubation. But in children, it's much less definite that has any impact at all on the difficulty of intubation. And then head and neck range of motion, as I said. There's the Mullen-Patty scoring system, and I won't go through it all, but in essence, it's the amount you can see through an open mouth in a cooperative person. So summary of what you need to look at when you're thinking about the airway. Is it a potentially difficult airway? Look at the history, facial appearance, any syndromes involved, airway scoring. Is there a history of successful bag mask ventilation, and how was that achieved? Is the grade of direct laryngoscopy known? Do you have to consider indirect laryngoscopy or fibre optic bronchoscope? And do you need the difficult airway trolley near you? I think that's 100%. You do need the difficult airway trolley near you. You plan for a failure of bag mask ventilation, supraglottic airways, surgical intervention. An ENT airway team, if it's available, can be called. And then make sure you have the correct people around, correct experienced assistants for you as either the anaesthetist or intubator, and then extra anaesthetists available to help. Anytime educated hands are always very, very, very useful. Surgical team then, as I said, ENT on standby as well. So preparation of equipment, plan ahead. Bag mask is an underrated skill sometimes. Often the registrars who come and work with us, they're so keen to get their intubations and their lines and things. But one of the things that we're most keen that someone leaves us with is the ability to bag mask a child, because that is the thing that'll get you out of a hole. It's the thing that'll allow you to temporize the situation until you get more experienced help. And being able to maintain an airway with bag mask is the thing that will save the child. Supraglottic airways can be very important. They've become more and more used in emergency situations over the last 10 or 15 years. They, in a situation where you have a difficult intubation, you may in fact be able to use a supraglottic airway successfully. And a lot of cases in theatres get done now with supraglottic airways in known difficult intubations, and it avoids the issue entirely. Multiple laryngoscope blades. All anaesthetists have their own favourite blades, particularly in children. Although I do use different blades for different scenarios, I always jokingly say that with a Miller 1 and a Mach 3 blade, you could pretty much intubate anybody. And I find the Miller 1 blade in small children is, for children that are easy to intubate, makes it slightly more difficult than maybe using a smaller Mach blade. But for children that are difficult to intubate, it's by far the best blade, in my hands anyway. And I therefore feel that I should, and therefore I do use the Miller 1 blade for almost all small children. My thinking being that if I use it for all the children, including the easy ones, then it'll be much easier to use it with the difficult children. Video laryngoscopes are hugely important, especially and increasingly so over the last number of years. The quality of them, the quality of the picture has become so much more. The key with that is that you do not need to line up the oral, pharyngeal and laryngeal glottic areas. And so basically you're able to see around the corner with them. It takes a little bit of getting used to using the either using a bougie or forceps to move the tube into position, and working through a video scope is slightly different, but we're all getting better and better at it in everything we do with ultrasound and these type of video laryngoscopes. But again, it's important to use them at times when you're not dealing with a difficult patient, because that enables you then, when you have to use it under duress, that it's much easier. The fibre optic bronchoscope has been around for a long time and is still a hugely important tool. We can either put it down a modified supraglottic airway, or just through the nose and round, while we're able to bag the patient or allow them to breathe, particularly on a mask. There are angle pieces that have little bits of on the top of them that allow you to put the fibre optic bronchoscope in while you still maintain the airway. And then the difficult airway cart. There are many out on the internet. You can see many options of what you can have in your difficult airway cart, and it's very much something that you should set up locally. But there are certain things that everybody's going to want on it. You've got equipment for helping you with the airways, such as Goodell airways, supraglottic airways, different types of tube, lots of different laryngoscope blades, and then access to video laryngoscopes, and possibly the fibre optic scope, although it generally is kept slightly separate from the difficult airway cart. And then an ability to possibly use needle ventilation and help with a surgical airway may be kept on that cart as well. So the key factor in any of this is do not start until you're comfortable that you have the people and equipment necessary. If you can bag mask successfully, then you're not in any rush. You can take your time, you can have a quick look in, see how difficult it is, and then reset your plans, reset your positioning, and then have another look, and then come back out again. There is no rush. And often the difficulties that I have been called to help people with in the past is where they've tried to do something and don't stop whenever they get into trouble, even when they were able to do bag mask ventilation. One of the keys with it is not to cause bleeding and not to cause problems that weren't there at the beginning. If the history is such that the patient has been impossible to get a decent look with a direct laryngoscopy in the past, and the people doing it were experienced, then you shouldn't try to do it, because you're just likely to make your subsequent choices more difficult. So use something that was done successfully in the past, or move on to the next step and go with the video laryngoscope or the fibre optic laryngoscope from the beginning as a planned intervention into an undamaged airway and pharyngeal region. Children, obviously the awake option is very limited, and you have to be very careful with the sedation that you give, because in all of this you're trying to sedate the child in a way that they maintain breathing. So inhalational inductions can work very well. The other option is judicious use of IV, propofol, ketamine, all of those things. Are, as long as you use them in small increments, bringing it up, sedating them slightly while hoping that they will maintain their breathing at the time. Muscle relaxants can be very important, but the key to that is that you should only use muscle relaxants when you're comfortable that you can use bag mask ventilation, and or it's the last step that you know that if you relax the patient, you will be able to get the tube in. And as we've talked about, fibre optic laryngoscopes and surgical airways. So difficult airway cart, some of the things to make sure that you have on it, I think I've already mentioned most of these. The only thing at the end, some of the adjuncts, the end tidal CO2 to check, because sometimes you may have got the tube in, but it's not actually all that easy to check that you've got it in. And end tidal CO2 will allow you to do that quite quickly. Ambu bags and suction catheters and forceps, all of these things should be available on the tube, along with stylettes, tube changers and bougies on the difficult airway cart. So sedation, as I chatted about, Inhalational sedation can be very important because it allows you to keep them breathing throughout with, for instance, sevoflurane. You can get them quite deep, and if they start to get too deep, then they don't breathe as much, and so that they regulate themselves to an extent, as long as you can keep a good airway during that time. Ketamine can be very useful. It probably, of all the other ones, of all the IV solutions, you probably maintain your airway the most, although and maintain your breathing the most. The only problem with it is you tend to increase the secretions, and so you may need more suction. Midazolam and propofol, both very useful. Propofol is very good at dampening and reducing any reaction in the airway, but it has more of a knife edge as to when they stop breathing. So as long as you're comfortable with propofol and you've used it a lot in a theatre setting, then it can be a very useful tool as well. As I said, try to maintain the spontaneous breathing. You may find that the best plan for bag mask ventilation is for one person to maintain the airway if there's some facial asymmetry, for instance, or difficulty with jaw thrust, and another person to do the bagging. And so that's where two experienced operators, two anaesthetists, are very useful. And as I said earlier, do not try laryngoscopy if it's proven to be difficult in the past, and direct laryngoscopy, that is, and particularly don't try multiple attempts if it's not successful the first time. So, in conclusion, as with anything we do, preparation is the key. Assessment of the situation, assessment of the child, assessment of the history in particular. This is a known difficult intubation, so there must be a history of difficult airway, difficult intubation. We need to look at that history and decide whether it was in a situation where there are very experienced personnel looking after it and had difficulty, or was it somewhere where you may feel that the experience of the personnel was relevant to the story. If the bag mask ventilation is safe in the history, then that gives you a lot more time and reduces a lot of the impetus to rush. But the urgency of the procedure is another key. Have we got time to gather a group of people who would be appropriate to this? Have we got time to get all of the right equipment together? Have I got time to call for a surgical team? And indeed, have I got time to access a transport team that would help you with the intubation from a tertiary centre for paediatrics? Is the venue that you're going to do it appropriate? You don't have to rush in and do things in A&E if you can move to a better situation. For instance, a lot of our DGHs will move children up to theatres for intubation purposes. Gather the right personnel. More than one anaesthetist is often handy. The experienced personnel, the nurses that are, or ODAs that are going to assist you with knowing what equipment you're likely to need and hand you the right thing at the right time can make all the difference. And then make sure that you have the appropriate equipment. So the key is don't rush and be prepared. I'm happy to answer any questions that you have on the subject.
Good morning, everyone, and welcome to Paediatric Emergencies 2021. It's great to have you join us. As Chris said, you're very welcome. We already have over 550 people who have joined us from areas as far as Malaysia, Australia, United Arab Emirates, so it's great to have you here. We hope it will be a really interesting and informative day. We've keen to keep it interactive, as Chris said. So as the talk's going on, we really encourage you to put your questions into the YouTube chat so that we can keep an eye on those. We do have a panel here who I'll introduce very shortly, who will be here to take any questions as the day goes on. And we will select a few of those questions out to discuss after each talk. So please do put your questions in the YouTube chat. We'll not be able to do them all, but we'll choose a select few to discuss. Just notice that we're joined by Jeremy. Thanks for your talk, Jeremy. Really interesting and informative. And we have the rest of the panel here at the minute. So I'm going to introduce them first before we talk through a case based on a difficult airway. So you first we have Chris Flannigan, who is a paediatric intensivist in the Royal Belfast Hospital for Sick Children. Dr. Jeremy Lyons, who is a consultant anaesthetist and intensivist in the Royal Belfast Hospital for Sick Children. Tudor Oman, who is a paediatric emergency medicine consultant, who asked me to introduce him as the boss here in Belfast. Kanaris, who is a paediatric intensivist based in Cambridge University Hospitals. Phil Ross is paediatric trainee and SIMED fellow in RBHSC at present. Peter Donnelly, paediatric intensivist in Glasgow. Peter Mallet, who's a paediatric trainee here in Belfast. Simon Jackson and Seana Molloy, who are PICU grid trainees based in Alderhay. And I am Ben McNaughten. I'm consultant paediatrician with special interest in respiratory medicine based here in Belfast also. So without further ado, we're going to hand over to Chris, who's going to introduce a case based and show a video based on a difficult airway. And then Dr. Lyons is going to answer sort of queries on how you might approach this if you're working in a district general environment. So Chris, going to hand over to you at this point. Take this forward.
Okay, thanks, Ben. As Ben says, please put your questions in as the talks are playing. We anticipated you were going to be a bit slow getting the questions in, and that's why I thought we'll start off with a case. So Jeremy, you're on for the intensive care unit, on for transport, and you're phoned by the District General Hospital about a 4-month-old that they have there. The child has bronchiolitis, 80% oxygen on high flow, wide out of the right lung, and clearly needs intubated. But do you actually remember this child when they say the name? Because they were in the Children's Hospital and you were called down urgently to the MRI scan to help another anaesthetist out with the intubation. And you think back, and I'll just pull up the intubation for you to jog your memory. So this patient had a grade 4 view with a direct laryngoscope, grade 3 view with a McGrath. This is with a gyroscope. Your colleague couldn't intubate the patient with a gyroscope, and this is you doing the intubation.
Yeah,
I think we could all agree that was a pretty difficult airway. Importantly, you can remember the bag valve mask ventilation. It was okay with 2 people and a Goodell. So that's the story. They're in the DGH. They're 40 minutes down the road. The kid obviously needs intubated, and they're phoning you for advice.
Yes, and I do remember this case in reality, and it was very awkward, even with the gyroscope, as you can see from that. And also the airway was swollen in a way that we weren't sure why, even at that stage. You could see that there was a little bit of swelling around the airway. It wasn't completely clean. And that was at a time when theoretically the airway was okay. And with the bronchiolitis that were being reported, the airway potentially could be more inflamed. So our advice was very much try not to have to intubate this child. Try to wait for help, and by help I meant me, who I was planning to go out with the emergency or the transport team. Now our transport team is not theoretically set up as a mobile intensive care team. We don't usually go out to help with the intubations. They're really meant to be done by the DGH. But that being said, there are instances where we have, well, they happen often enough actually, where we do go out and help because it's the safest way to do it. So our advice in this situation was maintain the bag valve mask. We knew that was okay. So with 2 people that it was possible to do with, and my memory was that we were able to do it with 2 non-pediatric anaesthetists involved. It was a non-fully consultant pediatric anaesthetist. There was a registrar involved. So I felt that the advice to the DGH would be that you would be able to do oxygenation through a mask And if you had to bag, then that would be possible using the 2-person technique. We would be about 45 minutes to get there. So the advice was to try and was basically to hold on for us getting there. And as you all know, 45 minutes can pass really quite quickly when you're that scared by what's going on. So the advice to them was that even with the McGrath, we had a McGrath trial at the time of the MRI, and it was a grade 3 view even with McGrath, and so the gyroscope was the one that we'd got a reasonable view with, and they didn't have a gyroscope. So again, you know, we were going to bring a gyroscope with us and intubate when we got there. We chatted through with them about what to do if things deteriorated, and one of the things is if you started having to bag the child, then we mentioned taking them. Well, we actually going to take them up to theatre first of all to get them into a good position, and even to help me when I got there, and then get everything prepared for intubation but to try not to do it. To put in an NG tube if you had to, because if you start bagging in these children, you quite often start blowing air into their stomach, and that can just make their oxygenation worse by splinting the diaphragm. And then the other things we chatted about, they had a fiber optic scope that they could have used in the age group, and the combination of a fiber optic scope and the McGrath potentially could have got you past the with the intubation, but as they pointed out, that's a difficult skill in itself in the age group, and they didn't feel terribly confident in it. We merely discussed it as a potential get out of jail free if they really got into difficulties with the child. So that was the case, and we came out, and they didn't intubate during the time. They had to support the breathing a little bit, but mostly they just used a 2-person technique or a 2-handed technique for the mask, and the child maintained its own oxygenation for most of the time. At a couple of points they had to give a few bags, but not too much. And as I got there, we were able to intubate the child a few minutes after I had arrived. So,
thanks, Jeremy. With 1 minute left, probably just time for one more question. There was a question about who, sitting in the District General Hospital ED resus and a sick neonate comes in, who's the best place to intubate that? An adult anaesthetist or a paediatrician who's done their neonatal training? I guess that probably comes down to knowing your team skill sets and confidence, but anyone want to comment on that?
I'll just briefly comment. I would say both. It's not one person's job. I think, you know, the adult anaesthetist will have a lot of skills and theoretically should be able to do down to at least under 5, and a lot of them would be confident down to 1. So that would gives you a basis, and the pediatricians are much more confident with the neonates. So it's a team in that situation. Anybody else want to?
So what I would say is that intubation is a team sport. So, and it's not just getting the tube through the cords, you know. So there's a different skill set in intubation in neonates in terms of what drugs are given or not given in the neonatal period. Is a skill that pediatricians have, just putting the tube through the cords, but how to sedate, intubate safely and optimize the clinical condition of the child is a skill that anaesthetists are better to do. So like the team said, you need to be aware of that skill set, who's done the neonatal, has had the most recent neonatal experience, who's best placed to have first pass success, but the onus and the ownership of sedation, analgesia and paralysis is almost always on the anaesthetist. So it's a team sport, but it's not just getting the tube through the cord, it's doing it safely. That's all.
Well, can I just say one more thing? Ben, I think for everybody listening, there have been a couple of papers recently, particularly the Nectarine study, which have shown that age in itself, down among the small neonates, age in itself is a risk factor for difficult intubation. So the fact that you have a inverted commas normal child the smaller they are, the bigger the risk of difficult intubation by itself without any history of difficult intubation. And if you're dealing with a neonate, you basically should assume it's going to be a difficult intubation until proven otherwise.
Okay, perfect. Thanks, Jeremy. And thanks
to make as well. Sorry, Ben.
Yeah.
I think like 95% of the time the anaesthetist is going to do these. But if you see the anaesthetist struggling, as can happen with small babies, and you're the pediatrician there and you intubate babies all the time, step up. Because what I'll often see is the pediatrician stands in the background and assumes that lets the anaesthetist try 3-4 times. So step up and put yourself forward in those situations would really be the only thing I would say.
Yeah.
Thank you. And thanks again, Jeremy, for your talk and for joining us today. Really appreciate the time you've put into this. We are going to move on to the next talk now. I'm going to hand over to Chris to introduce it.
Okay, thanks, Ben.
Thank you again to everybody.
Our next speaker is Tudor, who's already been introduced, and Tudor is going to speak about status epilepticus.
Hello, my name is Tudor Oman. I'm one of the Paediatric Emergency Medicine Consultants in the Royal Belfast Hospital for Sick Children. Today I'm going to talk to you about the management of paediatric status epilepticus. I want to have a look at the treatment considerations, potential causes, and the investigations we would perform in the emergency department. So let's dive in. Seizures are the most common neurological emergency that we see. It's our bread and butter. Around 8% of children will have an unprovoked seizure by the age of 15. Most of these will resolve spontaneously, requiring no treatment other than consideration of the potential cause and future management. Of these, the literature quotes that 1.3 to 16% progress to status epilepticus. This is affecting 10 to 73 per 100,000 pediatric population. Under 2s are more affected. Status carries with it a significant mortality of 2.7 to 8% and morbidity of 10 to 20%, resulting in significant neurological deficit. So that's the size of the problem. So when we think of status, we need to have a clear definition of what we mean by that. So what do we mean by status epilepticus? The standard definition that I learned when I was going through medical school was a single clinical seizure lasting at least 30 minutes or repeated seizures over a period of more than 30 minutes without recovery of consciousness. What we know now is that the longer a seizure continues, the more refractory they become to treatment and the higher the risk of neurological damage and cell death. Many organizations would now recognize convulsive status epilepticus after 5 minutes of continuous seizures, or at least recognize the urgency of treatment after 5 minutes if they haven't decided on a change in definition. And early treatment with rapid escalation to second line and potential RSI is the cornerstone of treatment of status epilepticus. Most of the best evidence for the treatment of status is for the use of benzodiazepines as first-line anti-seizure medication. Whether you use APLS, EPLS, or an American guideline, the advice is similar. After 5 minutes of continuous seizure activity, a dose of benzodiazepine should be administered, with a second dose 5 to 10 minutes later. IV lorazepam and IM midazolam are the most effective benzodiazepines to use. The practice I see currently in the UK is that the ambulance crew will administer rectal diazepam, and we like to use the second dose of benzodiazepine being IV lorazepam, as it's the best effective. I note that in the currently in the Australian guidelines, they use IM midazolam for the paramedics and the IV midazolam for in-hospital second dose treatment. So when the resuscitation phone rings and the paramedics inform you that they're bringing in a 1-year-old who has been seizing for the last 8 minutes, they have an ETA of 15 minutes. That's 23 minutes expected time of seizure prior to arrival in the emergency department. You know that the best chance for getting on top of the seizure is early administration of benzodiazepines. The best outcome is for benzodiazepines to be given within 10 minutes of the seizure starting. This is fine for inpatient use where they're monitored and rapid administration of drugs can be given. But unless the child is already known to have seizures and is on a rescue plan, this is not normally possible in the community. We also know that after 30 minutes of seizure, benzodiazepines become less effective. In fact, some literature quotes that they become 20 times less effective than within the first 10 minutes. And this is due to GABA receptor trafficking. So, this is a concerning finding. A meta-analysis showed that 17 to 64% of patients receive the first dose between 30 and 70 minutes, well beyond the time where benzodiazepines are effective. This delay can be explained in part by recognizing the seizure at home, contacting paramedics, the time to travel there, administer the drugs, and also the transport back to the hospital. The ambulance crew for this patient inform you that they're going to administer the first dose of benzodiazepine, as they understand that the early administration is important. You recognize that the time that they are going to have seizing prior to arrival in the hospital is also a significant delay in treatment. And therefore you advise them that after 10 minutes of seizing, following the first dose of benzodiazepine, to give a second dose of benzodiazepine. This leads you to have a preparation time with your team for the imminent arrival of this 1-year-old. You have to choose which medications you're going to prepare and what you're going to lead with on their arrival. We recognize that benzodiazepines can cause respiratory depression. A Cochrane review showed that 7.2% of patients who received buccal midazolam had respiratory depression, and on review of the other benzodiazepines, a similar number was also found. So a second dose should always be given by someone able to and equipped to identify respiratory depression and deal with it if necessary. Doses given too close together, benzodiazepine stacking, or a higher dose can lead to an increased respiratory depression and an increased need for anesthetic support. So if you want to stay on the good side of your anesthetic colleagues, don't stack your benzodiazepines. Studies looking at deviation from guidelines by using higher doses or a third dose of benzo have shown very little benefit on seizure cessation, but a twofold increased risk of RSI and a 1.5 times increased risk of PICU admission. So we decide not to give a third dose of benzo when this child arrives. So where does that leave us? Moving on to second line therapy? Well, I'd like to put a little caveat in here at the minute. The APLS guidelines in the UK still has a mention of paraldehyde as a use of an anti-seizure medication. In many countries, this has been withdrawn from use from its previous poor safety record for use as an intravenous anti-epileptic, leading to some pretty horrific side effects. But PR-diazepam has little side effects other than skin irritation. The problem is there's no evidence for its use. It's all anecdotal. However, in our department, we use it frequently. And in fact, we have some chronic patients who have seizure plans that state that their first line should be paraldehyde as they respond so well to it. So I think it's something that needs to be considered. And I think that the inclusion in our guidelines for its use gives you another option while you're preparing your infusions as second line. One thing, there's a number of things that I would like to mention in relation to its use. It needs to be mixed with 50-50 with olive oil. It cannot be given neat. The solution that we have, and the one that's on the screen here, is a pre-mixed solution and can be given in a dose of 0.8 mils per kilogram. You need to draw it up only at the time you're going to administer it, because it will dissolve your syringe. You need to hold it in, so squeeze those butt cheeks, okay? Keep the medication in to allow it to be effective, otherwise it just comes out. And you also need to be aware that paraldehyde will cause your acidosis on your gas to become worse. And I would always suggest that if you're giving paraldehyde, you should be hanging your second line therapy anyway, and that would be along with APLS guidelines. So, as the aroma of paraldehyde fills the air, you can consider your second line therapy for preparation for when this child arrives. Phenytoin and phenobarbital are currently on our guidelines, and they have been for years. phenobarbital is still the mainstay treatment for status epilepticus in the neonatal seizures and is very effective. It can cause respiratory depression and can cause hypertension. Phenytoin has a lot of side effects, including liver damage, Stevens-Johnson syndrome, arrhythmias, and even death. It also requires more time to prepare and administer, taking 20 minutes to give. So it's not a desirable drug. It's messy to make up. It requires a filter to use. And there are other drugs that are out there. Our neurological consultants have been using levetiracetam to treat seizures in their inpatients for a long time. Yet this hasn't filtered down into our guidelines yet. So there have been a number of studies coming out over the last few years. The Peruki-based study, the levetiracetam versus phenytoin for second-line treatment of pediatric convulsive status epilepticus, or the Eclipse study to be simpler, showed that levetiracetam was not superior to phenytoin, and it was set up as a superiority study and wasn't powered for a non-inferiority study. Similar rates of side effects were noted, similar rate for seizure cessation, and also time to numbers of people who stopped seizing and the time to stopping seizing were noted in this study. The New Zealand study, concept study, also came out around the same time, comparing levetiracetam and phenytoin. This also demonstrated that levetiracetam was not superior to phenytoin, and both studies gave the other drug if there was no cessation of seizing. So if you failed to stop seizing using phenytoin, they gave levetiracetam. If you used levetiracetam and you failed to stop seizing, they gave phenytoin. Another study, the ESSET study, Established Status Epilepticus Treatment Trial, came out shortly after, comparing valproic acid, levetiracetam, and fosphenytoin, again finding no difference in their use as a second-line therapy. So we have a bunch of drugs here that have not been shown to be any better than phenytoin, which is our standard treatment, but no worse, with similar rates of stopping seizures, similar rates of side effects, and similar speeds of seizure cessation. So where does this leave us? It leaves us with a drug that is commonly used for status epilepticus by our neurology consultants, that is just as effective, easier to give, and has less side effects. APLS have not yet changed their treatment algorithm to include it. Some other organisations, such as the Australian ALSG group, have decided to include it in the algorithm, either as the first, second line treatment or a second drug to be administered if the first one doesn't work. What I thought was interesting is this concept of using 2 second-line medications to try and reduce the risk of need for RSI in a child who fails to respond to the first, second-line treatment. The authors of the concept study commented on the Don't Forget the Bubbles analysis of their paper that a second-line medication reduced the number of children requiring an RSI and PICU admission by up to 50%. And thus reducing the risk associated with such an undertaking. However, the Eclipse group, also commenting on the same article, warned that children who have a real risk of significant morbidity and mortality may not benefit from a further delay on getting RSI and more definitive treatment. And they put out a word of caution saying that further discussion and a further look at the data is necessary before our guidelines change to include those as set in stone. So the way I see it is the current guidelines remain unchanged, but this gives us options to consider when we see a patient in status epilepticus. If we feel we have time for a second line treatment, then it gives us an option to use before needing to consider RSI and PICU admission. This may be more useful in areas where anesthetic support is more limited, but we'll wait to see what changes come. So, With more choices than what we previously had, and a better understanding of where the drugs fit in to our seizure algorithm for the treatment of status epilepticus, we result in having this plan. We come to having this plan for our 1-year-old coming in. Hopefully, the 2 doses of benzodiazepines have been given in a timely fashion by the paramedic crew on their way to increase the chance of this child resolving on first-line treatment. We would consider, and probably will give, paraldehyde on their arrival as a stopgap to getting up the second-line treatment, which will either be phenytoin or levetiracetam. If he continues to seize after administration of the second-line treatment, we can consider a second-line treatment, depending on how long he's been seizing and what his clinical state is. After this, we're considering RSI, using thiopentone and a short-acting muscle relaxant such as succinylmethonium. The management of status is one thing, and we have our plan for when this child arrives, but the overall outcome depends on why this child is seizing, and we need to have a clear understanding of the potential causes of seizures in children. The most common seizures we see are related to temperatures, febrile seizures coming in all the time to the children's emergency department. These are often self-limiting and resolve without any intervention from ourselves. Occasionally they can come in status. The other common group that we see are those children with known seizures who come in status. Often these children have a plan in place and we just need to follow it. Other areas that you need to consider are infection, your meningitis, encephalitis, increased intracranial pressure, such as those with space-occupying lesions, hematomas, cerebral edema, or blocked shunt. We see lots of children coming in with blocked shunts that need to be considered. Observations are key in this group, looking for signs of raised intracranial pressure, such as Cushing's triad. Ischemic insults, such as anoxic brain injury, stroke, poisoning, and this can be illicit drugs, but also prescribed drugs or household chemicals, have a high degree of suspicion, especially in teenagers, although I'd say that I have seen a child coming in with potential seizures in status at 18 months who turned out to have taken dad's ecstasy. So consider toxins, send toxicology screens, inquire about available drugs in the house, including illicit drugs. Metabolic derangement, so hyponatremia is very topical, as we all know. Keep the sodium above 135, and if it's low and the child is seizing, then give a bolus of hypertonic saline over 15 minutes and recheck it. Use your local guidance as to the dosing that you should be using. Hypoglycemia is also a concerning sign, and you should always look at it. So it's A, B, C, D, E, F, G. So it's airway, breathing, circulation, and don't ever forget glucose. Okay, so if a child's blood sugar is below 4 and they're seizing, then you should correct it. Give 2 mils per kilogram of 10% dextrose, and then recheck it. Never forget to recheck it, because if it's not gone up, or you have been without sugar for a while, it may have dropped again. Hypo or hypocalcemia can also cause seizures and can be checked on the electrolyte panel or your blood gas. Other causes, intracranial hemorrhage, either through traumatic cause, coagulopathic, AV malformations or aneurysms. And in all of these cases, you have to consider the potential for non-accidental injury. Unfortunately, in our work in children's, it's something that we always have to consider. Even when it seems innocent, we have to make sure that the story fits and then the mechanism fits with what we're seeing in front of us. It's important to take the time to quiz the parents on the events leading up to the seizure and after the seizure, what the child's premorbid state was, any developmental issues, birth history, growth and development, any medications that they may be on, and their social history. And And this gives you a broader understanding of the events leading up to the seizure and allows you to rule out some of your differentials. Investigation should be performed in all children coming in status. On arrival, you'll be putting in IV access so that you can give your second line treatment. During this, you should send for a basic screen, including an electrolyte panel, looking for your sodium, your potassium, your calcium, your CRP, and your magnesium and your CRP. You should send off a full blood picture looking at your hematological indices, including your platelet count and your infective markers like your white cells and your neutrophils. A point of care blood gas is extremely useful, can give you an idea of how significant a respiratory acidosis this child has from their hypoventilation during their seizure. It will give you an idea of the sodium, potassium, the calcium immediately, as well as the blood sugar. And this should be done in all patients coming in status. An ammonia should be considered for all children who have you have a suspicion that they might have an inborn error of metabolism, but you should also consider this for all neonates presenting in seizure. And then send toxicology if suspicious that there is something else causing this seizure. Examination of a child who is seizing should include full exposure to look for rashes, signs of infection, evidence of injury or abuse, and a full set of observations should be obtained and repeated on a regular basis, ensuring blood pressure is also obtained to rule out malignant hypertension. Further investigations will be determined by clinical findings, blood investigations, and the history from the paramedics and the carer. I put in there the history of from the paramedics, and this is me with my child protection hat on again, is that these are probably the only people who have recently been inside that house and can give you a report of what the house looked like, whether there were any drugs or alcohol present, whether the mechanism that of injury, if it was an injury, fits in with the pattern of injury that you're seeing on the child. So ask them what the home situation was like, or if they had any concerns in regards to parent interactions. Indications for CT scan include a history of focal seizures, or even if the seizure started focally and is now generalized. And again, that comes into the history. Trauma or concern regarding non-accidental injury, the presence of a VP shunt, and concerns regarding space-occupying lesions. These children should all be CT'd when stable enough to go to the CT scanner. So for our girl coming in, this 1-year-old, we've considered all these factors as we're preparing the team. The paramedic crew come in informing you that they've given their 2 doses of benzodiazepine, and the child has been seizing for 35 minutes now. The nursing staff obtain observations and you go to assess the child. They're obviously seizing. And the temptation that you're going to have is to move straight to giving IV access and getting your second line treatment up. But you know that all good resuscitation begins with an ABCD approach. And so you start off with assessing your airway. Is it clear? It is not uncommon for these children to come in with either vomit or a lot of secretions, maybe blood in their mouth. And this needs to be suctioned out to allow them the best chance of getting oxygen into their lungs. Look for any loose teeth or foreign bodies that may be there. Breathing. Seizing children often hyperventilate. Have a listen into their chest. Okay, is there good air entry? Is there good respiratory effort? Apply oxygen, and then consider giving some respiratory support in the form of either some CPAP or light bagging. These children often have a respiratory acidosis and a high CO2, and therefore need a little bit of support during their seizures. So please don't forget that. Nasopharyngeal airways can also be very useful and often get forgotten about when you're struggling with the airway. So if you have a child who you're having difficulty maintaining airway or getting good air entry, put a nasopharyngeal in. Sometimes a Guedel is more difficult to administer to pass due to the tonic nature of the seizures. But if you can utilize those as well. Moving on to circulation, children seizing will often have a prolonged capillary refill time and look unwell, probably due to a combination of the acidosis that they have and the prolonged seizure. I'm quite cautious with administering fluids to children in status unless I know they have had a significant fluid loss at some point. So I wouldn't necessarily jump in with fluid boluses with these children on the outset unless there's good evidence of infection or fluid depletion. So just be cautious with that. So as you're starting your IV attempts, you know that this child's been seizing for 35 minutes, 40 minutes now, and that if you can't get IV access, you may need to progress to IO access. And that's okay. It's important to get the second line treatment in as soon as possible. And without IV access, your options are quite limited. So IO access may be necessary. But while you're doing that, you can ask for the PR paraldehyde to be administered. So you get your bloods in, you get your line in, you get your bloods taken away, your blood sugar comes back at 6 for this patient, and we're awaiting a gas. When you look at his disability or her disability, the child has a generalized tonic-clonic seizure. All 4 limbs are shaking, and they're staring, pupils are large and unresponsive, and you request phenytoin to be commenced, and anesthetic support is requested as per our APLS guidelines. When you expose the child, you find that they have a temperature of 38.9 degrees. This could be that they have a febrile illness, and this is a febrile seizure, an atypical febrile seizure, or it could just be due to the fact that this child has been seizing for 30 minutes, 40 minutes. On exposure of the child, you note that there are no other signs. You request urine sample for culture and toxicology. I'm sorry, I should have mentioned any child who comes in seizing with a pyrexia should have a blood culture as well. While the phenytoin infuses, you take time to quiz the parents on the current history and clarify the events of the day. So this child has now been seizing for 70 minutes. We make a decision not to give a second line treatment, and instead move straight to RSI to protect this child from further neurological damage and try and get more control over their seizure activity. The child is given induction of thiopentone by the anesthetic team and a short-acting muscle relaxant, such as succinylcholine. No infusion of paralyzing agent is started due to the difficulty after intubation on identifying whether seizure activity continues. We rely on the observations, such as the heart rate, blood pressure, as well as the pupillary responses to gauge whether seizure activity has stopped or not. Up in ICU, they have other methods that they can utilize, such as EEG and CFAM, but it can still be difficult identifying when seizures stop in an intubated patient. So we've had this 1-year-old child presenting with what sounds like a standard seizure ending in status epilepticus. We've looked at the potential treatment options and why we have the sequence that we have, and the possible future developments and uses of the recent studies that we've, such as Eclipse and Concept. So I thank you for your time. I hope there was something in that talk for everybody. For a more in-depth discussion about the Eclipse and Concept studies, there are plenty of blogs out there discussing the ins and outs of those studies, and I'd recommend reading those. But if there's any questions, put them in the chat, and we'll try and answer them.
Great, and welcome back to the panel discussion. Thanks, Tudor, for that really interesting talk. It's always, status epilepticus is something we see a lot as pediatricians, but actually it's always good to question and to review our practice and to try and evaluate what we're doing and the evidence behind the treatment we're administering. So it's easy to kind of fall into a routine of I know how to treat this, but actually we need to think and make sure that we are doing things right and moving with the current evidence. So really useful to think about these common topics that we see on a regular basis in our practice. We do have had a few questions coming in. So first one was, I suppose, that's been raised, and it was actually raised by the panel here, was in the setting of a patient where you've progressed down the algorithm, you've got to the stage where you've decided to intubate, you've administered muscle relaxants. How can you tell that the seizure has terminated? And I suppose then if you're concerned that it hasn't, then what other treatment options are available? So maybe, Tudor, I'll start with yourself in that, if that's okay.
So this is always a tricky question to ask. So you've gone through muscle paralysis and sedation, and you've intubated them. There are a number of things that you can take into consideration. You can look at their observations, but these are not overly reliable and won't give you an exact time of termination of their seizure. However, I think one of the key things to remember is not to continue on giving an infusion of muscle relaxant to these children. And once the muscle relaxant has worn off, don't give further doses until you've either assessed the pupils to see if they have changed or if there's purposeful movement with this child. But it can be very tricky. Up in intensive care, you have other tools available to you, such as CFAM or EEG monitoring to see if the seizures have terminated. So if you have been unable to determine whether the seizure has terminated, then you are going to need to go on to further treatments. And most of those treatments require a medication that will cause respiratory depression. And that's one of the main reasons for giving an intubation, doing an intubation on these children, is so that you can protect their airway and give further treatment. From my experience, it has been a midazolam infusions, but I'm going to hand over to one of the other ICU guys to say if there are other treatments they would consider other than midazolam infusions. Anyone?
Yeah, so I think you're probably right, Tudor. Midazolam would be what we would tend to go with. The important thing to remember, it's not just what you would normally do for sedation. It's actually pretty massive doses of midazolam. You give quite a big bolus. I would normally start about 4 mics per kilo per minute, which would be the top end in terms of sedation. And that goes up pretty quickly to much bigger doses than you would use for sedation. Other treatment options, thiopentone came up in the discussion, but that would tend to be reserved to pretty late on. It's a really nasty drug, and if you give it by infusion, it hangs about for days and days and lots of side effects. So it's kind of really our last resort for a child we can't get the seizure to stop on. Other options then would tend to involve the pediatric neurologists, and there'd be different anticonvulsants they'll recommend in certain circumstances. That tends to be my experience of it. Start with midazolam and get the neurologist involved and work through that.
Okay. I hope that answers your question anyway.
Yeah, thanks. And I suppose there's another question coming through, just probably quick enough one to answer, that if you've got a child who's on levetiracetam, can you still give it as in the acute resus scenario?
Yes, you can give it in an acute setting. It's a loading dose again. Some guidelines might say that if they're on a medication, use an alternative medication. But yes, you can give it at the same time.
And give it at the right dose that the studies suggest, 40 milligrams per kilo. The problem is it's not yet updated in the BNF. So if you want to reference for your nursing staff to draw it up for you, you need to show them the eclipse and the concept or either of trials. But the evidence is that 40 per kilo is non-inferior to phenytoin. So don't give 20, which is what's historically been done. If you want it to work, do it properly and give 40.
Perfect. Thanks, guys. And I suppose one other question that, and again, a situation that most of us have been in when we're assessing these children have come in status is, when is the appropriate time to neuroimage in the emergency setting? So what kids in what scenarios and what children would you choose to neuroimage, Tudor, if we come to you again for that?
So we generally restrict it to those who have had a presenting focal seizure. So whether that started as a focal seizure or progressed or is a focal seizure when you see them, they can progress to secondary generalized as well. But if it started off as focal, they would get a CT scan. Those who have had trauma, whether that be NAI or a fall or something like that, they would get, or suspicion of NAI, we would do a CT scan. Babies, so neonates, would get a CT scan. What was the other one that I mentioned? Sorry. So trauma, focal seizures, and neonates. And guys, what is the other one?
So any child under 5 months. So for febrile convulsions are typically 6 months to 6 years. Any child under 6 months, about 5 months with seizures, that's unusual. Okay, so you need alarm bells ringing. It's not uncommonly to be NAI, and you will not get the typical history if it's NAI for obvious reasons. So you need to be cynical and scan these children. Over 6 months, it's a bit more forgiving.
Space-occupying lesions is the other one. Yeah. Sorry. So if you have evidence of space-occupying lesions in the history with ongoing headaches, morning vomiting, waking with headaches, those kind of things, then you'd consider scanning early. I think the question had been regarding a first prolonged seizure. First prolonged seizure outside of those age ranges that Costas has mentioned, those children are coming in, and if there's further imaging needed, we can progress to MRI or CT as an inpatient.
Yeah, and another thing coming through in the chat, a few people have mentioned, obviously, if there's shunts or there's concerns about,
yes,
shunt
absolutely, and that's your raised intracranial pressure and space occupying type. Yeah.
I was going to say, don't be falsely reassured by an ultrasound in those smaller babies just because they have an open fontanelle. It's not an appropriate investigation to pick up non-accidental injury. And in the past, I have reassured myself with a normal ultrasound, and it was only when the child wasn't behaving as they should, we got the eyes examined and then proceeded to a CT, which was grossly abnormal. So don't rely on an ultrasound in those scenarios. Okay.
And it was one more question, I think, that not necessarily related to status, but I suppose in the setting where you think maybe sepsis as a cause, about do we send blood cultures without starting antibiotics? Peter, do you want to say anything briefly on that? I see you've put something into the chat.
Yeah, absolutely. No, it's a really good question, and particularly in the age of judicious antimicrobial stewardship. But I think where there's, in these cases where there is a reasonable pre-test probability of serious bacterial or viral infection, it's most appropriate to take your cultures and commence appropriate antimicrobials in this instance, particularly in situations such as febrile status, etc. But that's a really good question.
Perfect, thanks. I think that's most of the questions come through in the chat. Anyone in the panel, any other comments?
One more, Ben, if that's all right. Or it's maybe actually two questions. So it's in terms of the drugs of sending a kid with status off to sleep with and what muscle relaxant to use. Mm-hmm. So there's always a bit of debate between thiopentin and propofol. So maybe we don't have a lot of time. So maybe just a raise of hands from the panel we'll do thio and propofol first. So a raise of the hands for thiopentin. No hands. Phil's got his hand up, but I think his screen might have frozen. We'll go for propofol. Okay, well, we'll not go into that. And then we'll go for sucks. Who would use sucks? Anybody using rock? Okay, and for time, do we need to go into those and explain the reasons?
I think we're kind of tight for time, Chris, and I think that's fairly unanimous. So we'll maybe draw this session to close. That's okay, and I'll hand back again then to yourself, Chris, just for the introduce the next talk. Thanks, and thanks again, Tudor.
Okay, no problem. Thanks, everyone. So our next speaker is Dr. Julie Richardson, who's not on the panel today. She's unwell at the moment, but she is going to be speaking on traumatic brain injury.
I'm going to be talking to you about the early management of traumatic brain injury. So we have a little 1-year-old who has presented to ED. They were staying with Granny. Unfortunately, the stair gate at the bottom of the stairs was left open and the child has fallen down a few stairs. We don't know how many because it was unwitnessed. Granny heard a bump, child got up and walked afterwards and seemed to be fine. Injury, or the time of injury, was probably about 3 hours ago, and the child has come in because they're just not quite right. They vomited once, they may have had a very brief seizure, and they're just more and more sleepy. Heart rate's 170, the MAP is 70, CAP returns less than 2, but the GCS is quite fluctuant. At 1 minute it's 8, the next minute it's 10, occasionally it's up to 12 and then it's back down to 8. And really for a lot of the time the child is just flexing to pain. What do you think is going on? At this point I'm worried. We've had a history of an injury unwitnessed. We have a child that might have had a very brief seizure, but they have settled. They're certainly not seizing now. And there's a very fluctuant GCS, which wouldn't be typical of somebody post-ictal. So I'm going to plan to intubate and ventilate this child in order to do some more investigations and to keep them safe. So I'm just going to talk you through my approach to managing an airway in a child with a suspected head injury. So for a start, this is a child that by definition has a difficult airway. We have to think about C-spine injury. In this particular case, we're less worried because the child's been up and about, but we can't rule it out completely. So in terms of management, we're going to have to keep C-spine control, which immediately makes intubation more tricky. In terms of agents that I'm going to use ketamine and rocuronium. Why do I use these? Ketamine is probably the least cardiovascularly unstable agent. It's really important when you've got a head injury or a potential head injury to avoid hypotension. One episode of hypotension can equate to a much poorer prognosis. Obviously, with the brain, you want to make sure that they are very well oxygenated. You want to pay attention to the end tidal CO2, particularly once we've got the tube in and you're perhaps directing other aspects of management and organising to go to scan. It's very easy if you're hand ventilating to either underdo it or overdo it as you're talking. So keeping a real close eye on end tidal CO2, and I'll explain the mechanism for that later on. Again, this is a child who you want nicely sedated, and also if they've had an injury, they need some pain relief. So you're going to look at those things too. So this is the scan. Child was stable through intubation, parameters all settled, her heart rate came down a little bit. Pupils were equal and reactive as before we went to scan. It was safe to go to scan, and this is the scan we found. What do you think of it? So what we have is a classic extradural or epidural with a convex hematoma, which goes from suture to suture. So an epidural or extradural is a lesion of the skull rather than a brain injury. However, it has a secondary effect on the brain. And you can see here that we've got midline shift and some loss of grey-white matter. But the most significant thing here is that we have an extradural. So what are you going to do? What's your next step? Your child is cardiovascularly and neurologically stable at the moment, and the pupils are equal and reactive. So this is a true emergency. And you're in a local DGH and you do not have neurosurgery on site. So the first thing you're going to do is ring your friendly neurosurgeon, and they are going to be interested, because what you're going to state on the phone is, I have a 1-year-old with a large extradural who is intubated and ventilated, cardiovascularly stable, pupils are currently equal and reactive. Why are they interested? Because this needs their help and it needs it as quickly as possible. So what they will be doing at the other end of the line and the tertiary hospital is preparing a theatre and perhaps opening a second theatre so they can get this child into theatre as quickly as possible. So what's your next step? Well, you're going to give PICU a quick ring out of politeness and to let them know there's a child around, and if they are very useful in terms of giving you some further advice if you've forgotten everything I say in this talk. The next thing you're going to do is ring for an ambulance. It is absolutely paramount that we move this child as quickly and as safely as possible, and time is of the essence. This really is a true time critical transfer. The PICU team and your local transfer team will not come out and collect this child and retrieve it, because that takes more time. So you need to be ready to move this child as quickly as possible. You're going to pay attention to some of the neuroprotective mechanisms that I'm going to talk about later, but actually the real priority here is surgery, and you must move, and no delays for putting in central lines and arterial lines. If the ambulance arrives, you need to be ready to get in it and move quickly. In terms of transfer, you need to be prepared for this eventuality. So it's something that as a hospital you should have had a thought about, had some sim practice and worked out what you're going to do when this happens. Extradurals in children are uncommon, but they happen, and time is of the essence. So you're going to prepare for transport like you would for any other child, although you do this less frequently, so you need to have thought about it before. So you're going to prepare equipment, you're going to prepare for disaster, you're going to predict what happens if the tube comes out, what happens if the line comes out, but you're also going to think about what happens if the child deteriorates and think about what you might need specifically for this child. So you're going to try and think through what management you might need. PICU will always be helpful on the other end of the phone. So en route, on transfer, this child suddenly has a dilated pupil. You don't know that at first. All you can see sitting in your chair on the ambulance is that the child suddenly became very hypertensive and there was a bit of a bradycardia. So what are you going to do? The first thing you're going to do is stop the ambulance, and you're going to check the pupils. And yes, you were right that one of the pupils has blown. What are you going to do in this situation? What's your next steps? So the next steps are you're going to sedate this child more heavily, make sure that they're asleep. You're going to use your hypertonic saline that you thought ahead and thought, I might need that, and you're going to give 2 mils per kilo of hypertonic saline, and you're going to briefly hyperventilate this child for 5 minutes. And then you are going to move, get the ambulance moving again, and really as speedily but as safely as possible get your team and child to the tertiary centre. Because absolutely nothing you can do in the back of the ambulance is going to make too much difference to the actual bleed itself. You might help a little bit with the secondary brain injury. So when you get to the tertiary centre, you will be going straight to theatre, and the anaesthetic team and the neurosurgical team will be there waiting for you. They're lightly scrubbed and ready to go. As you hand over events, they will be already prepping the skin and beginning to open the head, because this really is a timely situation. They need to take the clot out, and almost 2/3 of extradurals are secondary to rupture of the middle meningeal artery, and that needs to be cauterized and fixed. At that point, you'll step back. This child post-op will go to paediatric intensive care, where they will be asked to wake the child up immediately. And all being well, and if this has happened quickly and fast, the child will wake up and be completely and utterly well, and you will have actually saved a life. Right, okay, so you saved a life, well done. I'm so pleased. Extradurals are uncommon, but it is really about identifying them, thinking, could it be, treating them and getting moving as quickly as possible. So now we're going to rewind, and we're going to go back to our 1-year-old. So this 1-year-old this time has come in, and the history is that their older brother has hit them with a toy earlier in the day, about an hour ago. They come in, their heart rate is 170, their MAP is 70, their cap return light before is less than 2 seconds. You're told that they are seizing, and their GCS is 6 to 8. When you arrive, you actually think this child isn't seizing, they're posturing and they're decerebrate. And I have to say that's something that does get missed occasionally, because in paediatrics we see so many seizures that we're very tuned into them and very good at identifying and treating them. Posturing is less common and it is sometimes missed. So I think if you've got a child with an unusual history or is not responding to seizure management, I would always just have in the back of your head, could this actually be posturing? Am I dealing with something else? So back to managing the airway, and oh, surprise, surprise, it's exactly the same. So by definition, this is a difficult airway. This child is 1, so they'll be in the neutral position, which makes it not too tricky. If this was an older child, you might want them in an extended neck position, usually for intubation. Obviously, you can't do that because you've got to protect the C-spine. So it is by definition a difficult airway, and it's useful that the whole team is aware of that and knows how to help you and keep inline stabilisation. The other thing about trauma is that they always have a full stomach and they're very much more likely to vomit than other children. So you need to be aware that aspiration and vomiting is possible and be prepared for that and know how to tip your bed, etc. Again, I'm going to use ketamine and rocuronium for the same reasons as before. Again, I'm going to avoid hypotension. We're going to oxygenate really well, and I'm going to pay a lot of attention to my end-tidal CO2 and get a gas as soon as possible to check that my PCO2 is just perfect. Again, once intubation has been achieved, I'm going to introduce continuous sedation, probably morphine and midazolam, and which includes some pain relief. So this is the next scan. What do you think of it? I'll give you a minute to look. So in this case, we have a different situation. So as you can see, there's a lot of external boggy swelling, and actually you could feel this and see it when examining the child. We've also got a very definite comminuted fracture. We have a subdural. We have definite loss of grey-white differentiation, and we've lost our ventricles, and there's perhaps a little bit of midline shift. So what are we going to do next? Well, unlike the last case, yes, you may well contact the neurosurgeon, but they're going to be a lot less interested. I'm going to tell you a secret. Neurosurgeons don't like head injuries because they can't do anything about them. It's rare that they can do anything to change their outcome. And really, it's all about doing some basic things really well. We can do absolutely nothing about the injury that has happened already. All we're trying to do is to prevent secondary injury, secondary swelling, trying to manipulate the intracranial pressure as best we can. In order to understand the management of traumatic brain injury, I think you need to understand a little bit about the Monroe-Kelly doctrine. And that really is talking about the fact that you have a closed box in the terms of you being your skull, and there is only so much you can put inside it in terms of volume before it leads to high pressure. Obviously in an infant that's different because they have an open fontanelle, and that's why some infants get away with quite serious injuries, because basically they've got an open lid and the pressure is let out, and you feel that when you've got, say, a meningitis and they've got a full fontanelle. So in the usual circumstance in the skull you have 3 things. Mostly you have your brain taking up the vast majority of space, and then you've got a static volume of CSF and blood. Once you get to a point where the brain is injured or there's something extra in the brain, you're putting in extra pressure. So in the second diagram, this is where we have the extradural. So the extradural could be replaced by a tumour. It just means you've pushed something extra into that brain, which is a very fixed volume, and in doing so that squashes the brain and the CSF and increases the pressure within your brain. That's the mechanism of increased ICP. And then in our current situation, the blood-brain barrier has become disorganised and broken, and therefore changes in blood flow are much more likely, and I'll demonstrate that I'll demonstrate that in a moment. The brain itself has become swollen, which then reduces the volume in which the CSF can take space, and the ICP rises. And this is demonstrated in this graph, which shows you pressure volume. So in terms of, if you think of it a bit like a suitcase, so you have your suitcase, nothing in it, you put more and more clothes in, more and more and more, you try and close it, it closes, you open it, you put some more things in, it closes, but you're struggling more and more to get it closed. And then at some point you put so many things in that when you close it, the pressure within it just pops open. And you reach a point where exponentially pressure goes up. And that is what goes on in that closed box of a skull. So as I say, the reason that infants get away with fairly severe injury sometimes is because they have got an open box. And the pressure at which the exponential rise in pressure happens is about 20 millimeters of mercury, which is why that's the aim, to keep ICP below that range if possible. In a smaller infant, actually, we may be overestimating what it should be, and it may be 15 millimeters of mercury is where we should be targeting once we've got an ICP monitoring. But currently we're in the ED, we do not have access to an ICP monitor as yet, but there are some things that we can do to actually help and to try and alleviate and reduce pressure if we can. So it's really important to do the basics well, and I cannot emphasize this enough. And even when we go up to intensive care, this is the main emphasis of management. It's not the fancy stuff, it really is doing the basics well. So what are the basics? So if you haven't already, you're going to put this child head up, about 30 to 40 degrees. And why do you do that? It's basically about allowing your venous drainage to occur. It's about gravity and allowing blood to flow away from the head. Then you're going to pay attention to the lungs and your gases. You're going to oxygenate this child really well. Why are you going to do that? Because the brain lives on oxygen. So you want your SATs 96 and above. You want your PaO2 8 to 10 or more. You're also going to control your PCO2. We've talked about paying attention to your end-tidal CO2. Now we're going to talk about your PCO2. And it's really, really important. And I rarely say I want things to be perfect because it's impossible, and it is impossible, but I want that CO2 to be 4.5 kilopascals, or I want you to aim for that. And why do I want it to be absolutely perfect? Because physiologically it makes a huge difference to the amount of blood that you send to the brain and the amount of oxygen. So if your CO2 is too high, your blood vessels vasodilate and you're putting more blood into the brain and causing a rise in ICP. If you reduce your CO2 down to the 3s, then your ICP will fall, which might sound like it would be a great thing, but the problem with that is you've actually led to vasoconstriction of the blood vessels and you're actually limiting the amount of oxygen to the brain, which is not a good thing. So I want the CO2 to be perfect. In terms of other things that you need to manage, so blood pressure. So you want good blood pressure. You want to avoid hypotension. We don't have an ICP in place at the moment, so we can't really decide what the cerebral perfusion pressure should be at this point. But you want the blood pressure to be adequate and good for this age of child. One note, if you are struggling with hypotension in this child, I would be looking for another mechanism of injury. Is there somewhere else that this child is bleeding from? Is it the abdomen? Is it the pelvis? Is it in the thigh, femur injury? Because If the skull is closed, you should not be able to lose enough blood into your skull to drop your blood pressure. Obviously, if this is an infant, that can be very different. You can lose your whole circulating volume into your head, in which case that can be the only injury. But if you're having trouble with hypotension and you've not given drugs or anything that would cause that, look for another injury. The other thing you're going to do is you're going to pay attention to the glucose. You want to avoid hypoglycemia. The brain's fuel is oxygen and sugar, so if you don't have enough sugar, it's like a neuronal assassin and you will not have a good outcome. The other thing you're going to pay attention to is the sodium. I'm not worried if the sodium's a bit on the high side. I actually prefer it like that, but I would want to avoid hyponatremia and fix it. In terms of temperature, these days we want the temperature to be normal, and certainly we want to avoid pyrexia. Every degree C of temperature that rises above the 37 increases the metabolic rate exponentially, so just be careful. So avoid temperature. You want to sedate this patient really well. What you're trying to do is switch off as much brain activity as possible and really let this brain rest. So you're going to sedate them well and make sure that they are pain-free, because pain will absolutely cause a rise in ICP. Prevention of seizures. If you've had a head injury, there is a chance that that might lead to a seizure. And a seizure increases the metabolic demand of the brain by a huge amount, so it is best if it doesn't happen. And these days my recommendation would be to start Keppra and probably run that for at least 7 days. Okay, so medical management is really important. It's doing the simple things really well is really important and may make the difference. There's not a lot of evidence about everything that we do in intensive care. In terms of prognosis, it definitely, some of the things we do changes the ICP, but does that make a better outcome? A lot of that is unknown, but these basics are really important. The other thing that might be considered at this point, although rarely, is a surgical decompression. In this particular child, it's unlikely because we've got a skull that's fractured, which will be allowing some of the pressure to dissipate. This is where the neurosurgeon needs to be involved and have a serious conversation about, is an early decompressive craniectomy something that will be useful in this case, and it's very much a case-by-case decision. But decompressive craniectomy, if undertaken, is proven that the earlier you do it, the better the outcome. So to go back and summarise what we've talked about, do the basics well. You have this patient head up, you want to provide good oxygenation, you keep the CO2 perfect, you avoid hypotension, you avoid hypoglycemia, you keep them apyrexial, you sedate well, and you avoid seizures. The other little things are, you're going to put a catheter in if you haven't already, because if this child's trying to pee and can't because of all the drugs you've given them, that's going to put their ICP up. You're going to try and minimise handling and log rolling. Again, those things will put up the ICP, but are important to be done at least once so that you know what you're dealing with. And in terms of suctioning, you should suction and make sure the ET tube remains patent. People always worry about causing a spike in ICP with suctioning, and in truth, when we have an ICP monitoring, that does happen. We often give a little bolus of sedation beforehand, but what would be far, far worse than doing a one-off suction is if an ET tube actually gets blocked and you have to change it. That's definitely going to put your ICP up. Okay, so going back to our child, we've done all of those things and they've been very stable, and we're going to think about they're not suitable for a decompressive craniectomy, and we're going to move them up to intensive care. However, let's go back to the history. This was a child who seems to have a very severe head injury, and the story was of a child, an older child, hitting them over the head with a toy. That seems unlikely in view of what we found on scan and the way the child is behaving. So we're worried about safeguarding. And it's really important at this point to get a multi-agency approach, get the police involved, get social services involved, make sure that any other children in the family are protected and safe. You need to be really open and transparent with the family about your worries and concerns. A detailed history about time and what happened and where things happened is really important. A body map has to be thoroughly completed to document any other injuries and the injuries that you find, and there should be detailed measurements and photographs taken. And then you need to make sure you've done some basic investigations, including the full blood count, clotting and U&Es, and really follow your local safeguarding pro forma. It's important that this is done in parallel with looking after the child. Obviously the ABC and medical management of the child comes first, but this needs to go hand in hand and must be delegated if you can't do it yourself. And the sooner you get a detailed history and get a catalogue of events, the better. That's all I'm going to say today. The management in paediatric intensive care really continues what we've talked about, and we add in a few other strategies, but the basics are the most important and well proven aids to care of the child with a traumatic brain injury. Thank you.
Hello and welcome back. Thanks to Julie for that really interesting talk. As Chris said, unfortunately, Julie can't join us today. Panel here are happy to take some of the questions. So thanks for sending those in. And it really is important that you continue to send those in because we're keen for this to be as interactive as possible. So early in the talk, there was a question that came in about how safe it is to use ketamine in the setting of the head injury versus thio. I'm just wondering, Chris, is that something you'd like to maybe comment on?
Yeah, no, I'm happy to cover that. I think if you went back 10 years ago, thio was probably the standard for these patients because people were worried about raised intracranial pressure, and as we know, thiopentone reduces that. The big problem with that is thio also reduces your blood pressure, so it reduces your cerebral perfusion pressure. And as we all know, hypotension is one of the things you need to avoid. Have you ever seen a well patient come to theatre, been given thio, their blood pressure plummets when they're given it? So it's the last thing you want to do with a patient who's got a head injury. Ketamine is the stablest drug. It's going to actually potentially slightly increase your blood pressure. There was some worries about it increasing intracranial pressure, but I think those earlier studies have been refuted. So ketamine is without any doubt the safest drug to give these patients. It probably won't drop your intracranial pressure, but it preserves your cerebral perfusion pressure, which is the most important thing for these kids. So as an absolute standard, I think we're all agreed on the panel here. We would all use ketamine for these children.
Perfect. Thanks, Chris. And another question. So Julie had mentioned in her talk the use of hypertonic saline. I know there's previously been some discussions around hypertonic saline versus mannitol, and there might be some variation in practice. Seana, you wrote a paper in Archives on education and practice on traumatic brain injury, which is really useful, well-distilled article. And just wondering, have you any thoughts on mannitol versus hypertonic saline?
I mean, I think it's pretty much practice, pending what you use in each unit. There is some evidence, mainly in adult studies about hypertonic versus mannitol, mainly in favor of hypertonic. I mean, hypertonic, low penetrance across the blood-brain barrier, which reduces ICP by osmosis and restores the natural cellular membrane potential and cell volume, whereas mainly mannitol reduces blood viscosity, and there are adverse effects of both, but mainly in adult studies, there's some evidence they say that hypertonic is more effective than mannitol, and I think Costas has a link to a small RCT in kids, but as always, there's only limited evidence. There's no studies available for mannitol and pediatric traumatic brain injury to support its use over hypertonic, so I think maybe from evidence, be it limited, that hypertonic has the headway over that. But again, it's up to debate and what people use in their unit.
Yeah. Perfect. Thanks, Seana. And just I suppose while we're talking about fluids, there was another question about the you're in the DGH, this patient's come in. Is there any argument for preemptive use of hypertonic saline, sort of before you transfer, just as a kind of preventative measure? So Kostas, I think you were keen to maybe answer that one.
Yeah, so I wouldn't routinely preemptively give it with one exception, probably. If you're significantly hyponatremic, so about 120 or less, where you're also more likely to be having seizures because of that hyponatremia, I would then give it, because you need a high normal sodium to neuroprotect appropriately. You need to have it pre-drawn and ready. So the dose we tend to use is 3 to 5 mL per kilo of 3%. Have it pre-drawn preemptively and have it as part of your armory and part of your plan if the patient on transport starts having Cushing's features, so bradycardia, hypertension, and abnormal breathing. But giving it preemptively is not really indicated. But hyponatremic states, yes, you would give it.
Thanks, Kostas. And I see there's questions just come through in the YouTube chat, and this is something we were discussing as a panel, so I think we were picking up on, and it's regards to the use of TXA in traumatic brain injury. Stephen, ED consultant, do you have any thoughts on that?
Yeah, the evidence from a paediatric population is pretty limited for TXA in general, and we're trying to get a little bit more evidence, and we're trying to interrogate the TARN database, which is a trauma database in the UK, to try and give a little bit of guidance on TXA. But our current practice is that we use TXA for traumatic brain injuries, follow the current guidelines by the Royal College, so 15 milligrams per kilo, and give it ideally within 3 hours. In terms of the adult studies, you're really looking at CRASH 3, and looking at that evidence trickling down in the paediatric practice, but most of us will use it.
Perfect, thanks. And again, I see another question coming through about moving children with traumatic brain injury by helicopter. Catherine, your HEMS involvement, and I see you've made a comment sort of about the issues with that. So would you be happy to give a sort of brief statement on the challenges in that front?
Yes, the main challenge with this is mainly to do with do the children need intubated before you fly them, because you can't really intubate a child in flight. It's very difficult. We would do all of our preparation on the ground, so if you need a RSI, it'll be done at scene before the child is loaded onto the helicopter. Once they're secured in flight and to be flown to the MTC, all you really want to be doing in flight, because you can't move around very easily, is to be pushing hypertonic saline if you need it as a bolus, or deepening sedation, or having your anti-epileptics ready to go if there's evidence of seizure activity. The children that are difficult in the pre-hospital scenario are the ones that aren't so deeply unconscious that they instantaneously need a RSI, that are more awake, and you are weighing up the benefits of controlling the airway versus the speed of getting them to hospital. These ones are the difficult ones where you may take them by road, because you know that they may deteriorate and need that intervention en route, and you'd rather be doing that on the ground in the back of an ambulance that you can stop really quickly, versus in the back of a helicopter. But that's always a difficult decision based on where you are and how long your flight time is.
Thanks, Catherine. And just keeping an eye on the questions coming through. So another one, good question about, would you recommend prophylactic anti-epileptics in such cases? Kostas, again, you commented that in our chat. Are you happy to speak on that?
Yeah, so I do, because I feel we have nothing left to lose if we give a safe anti-epileptic. This is important. So since the advent of Eclipse and concept studies, given how safe Keppra is without the risk of arrhythmias, I have a very low threshold to give it to all TBIs, all post-cardiac arrest patients, to try and help neuroprotect them better, because we're not very good, especially when we're mobile and retrieving and moving around, at monitoring for seizures. So the very least I can do is give them 40 per kilo of Keppra, which is safe, and then I can put that at rest. That on balance, I'm probably doing as best as I can to not allow them to have seizures without me noticing it. So yes, I would give it routinely.
I'm going to maybe add in a wee bit there.
I completely agree with Costas, and certainly in the ICU, all these traumatic brain injury patients I would give anticonvulsants to. That first patient with that really time-critical transport, I maybe wouldn't recommend the DGH given the anticonvulsants because it's one additional thing to do. Again, I wouldn't recommend they put a central line in, I wouldn't recommend they put an arterial line in or a catheter, but we're going to do all those when they get to the tertiary centre. And I would worry that might just delay the transport by 5 minutes. Maybe they're not so familiar in that hospital with Keppra and drawing it up in a personal way from transporting that patient. So I suppose that's maybe the only thing to weigh up in that scenario. But the patient who's not time critical, I would 100% agree with you and give it in that scenario.
And that leads on nicely, Chris. We've probably about 1 minute left, but there was a question that come through earlier about asking, is there a national standard? I don't know if that exists, but how long should there really be before a DGH gets a patient after the diagnosis of an extradural on the road on the way to the tertiary centre? And I assume that's really as soon as possible when they're sort of stabilised. Anyone keen to comment on that?
I mean, they say the golden hour, and it depends where you are geographically in the UK. At least I know we have an international panel, but with the advent of trauma centres, most advice is if there's trauma, and this is important, it's not just trauma, not just the head, it can be anything. So if the neurosurgeons say we don't want without a scan, it doesn't matter. There's other parts of the body that can make you die if you get traumatized. So you don't need to CT in a DGH if you're within a trauma network. So it's faster. It shows it's faster to scoop, stabilize quickly, run, go to the trauma center, major trauma center that does this a lot more frequently and much more efficiently by default. And they will scan much faster than a DGH would. It depends on your local setup. This is important. So if you're not within a trauma network, then you would need to scan yourself before you move.
Thanks, Costas.
And one additional little bit of advice, really key pearl, I think, is once you're in the district general and you realise you have a time critical transfer, phone the 999 ambulance at that point. Don't delay it. If you have two paramedics standing at the bottom of the bed, you will not do anything unnecessary to that child, and it will be a big reminder to you that you need to get that child out the door, and that's the priority.
Perfect. Probably need to wrap up there. Thanks for everyone for your contributions, and thanks to everybody for continuing to send through questions and chat. I think it's time for a coffee break, but I'm just going to hand over to Chris just to confirm that. Thank you.
Yep, that's right, Ben. We're going to take a quick break now for about 10 minutes or so. During the break, we are going to play some of the videos from our sponsors, so please do take a look at those. Again, the reason we've been able to do this for free today is because of the sponsors. When we do come back, we're going to get straight into the next talk, and it's going to be myself and Ben talking about asthma.
With reusable scopes, setting up a bronchoscopy can involve a lot of waiting. Waiting for the respiratory therapist to call you back. Waiting for a time slot. Waiting till a bronchoscope is available. The Ambu A-Scope 4 Broncho is ready when you are. You simply grab the scope and monitor and are ready to go. With reusable scopes, contaminants can hide in the bends and channels even after high-level disinfection, bringing risks to your patients. With Ambu A-Scope 4 Broncho, you get a brand new, sterile bronchoscope straight from the pack every time. With the Ambu A-Scope 4 Broncho, you get more than just a bronchoscope. It's a fully integrated solution with 3 scopes, a tailor-made sampling solution, and a high-definition monitor to help you deliver the very best in patient care. Ambu A-Scope 4 Broncho. Guaranteed sterility, ready when you are.
True Baby X represents the appearance, weight, size, and movement of a 5-month-old. The pediatric clinical skills training model is ideal for anaesthetists, nurses, and other pediatric emergency medical professionals practicing directly observed practical skills, pediatric advanced life support, and critical emergency medicine. Techniques and skills which can be taught include infant airway management, CPR, peripheral venous cannulation, PICC line insertion, needle thoracentesis and chest drain, intraosseous infusion, urethral catheterization, and lumbar puncture. The model has been designed to be fully interchangeable. All the parts are cost-effective and can be replaced quickly when required. The initial setup time is less than 5 minutes. This model is part of the AirSim X range, which provides realistic and durable training and comes with a 5-year warranty on the Airway and 1-year warranty as a standard for all other parts. For more information or to speak to a product specialist, email info@truecorp.com or call 4428 3888 2714.
GlideScope Core, the most comprehensive and flexible airway visualization system for video laryngoscopy, bronchoscopy, and multimodal airway procedures. GlideScope Core is an all-in-one system offering immediate access to the tools you need to visualize the airway and tracheobronchial tree. Designed around a high-definition touchscreen monitor and comprehensive workstation, GlideScope Core delivers elevated visibility and improved workflow with both the 10-inch and 15-inch GlideScope Core monitors. Now you can see more and do more. With dual connection ports, GlideScope Core is the first airway visualization system to offer live multimodal imaging, picture-in-picture on GlideScope Core 10 and dual view on GlideScope Core 15. You can now view the airway via a GlideScope video laryngoscope and B-Flex single-use bronchoscope simultaneously, helping to navigate routine and difficult airways. Record, take photos, and annotate through one device. Display, play back, and export captured videos, images, and patient notes from the monitor's gallery. Completely redesigned based on user feedback, the comprehensive workstation features an adjustable arm for optimal monitor placement over your patient, putting the monitor and SpO2 and pulse rate reading in your direct line of sight. The cable organizer and convenient prep tray ensure easy access to the airway tools you need right when you need them. The GlideScope Core workstation adapts to your space and offers the flexibility you need to fully focus on your patient. GlideScope Core is compatible with GlideScope's extensive portfolio of angulated and Max-style video laryngoscope blades and B-Flex single-use bronchoscopes. GlideScope Core is always ready, with everything in reach. No more having to use multiple systems or vendors for video laryngoscopy and bronchoscopy or when utilizing the multimodal airway approach. Now, your airway visualization system does more by supporting bronchoscopy-assisted procedures in OR, ICU, and ED. From the brand you know and trust, GlideScope Core gives you the power to see more and do more.
Hello, my name is Ben McNaughten. I'm a consultant paediatrician with a special interest in paediatric respiratory medicine based here in the Royal Belfast Hospital for Sick Children. This next talk focuses on the management of children and young people presenting with acute severe asthma. I'm going to deliver the first half of the talk before I hand in over to Christopher Flannigan, paediatric intensivist, who will take over for the second half. So why did we choose to do a talk on the management of severe asthma? Well, firstly, asthma is common in children and young people. It's estimated that 1.1 million children in the UK are receiving treatment for asthma, which works out at approximately 9% of all children and young people.
Importantly too, asthma still kills. The National Review of Asthma Deaths in 2014 showed that within the period of the review there were 28 deaths in children and young people. Of those deaths, only one was felt to have been adequately managed. This is a worrying statistic, and we do know since the National Review of Asthma Deaths in 2014 that the UK continues to have a higher mortality rate in children and young people with asthma than the rest of Europe. Although many of the recommendations published in that guideline and that review were focusing on outpatient management of children and trying to prevent the acute exacerbations that we're going to talk about today, it is inevitable that we're going to see them, and it is imperative that when a child presents with an acute severe exacerbation of asthma, we manage them appropriately to prevent morbidity and mortality. We're going to use a case-based discussion today to talk through the management. We'll look at some of the controversies and some of the unique challenges that we face when we're managing children with acute severe asthma. This is a fictitious case, but one that most of you will be familiar with. The scenario is that you're working in a district general hospital and the triage nurse has come to ask you to see a patient urgently who she's brought directly from triage to the resuscitation room. It is an 8-year-old, non-asthmatic, with previous PICU admissions with wheeze. They have admitted to relatively poor compliance of late with their regular inhaled therapy, and they presented with a 2-day history of cough followed by a 1-day history of increased work of breathing and shortness of breath. Their weight is estimated to be 30 kilos, and you go to assess them in the resuscitation department. You perform a structured A, B, C, D, E assessment and find the following clinical findings. Assessment of airway reveals that it's patent, although the patient is struggling to talk in full sentences. Their oxygen saturations are 88% in room air. They are tachypneic, with marked increased work of breathing and use of accessory muscles, a prolonged expiratory phase on auscultation and bilateral wheeze with reduced air entry throughout both lung fields. They're tachycardic with a pulse of 135 beats per minute. The capillary fill time and blood pressure are normal. Disability-wise, they are alert and orientated. Their blood sugar is slightly elevated, 7.1, and pupils are equal and reactive to light. And on exposure, you note that they have some eczema in the flexures. You decide that the most likely diagnosis is an acute severe exacerbation of the asthma, and this falls into the acute severe asthma category as outlined in the BTS and SIGN guidelines. Criteria for this is shown on the slide. They don't yet have any life-threatening features, and so that does not push them into the life-threatening category at this stage. And as a result, you decide to implement 3 key clinical treatments at this stage. The first is oxygen, the second, nebulizers, and the third, steroids. And we'll talk about each of those in more depth now. BTS and SIGN guidelines would recommend that all children presenting with severe life-threatening or asthma or with oxygen saturations less than 94% in room air should be supplied with high-flow oxygen via tight-fitted face mask or nasal cannula and the flow adjusted appropriately to maintain their saturations in the normal range of 94 to 98%. Children presenting with severe asthma or with saturations of less than 92% in room air should also be administered oxygen-driven nebulizers. There's good evidence for the use of salbutamol nebulizers, and the BTS and SIGN guidelines would recommend that children with SATs less than 92% should receive oxygen-driven salbutamol nebulizers frequently, every 20 to 30 minutes during that initial resuscitation period. The dose for an 8-year-old would be 2.5 to 5 milligrams, but in reality, we would be given the 5 milligram dose. There is also good evidence for the use of ipratropium bromide in children presenting with severe asthma in combination with salbutamol. Although the guidelines would recommend that salbutamol is administered first and ipratropium added if there's a poor response to the initial beta agonist, actually in practice we would often combine the two from the outset and administer 3 sets of back-to-back nebulizers containing salbutamol and ipratropium bromide. Dose for ibuprofen bromide for this 8-year-old patient would be 250 milligrams or micrograms. There's a little bit more controversy around the use of nebulized magnesium sulfate, and this is something which there has been some debate about over the years. We are keen to keep this interactive, and I'd encourage you at this point to go over to the YouTube chat and enter into the chat at this stage whether you would, in your own practice, give or choose to give magnesium sulfate at this stage. Type in yes if you would and no if you wouldn't. So as we'll discuss later, magnesium sulfate is traditionally used intravenously as a second-line agent in children with severe asthma who have not responded to first-line agents. The use of nebulized magnesium sulfate is a little bit more controversial. BTS and SIGN guidelines recommend that there's no real role for nebulized magnesium sulfate in children with mild to moderate symptoms. However, they do suggest the consideration to consider adding 150 milligrams of magnesium sulfate to each magnesium or to each salbutamol and ipratropium bromide nebulizer over the first 2 hours of an acute exacerbation, particularly in children with acute severe symptoms or those with a relatively short and sudden onset of symptoms. This is largely based on data coming from the Magnetic trial, which was published in 2013, in which a subgroup analysis suggested a possible role in that group of children who had short and rapid onset of symptoms. The level of evidence is grade C, and actually since the publication of the BTS and SIGN guidelines, there's since been a much larger trial published in JAMA, which took place across 7 centres in Canada, recruited over 8,000 patients. And when they looked at their primary outcome, which was hospitalisation rate, they did not notice any significant difference between the groups who received magnesium sulfate nebulizers in combination with the normal bronchodilators and those who just received salbutamol and ipratropium. So would it be wrong to administer at this stage? No, but is there enough evidence to say that we should routinely be using nebulized magnesium sulfate? Not at this current moment in time. The third intervention at this stage that we'd want to give is steroids. There is good evidence to suggest that early administration of steroids in acute severe exacerbations of asthma lead to improved outcomes. There are a number of choices of steroids, and these include oral prednisolone, oral dexamethasone, or IV hydrocortisone. Again, there might be some variation in your normal practice, and I'll be keen to see what you would choose in this situation. So head over to the YouTube chat and enter into the chat what you would choose to administer this patient at this time. So as we mentioned, there is good evidence to support the use of oral corticosteroid or steroids in acute severe asthma. And actually it's important to bear in mind that oral steroids have been shown to be as effective as IV steroids in the management of acute severe asthma. And so IV steroids should really be reserved for those cases where a patient is unable to tolerate the oral form. Most clinicians are probably familiar with the use of oral prednisolone as a first-line steroid choice. This is something which the BTS guidelines also support. They recommend dosing of 10 milligrams for less than 2-year-olds, 20 milligrams for those 2 to 5-year-olds, and 30 to 40 milligrams for those who are greater than 5, or 1 to 2 milligrams per kilogram up to a maximum of 40 milligrams. And often, except in those patients who maybe have a history of difficult to treat asthma, a 3-day course is sufficient. There has been a move, however, in a number of centres towards a single dose of oral dexamethasone as an alternative to oral pred. This is based on a number of studies which really were non-inferiority studies to show that administering a single dose of dexamethasone was non-inferior to using a 3-day course of prednisolone. Advocates of a single dose of dexamethasone would argue that it is better tolerated generally and more palatable, that it only involves 1 dose and you can watch that patient taking that dose in the ED department as opposed to relying on parents to administer 2 subsequent doses at home. And actually, when centres have calculated the cost, a number of centres have estimated that it would cost about 10 to 20% of the cost for them to supply a 3-day course of prednisolone. Those arguing against single dose of dexamethasone would suggest that there is clear dosing guidelines around prednisolone. People have a greater feel for how to manage patients with weaning courses of prednisolone, that dexamethasone is more difficult to store in primary care, and that these studies don't prove that dexamethasone is any better, they just simply show that it's non-inferior, so why should we change practice on that basis? The jury's out, and certainly at the minute I know centres are using both approaches, and I think it comes down to what you as a clinician are comfortable, what your normal practice is, but also what the experience of the centre or the institution in which you're working. In children who can't tolerate oral steroids, then IV hydrocortisone has been recommended, and the dose of IV hydrocortisone will be 4 milligrams per kilo, up to a maximum of 100 milligrams, which would be the case in this scenario, every 6 hours. So we've put our patient on high flow oxygen. We've given 3 back-to-back nebs. We chose to administer salbutamol and ipratropium, but didn't opt to administer magnesium sulfate nebulizers. And we've given them a 100 milligram dose of IV hydrocortisone. We did try oral pred, but they vomited, and we move on to reassess them. So overall, there's not been a significant change. They're still finding it hard to talk in full sentences, but their airway is patent. Their oxygen saturations have improved on the 15 litres of oxygen via the non-rebreather. They remain tachypneic with no significant change in their chest symptoms. They are slightly more tachycardic with a pulse of 160, probably a combination of the fact that they're unwell, but in addition to the salbutamol nebulizers which we've administered. And no significant change in regards to disability and exposure. This stage we do have venous blood gas. It is important to note that blood gases are not routinely recommended in children presenting with acute severe asthma, but should be considered in those with life-threatening features or those who are failing to respond to the initial first-line therapies. In practice, the opportune time to do so, to check the blood gas, is when inserting an IV cannula because you feel that you're progressing towards second-line intravenous therapies. In this case, we can see that there's a very, very mild metabolic acidosis, but the blood gas is otherwise satisfactory. We also request a chest X-ray at this stage. Again, like blood gases, this is not routinely recommended in children who respond well to first-line therapies. However, should be considered if there's a failure to respond to initial therapies, or if there's concerns about subcutaneous emphysema, persistent unilateral signs suggesting pneumothorax, or life-threatening asthma, which is refractory to treatment. Again, in this scenario, we see some hyperinflation, which is what we would expect in a child presenting with asthma, but no other significant chest X-ray findings. Given that the patient hasn't responded as adequately as we would like to the first-line therapies, we now need to think about administration of second-line therapies. And there are 3 main intravenous therapies we would consider at this stage: IV magnesium sulfate, IV salbutamol, bolus and continuous infusion, and IV McNaughten, again, normally a bolus followed by a continuous infusion. Again, a bit like steroids, there's probably some variation in practice between clinicians and centres. I'd be keen to hear what you do in your centre, so please head over again to the YouTube chat and enter into the chat your order of preference for using these 3 agents in relation to this case. As mentioned, there probably will be some variation in the responses we've received in the YouTube chat with regards to this, the preference of intravenous bronchodilators. This is not unexpected. We know that there is a variation between clinicians and centres. And part of the reason for the variation is that there is certainly, although there's some evidence supporting the use of IV magnesium sulfate, there's a lack of evidence advocating for the use of McNaughten over salbutamol or vice versa. In 2015, Paediatric published results of a survey of practice across 24 EDs in the UK. They looked at the use of IV bronchodilators in these centres, and there was a total of 110 cases of children who received IV therapy. This did show a wide variation in practice. IV magnesium sulfate was the most commonly administered IV bronchodilator, and with up to 61% of the children receiving IV magnesium sulfate as either in isolation or combined with other IV therapies. There is good evidence to suggest that IV magnesium sulfate acts faster than McNaughten and salbutamol in improving patient symptoms, and the BTS and SIGN guidelines do recommend it as first-line intravenous agent in children with acute severe asthma refractory to first-line treatments. The dose of IV magnesium sulfate is 40 milligrams per kilo, up to a maximum dose of 2 grams, and this is administered for 20 minutes. The Peruke study showed that salbutamol was the second most commonly used IV bronchodilator, with 56% of patients receiving salbutamol either as a bolus or infusion or both, or either in combination or in isolation. Although there's good evidence to support the use of nebulized salbutamol in patients presenting with acute severe asthma, there is less information about how IV salbutamol should be used to support nebulized treatment. There is some evidence to suggest that a bolus of IV salbutamol at 15 mics per kilo over 10 minutes can improve symptoms in a severe attack, and it should be noted, however, that the maximum dose is 250 micrograms, which is reached at a relatively low weight of 16 kilograms. A continuous IV infusion should be considered if there is concern about the administration of nebulized therapy or in asthma where there's life-threatening features with refractory to first-line treatments. Again, there's some clarity needed with regards to dosing. The starting dose is recommended as 1 microgram per kilo per minute. Guidelines do suggest that this can be increased to 5 micrograms per kilo per minute as required in a PICU setting. It is important, however, to be careful with the dosing of IV salbutamol. Although there's no clear guidelines on the upper limit of doses, apart from saying a potential to increase to 5 mics within the ICU setting, it should be noted that the adult maximum dose is 20 mics per minute. Beyond these doses, this dose and in higher dosing of IV salbutamol, there is concern that actually we may not be conferring an additional therapeutic effect. However, we are much more likely to experience the effects of salbutamol toxicity and side effects. McNaughten was the third most commonly used of the IV bronchodilators in this study, with 47% of patients receiving McNaughten. There was one randomized controlled trial which involving 100 patients, which did show that McNaughten reduced symptom severity in children with acute severe asthma. However, it is important to note that in that trial, the patients who received a loading dose which is generally double what we currently administer in the UK, and a number of patients had to be withdrawn from the study because of nausea and vomiting. BTS guidelines do recommend considering it in patients with acute severe asthma refractory to first-line therapies, but do advocate the use of magnesium sulfate in the first instance. McNaughten can be given as a bolus first of 5 milligrams per kilo, followed by a continuous infusion of 1 milligram per kilo per hour. It's important to mention for both salbutamol and McNaughten, there are significant side effect profiles, and patients being commenced on both should be on ECG monitoring and have regular electrolyte checks. Magnesium sulfate probably better tolerated. However, again, we would recommend that they should be on a cardiac monitor, and also with close observation of their blood pressure, as hypotension can be a common problem. So we decided to administer IV magnesium sulfate and reassess the patient afterwards. We've given a dose of 1.2 grams over 20 minutes. Unfortunately, there's been no significant improvement or change in the clinical picture from our previous reassessment, and so we decided to try a second-line intravenous therapy. At this stage, we opt for McNaughten with a loading dose of 150 milligrams over 20 minutes and a continuous infusion of 1 milligram per kilo per hour, which is 30 milligrams per hour. We then reassess the patient after a period on the McNaughten, and we find that actually, if anything, there's been a deterioration. The airway remains patent, but we're only getting one-word answers. Oxygen saturations are down to 89% despite 15 litres of oxygen via a non-rebreather mask. Patient's still tachypneic, but the respiratory effort is poor, much less air moving through the chest, and the wheeze is less audible. They're quite tachycardic with a pulse of 180, and their cap refill time is less than 2 seconds. Blood pressure is lower end of the normal range. Patient does remain orientated. Their blood sugar is 10, and pupils are equal and reactive. And my question for you at this stage is, would you intubate this patient now? Again, head over to the YouTube chat, put your answer in, and we'll move on to discuss that. So I hope that most of you have said, no, not yet. Certainly we're starting to become very worried about this patient. They've got features of acute severe asthma, starting to develop maybe features of life-threatening asthma, and they've been refractory to a number of first and second line treatments. However, the decision to intubate a patient with life-threatening asthma is not one that should be taken lightly. The process itself of intubation is not without risks, and will also almost certainly make the patient worse before they get better. As Chris will move on to talk about, this is a decision which needs careful consideration. Before doing so, it is important that we have maximised medical management. Certainly at this stage, even if we're not intubating, it would be important to discuss the patient with regional or your local paediatric intensive care unit. This gives them the opportunity to give some advice with regards to management, if there's perhaps something that hasn't been thought about or hasn't been done, but also then makes them aware of the patient and allows them to start the ball rolling in terms of mobilising retrieval team and getting organised in case this is something which is going to deteriorate further and proceed to intubation. In terms of medical management, at this stage we haven't tried IV salbutamol yet, and at this stage it would be appropriate then to administer a bolus. In this case, it's going to be a maximum of 250 micrograms IV bolus, followed by a continuing infusion of 1 mic per kilo per minute, but we would be capped then at the maximum of 20 mics per minute. The evidence for high flow and NIV use in asthma is very limited. There was a recent systematic review which included 2 randomised controlled trials looking at the use of NIV in addition to normal asthma treatment. This did show some improvement in asthma severity scores, however the numbers were very low, and there was felt to be a significant risk of bias. The BTS and SIGN guidelines suggest that although it would appear that it would be safe to use them in this situation, there's insufficient evidence to make any real recommendation about the use of NIV or high flow. However, in this situation where the patient is deteriorating, it would be reasonable to commence high flow therapy and to try to use it to potentially negate the need to proceed to intubation. For an 8-year-old, we would be considering starting at 35 to 40 litres per minute and titrating the oxygen as required. Finally, in this sort of scenario, it's always really important to have a think about whether or not we are actually have got the correct diagnosis, and are we treating the right thing. We have a patient who is getting worse despite our treatments, and this can happen with asthma, and we do see it happening. However, this is important whenever we're administering treatments to be thinking, is there potentially another reason as to why this patient is deteriorating that we haven't thought about? Are we missing a diagnosis? Could this be anaphylaxis, for example? Do we need to give adrenaline? Or are there further therapies we need to be thinking about, such as Heliox and ketamine, which Chris will talk about in his presentation when he picks up. So we've started the IV salbutamol, we've placed the patient on high flow, but shortly after we noticed that there's been a marked deterioration. They're drowsy with a reduced level of consciousness, and a very poor respiratory effort with silent chest. They've become hypotensive, and when we repeat the blood gas, we noted that there's a mixed respiratory metabolic acidosis with a pH of 7.02, CO2 of 11.3, bicarb of 17, base excess of -4, and a lactate of 4. The glucose is elevated, probably in combination of the stress, but also the steroids that we've administered, and the potassium is starting to drop at 3.1. And at this point, I'm going to hand over to Chris Flannigan to take us through the remainder of the case. Thank you.
Hello, I'm Chris Flannigan. I'm a consultant paediatric intensivist, and I'm going to be continuing on with this case from where Ben left off. So we reached a critical point where we need to decide if we should intubate this patient or not. And to help us make up our mind, I want to take a look at the indications for intubating an asthmatic. Now, this is life-threatening features which are refractory to maximum treatment. And you can see the life-threatening features over to the right-hand side of the screen according to the BTS guidelines. So importantly, it is life-threatening features are refractory to maximum treatment because we will get a lot of children presenting to the emergency department with life-threatening features. But give them some steroids and 3 back-to-back nebulizers and the majority of them will get better without needing intubation. It is also important to remember that we do occasionally get patients presenting in extremis, and it wouldn't be right to delay intubation to work through maximum treatment options before deciding to intubate them. When it comes to intubating asthmatics, I've got 2 main rules. The first is that you shouldn't do it unless you really have to, and the second is for the patient in extremis, you shouldn't delay intubation. Now, I know some of you are probably raising your eyebrows at that second rule, as who isn't going to intubate the patient in extremis? But once we look at the first rule and you understand the reasons behind that and the human factors involved, the reason for the second rule will become clear. So taking a look at the first rule, which is don't intubate the asthmatic unless you have to, the main reason behind this is actually there's a very real risk of the patient dying during your intubation attempt. And for asthmatics in hospital, the most likely time for them to arrest is immediately on intubation or the few minutes following intubation. And in fact, by the time they reach the intensive care unit, their risk of death is relatively low. So that in itself is a big reason not to do it unless you have to. There are other problems. The first thing is that you putting the endotracheal tube in the trachea does absolutely nothing to reverse the disease process because this is all happening below the level of the trachea. As well, by intubating the patient, you're introducing a whole host of new problems. Air trapping is a big issue and it's one of the common reasons these patients arrest, and we'll talk about this more as we go along. These patients are often frequently difficult to oxygenate and ventilate, and you're going to have to use much higher pressures to do that than what you're comfortable with, putting the patient at risk of pneumothoraces and air leaks. If I intubate an asthmatic, I know that I'm in for a really tough shift. I'm not going to be able to leave them. They're going to try and die multiple times on me, and I'm going to have to intervene. So in reality, you should not be doing this unless you really have to. And if you're intubating the patient who's on 40% oxygen on some high flow because their SATs are 92%, you don't know what you're doing and you haven't looked after an intubated and ventilated asthmatic. So now that you understand the reasons for the first rule, the reasons that the second rule exists should be clear. The fact that this patient is at risk of dying during an intubation attempt, people who have the insight to understand this will obviously try and avoid it if at all possible. And we need to recognise that we're going to have this instinct. And the patient who presents in extremis, there will initially be a natural reaction to try and avoid intubating them. But for that asthmatic who is very clearly over the hill and that slippery slope towards death, you need to intervene in a timely manner and not unnecessarily put the intubation process off. So taking a look at our patient very clearly has life-threatening features that are refractory to maximum treatment. We have worked our way through the algorithm and exhausted all treatment options. So it is clear that our patient is going to require intubation and ventilation. The next thing I want to do is take a look at the reasons why an asthmatic will arrest on induction of anaesthesia, so that we can come up with a treatment plan of how we're going to get our patient intubated safely. So by far the most common reason for the asthmatic to arrest in that peri-intubation period is air trapping. So if you haven't heard of air trapping before, don't worry, I'll explain exactly what it is. So I'm sure most of you have looked after asthmatics, and what you'll notice when you look after an asthmatic is they don't tend to have problems getting air into their lungs, but they struggle to get it out. And when you listen to an asthmatic, you'll notice they've got prolongation of their expiratory phase. It takes them a very long time to empty their lungs. And that isn't a big problem for them when they're breathing spontaneously, because they'll wait until they've finished expiring before taking the next breath. Where it becomes a problem is when we intervene and put them on a ventilator. And if we haven't set the ventilator up properly, what will happen before they have finished expiring, another breath will be given. And if that cycle repeats itself time and time again, with each breath, more and more air is retained in the lungs, resulting in the lungs becoming more and more distended with each breath. And that has a very similar effect to a tension pneumothorax. The increased intrathoracic pressure impairs the venous return coming back to the heart. The patient will become hypotensive, bradycardic, and unless you intervene appropriately, will arrest. And importantly, if you manage the cardiac arrest just like any other cardiac arrest, you will never get this patient back. So we are going to talk about the detection, prevention, and treatment of this later on in the talk. Another common reason these patients arrest is a pneumothorax, and you have to think, how are you going to pick this up in that peri-intubation period? And if you're saying wait for a chest x-ray, which is going to take 10 or 15 minutes, that is obviously going to be too slow. So for me, there is really only one way to pick these up in a reliable manner, and that is with ultrasound. Within a matter of seconds, you'll know whether your patient's deterioration is related to a pneumothorax or not. So if I'm going to intubate an asthmatic, one of the things I'm going to want in place before I start is the ultrasound been brought to the room. So should our patient deteriorate, we can either rule in or rule out a pneumothorax very quickly. The other thing, should you find a pneumothorax, you're going to want to treat it. And the first action is going to be to needle the chest with a large bore cannula. And again, be careful where you are in the hospital, because if you're in a paediatric area, quite often you might only find 24 and 22 gauge cannulas, which are going to be far too small for our 8-year-old. So again, a bit of preparation is going to be needed. If you're going to be intubating and ventilating the patient, you're going to want to make sure you've got large enough cannula to decompress any tension pneumothorax. The other important thing to remember, and I've seen this numerous times over my career, is just because you have needled a tension pneumothorax does not mean you have relieved the tension. When you actually put the chest drain in, quite often you will get a sudden hiss and release of tension and sudden improvement in the patient who actually has a cannula which has been held by somebody, making sure it's not kinked in place. And I've seen this a number of times where a cannula in a tension pneumothorax has not relieved the tension. So you are going to want to follow up that needle decompression with chest drain insertion in a relatively timely manner. And again, depending on where you are in your hospital, do you have appropriately sized paediatric chest drains available? So these are some of the things you may want to find out about in advance before you start, because when you've developed a pneumothorax is not the time to go looking for these things. The final thing is you might not actually be able to oxygenate and ventilate your patient any better with the endotracheal tube in place than what you could beforehand. And the big reason for this is, as we've mentioned, the disease process is happening below the endotracheal tube, and putting the tube in does nothing to alter that disease process. It just treats respiratory failure. Okay, so now we've had a look at the main reasons our patient is likely to deteriorate with intubation. I want to use this to help us come up with a plan for intubating our particular patient. I think the first thing we need to do is discuss with either the paediatric intensive care team or the transport team, depending on what the arrangements are in your local area. And the reasons for this are, first of all, although our patient obviously does need intubated, the asthmatic that you're referring may not actually need intubated. And by picking up the phone and speaking to us, we may well be able to suggest some steps that you can take and actually turn your patient around. And if you turn them around, the risk of death is significantly lower. The other thing is say your patient does need intubated and we agree with you, knowing that going into that risky scenario of intubating them is going to give you some backup that you have no choice into doing this. As well, we're going to be able to discuss and agree the plan with you so that you're going to be doing this in the safest possible manner. The next thing that I think is really important is a good team brief, because as we've mentioned, most people will not understand the very real risk of this child dying during the intubation attempt. So if you start allocating rules for cardiac arrest during intubation and asking for resuscitation drugs to be prepared, I find this really focuses everybody's attention in the room and just how serious this situation actually is. As we mentioned, air trapping is probably the most likely reason your patient is going to arrest in this particular period, and preventing it is much better than curing it. So the common reason it happens is because you haven't let the patient expire before giving the next breath. And from a human factors point of view, you have to recognise that your own adrenaline as the intubator is going to be sky high. This is a really sick patient, a really stressful scenario, and your own natural instinct is going to bag this patient faster and harder than what you need to. So when I'm intubating one of these patients, I will tell somebody else in the team, I want you to remind me after I put the tube down to bag the child slowly, watch their chest, making sure they're finished expiring before I give the next breath. And you can't rely on yourself to remember that. You need to raise that up to the team so that others can remind you to do that. The other important thing to remember about these patients is they are highly likely to desaturate on intubation. And again, your natural response to a desaturated intubated patient is to bag harder and faster to try and bring the sats up. And this will have the opposite effect in these patients. The other important thing to remember with air trapping, if it's likely to occur, you can help lessen the effect it has on the cardiovascular system by filling up the system. So for most patients I'm intubating, I will give them 10 to 20 mils per kilo as a fluid bolus to try and increase their preload. So should there be any increased intrathoracic pressure, and there almost certainly is going to be with the high pressures we're going to need to ventilate these patients with, it's going to have less of an effect on the cardiovascular system. The final important key point I think in preparing these patients for intubation is to consider inserting an arterial line prior to the induction of anaesthesia. This is quite an unusual thing to do because most of the time we will put the arterial line in after the patient is asleep. But this is one particular situation where I would strongly ask you to consider doing this prior to putting the child to sleep. And the reason for this is by far the best way to pick up air trapping, which in general is a cardiovascular phenomenon. If you think if air trapping was to occur without an arterial line, how would you actually pick it up? Well, the first thing is your patient would become hypotensive. Your blood pressure cuff would cycle, it wouldn't give you a reading, it would try again, it wouldn't give you a reading, and it would repeat that a number of times before anybody had actually noticed. The next thing that would happen, again, probably before anybody's noticed, is the patient would become bradycardic. Within a number of seconds after becoming bradycardic, the patient normally arrests. And like we've mentioned, if you don't recognise this as air trapping and intervene appropriately, you will never get this patient back. If you have the arterial line in, what you will tend to notice is the blood pressure just goes down, 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 and disappears off the bottom of the screen. The patient then becomes bradycardic, and that cycle continues on. So hopefully with the blood pressure disappearing and the monitor alarming, you will be able to intervene at that stage rather than waiting to the bradycardia. So you're more likely to prevent the patient arresting. This is a bit controversial and not everybody would recommend doing it, but for me this is one particular circumstance where I think you should do it. If it's done with some local anaesthetic cream applied, then you infiltrate a little bit of local anaesthetic, the patient will not feel this, and in general these patients have good radial arteries. If they don't, ultrasound guided femoral arterial line is very straightforward and easy to do. And in our 8-year-old, the femoral arteries are going to be absolutely massive and you'll have a harder job missing them than actually hitting them. Moving on to the technicalities of actually putting the tube in, and a question I'm often asked is, should I use a direct laryngoscope or a video laryngoscope? And my answer to this is always the same. You should use whatever tool you're most likely to succeed with on the first attempt. And this patient, is, as we've mentioned, is at very high risk of death during the intubation period. And should something go wrong, for example, should they vomit and aspirate, or should you not be able to get the tube in and have to resort to face mask ventilation again, this could be critical for this particular patient. So the person putting the tube in should be the person who's most likely to succeed, and they should be using whatever method they're most likely to succeed with. So they don't normally use a video laryngoscope, it's probably not the time to try out the new video laryngoscope. You want to get this tube in fast and first pass if possible. In terms of what tube you put in, you don't really have a choice here. you must put a cuff tube in these patients, regardless of what's done in your local area as a standard practice. We use all cuff tubes in Northern Ireland unless they're contraindicated. If you don't, this is one particular group where you should be putting a cuff tube in, because if we come out and find the patient with an uncuffed tube in, you're going to have one very unhappy paediatric intensivist, as they have to do a very difficult emergency tube change. In terms of the drugs you're going to use, we tend to use ketamine for intubating most critically ill children. The exception to that tends to be seizures, where we'll tend to use either propofol or thiopental, providing the patient's stable enough. But in general, ketamine is what we use. In asthmatics, ketamine does have some bronchodilatory properties, so there's absolutely no reason to go away from ketamine. You're going to want to do a modified rapid sequence induction in these patients. As we've mentioned, should they get laryngospasm, should they vomit and aspirate, it's going to be an absolute nightmare and the patient is very likely to arrest on you. So you are going to want to give them a muscle relaxant. There's only 2 muscle relaxants which are quick enough to do a modified rapid sequence, and they are Sux or rocuronium. I'm using rocuronium all day, every day. I don't use Sux as a paediatric intensivist due to its side effect profile. But again, you should use whichever of these 2 drugs you're comfortable with and are part of your normal practice. Okay, so going back to our patient, we go ahead and put a right radial ultrasound guided arterial line in under local anaesthetic without any difficulty. We go ahead and give our patient 20 mL per kilo as a fluid bolus prior to induction of anaesthesia. We pre-oxygenate our patient. Following a bolus of ketamine rocuronium, 1 mg per kilogram of each, we carry out a modified rapid sequence induction. We have no trouble getting a grade 1 view with a video laryngoscope and no trouble passing the endotracheal tube. However, shortly after the tube has been passed, our patient becomes hypotensive and bradycardic. So on your screen now, you can see a list of potential treatment options for this particular patient. So what I want you to do is pick one of these options, only one of them is correct, and I want you to go over to the YouTube chat and type in what you think is the correct answer. What I'll do, I'll read through the answers for those of you listening to the audio-only version of this talk. So option 1 is remove the tube and return to face mask ventilation. We can start CPR. You can give a fluid bolus. You can give an adrenaline bolus. You can give some atropine. You can disconnect the endotracheal tube and manually decompress the chest, or you can do needle decompression of the chest. So as we've said, air trapping is by far the most common reason for these patients to arrest during intubation, and our patient is very definitely peri-arrest, and unless we intervene appropriately, is likely to go into full cardiac arrest. So if you have a tension pneumothorax, what you do is you relieve the tension. You put a needle or cannula into the area of tension, remove the pressure, and hopefully things will improve fairly quickly. Our area of tension is actually in the lungs themselves with air trapping. We don't need to put any needles into the lungs. We've already got a large endotracheal tube going down to the lungs. So all we need to do is disconnect our patient from the bagging circuit, our ventilator, and if air trapping is the cause, what you will hear is a hiss coming from the endotracheal tube as the tension relieves itself, similar to the hiss you will hear when you needle a tension pneumothorax. That's option 1. Option 2 is you can disconnect and actually manually compress the chest for about a second, forcing the air out the endotracheal tube. This is a little bit controversial because for that initial second that you are pressing down on the chest, you're actually increasing the interthoracic pressure. So there isn't a clear answer. Obviously, nobody's done a randomized controlled trial on this for obvious reasons as to which you should do. You can either disconnect and leave the patient alone, which is going to take a little bit longer to relieve the area of air trapping, or you can disconnect and press on the chest. I've always been a presser on the chest. I've never had any adverse outcomes from doing it, and I'm a believer that these patients are going to arrest in the next few seconds, and I don't have time to wait. But you'll have to make your own mind up over which of the 2 methods you use. The important thing, as we've mentioned before, is if you manage this like any other cardiac arrest with the other treatment options on the screen, you will never get this patient back. If you start CPR, continue bagging them, don't relieve the area of air trapping and tension in the lungs, which is impairing the venous return, nothing else you do will actually bring this patient back. So the first action you need to remember in an intubated asthmatic is always to disconnect them from the endotracheal, disconnect the endotracheal tube from the ventilator or circuit, plus or minus manual decompression of the chest. Okay, so going back to our patient, we disconnect them from the bagging circuit, manually decompress the chest, and the blood pressure just appears back on the screen and the bradycardia disappears. So we want to go ahead and reassess our patient. So from an airway point of view, we've got a 5.5 cuffed endotracheal tube at 16 centimetres at the lips, and we've already been down the endotracheal tube and suctioned out some secretions. In terms of breathing, we're still handbagging our patient in 100% oxygen. They do actually have a silent chest. When we listen into the chest, we can't hear any air entry or any additional sounds. SATs aren't good. They're only 79% on the 100% oxygen. And our bronchodilators are unchanged. We're on 20 mics per minute of salbutamol and 1 milligram per kilogram per hour of aminophylum. Going on to look at the cardiovascular system, our numbers aren't too bad. We're a little bit tachycardic, as you would expect, being on the bronchodilators that we're on. Blood pressure is good with a MAP of 75, cap refills 2 seconds, and we've had in total 30 mils per kilo of fluid as boluses, 20 mils per kilo prior to induction of anaesthesia, and a further 10 mils per kilo given during the episode of our trapping. From a disability point of view, our patient is sedated muscle relaxed, or coma scales 3, pupils are equal and reactive, nice and brisk to light, and our BM's up at 11.7, which again isn't a surprise given the stress and the steroids that the patient has already had. Taking a look at our blood gas, and it's not good. We've got a fairly severe acidosis with a pH of 6.82. It's mostly respiratory with a CO2 of 18.9 kilopascals, although there is a metabolic component with a base excess of minus 9.2, which is mostly made up with the lactic acidosis with lactate at 6.4 millimoles per litre. So we've got a patient who isn't oxygenating and ventilating well, so we're going to need to carry out a dopes assessment to try and get to the bottom of the cause. You can see what DOPE stands for on the screen. I'm not going to go through it all again because I did do a full talk on DOPEs 2 years ago at the Waiting for the Retrieval Team Day, and you'll find a link to that lecture on the Paediatric Emergencies website. So in terms of DOPEs, the two main things that we need to look for are air trapping, as we already mentioned, in an asthmatic. It does tend, however, to be a cardiovascular phenomenon. It's more likely to cause cardiovascular issues than issues with oxygenation and ventilation. Pneumothoraces tend to cause problems with both, and as we've mentioned, the best way to pick this up is with ultrasound. So we go ahead and get our portable ultrasound and bring it to the bed space and scan the right lung. And when we look at the right lung, we can see pleural sliding, ruling out a pneumothorax. Go ahead and scan the left lung and we see the same. We've got pleural sliding, so we ruled out a pneumothorax fairly quickly. 10 minutes later, we get our chest x-ray, and as we were expecting based on our ultrasound, there's no evidence of a pneumothorax. We can see our endotracheal tube is in a good position. So what do you want to do now? How are we going to get this patient turned round? We've got a patient who isn't oxygenating well, isn't ventilating well. We've been through our DOPEs assessment and ruled out the common causes. So on the screen, you can see a list of potential treatment options that we can do at this particular stage. And again, what I want you to do is go over to the YouTube chat and pick which one of the following you would use now. And again, for those of you listening to the audio-only version, I'll read through the options. So option 1 is an adrenaline infusion. Option 2, magnesium infusion. Option 3, ketamine infusion. Option 4, you can increase the salbutamol infusion. 5 is Heliox. 6, volatile anesthetic agent. 7, physio. 8, DNAs. 9, bronchoscopy. And 10, ECMO referral. So I'm going to make a start at going through these. If you've still got to get your answer in, keep it coming. But looking at the first 3 treatment options, these are all things I would consider doing at this stage when I've got a patient with refractory asthma. The only downside is that I don't think any of these 3 first treatments are likely to turn our patient round in the next 5 to 10 minutes, which is what our patient actually needs. So an adrenaline infusion is definitely a good option to consider at this stage. The beta effects are going to help with bronchodilation. And the other important thing to remember is that actually some of these patients who've been labelled as asthmatics actually will have anaphylaxis. And if you don't give them adrenaline, you're not actually treating them. So as well as helping in refractory asthma, low-dose adrenaline infusions will actually treat the undiagnosed patient with anaphylaxis. So it would definitely be something I would want to add in at this stage, but I wouldn't think it's going to turn my patient round in the next 5 or 10 minutes like I need it to. Similarly, a magnesium infusion is something that's worth considering at this stage. The magnesium is going to relax the smooth muscle in the airways, and what we can either do is give another bolus of magnesium or start the patient on a continuous infusion, something like 30 milligrams per kilogram per hour, targeting magnesium levels somewhere between 1.5 and 2.5. And at those higher levels, as well as relaxing the smooth muscle in the airways like we'd hope, it is likely to relax the smooth muscle in the vasculature. So you will tend to have to support the patient's blood pressure if you are going to go with a magnesium infusion. Ketamine infusion is another good treatment option. As we've mentioned, ketamine has bronchodilatory properties. You are going to have to give this patient something to keep them asleep. So it does make sense you use something that's going to actually help with the airways as well. And I would often pair ketamine with something like fentanyl for these patients. I tend not to use morphine, which we would tend to use first line because of the risk of histamine release. And that would be a similar reason if we're going to use a muscle relaxant, I wouldn't use antracurium. If the patient's sick like this, ketamine and fentanyl would be my preferred choice. If this is just a patient with wheeze, like a viral-induced wheeze, who actually were not struggling to oxygenate and ventilate, I would tend to go with fentanyl and midazolam rather than ketamine. Because I find when you add ketamine to the other bronchodilators, you end up with a patient that's very tachycardic and hypertensive. And I find a combination of fentanyl and midazolam is better to treat that. This particular patient, we're trying to get every single thing that we can to improve the bronchodilation, so I would use ketamine for this particular patient. We've got the option to increase our salbutamol infusion, and as Ben has mentioned earlier on, we don't find a great benefit with using the higher doses of salbutamol infusion. It's very rare that I'll go more than 1 mic per kilo per minute, sometimes up to 2 mics per kilo per minute. And I know the BNF does say you can go up to 5 mics per kilo per minute, but again, I would almost never use those doses. Quite often, our preconceived ideas will be wrong in the individual patient. So for most patients who I'm really struggling with, I will try and put the salbutamol up a little bit, see if it makes any difference. If it doesn't, I'll put it back down again. So it's not that I'm saying I'm definitely never going to put it up. I think you have to sometimes go against what you think is likely to work, and every now and again you're surprised and quite happy to be wrong when your patient turns around. Heliox, if you're doing an exam, this is a good answer to give. Outside the exam scenario, I have never found this to be of any use. Heliox is a low density gas which turns turbulent flow into laminar flow, so it's hopefully going to improve our moving in and out of the asthmatic's lungs. There's 2 main problems with it. The first is, do you know where you're going to get this in your hospital in a timely manner? I certainly don't. The second reason is that once you start adding oxygen to Heliox, it loses its beneficial effect. And for our patient at 100% oxygen, it's not going to be helpful, even if you had it immediately available. Volatile anesthetic agents, I think, are where you're actually going to get the most chance of turning this patient around in a timely manner. And again, they work on relaxing the smooth muscles in the airway. And I have used it in numerous situations like this and turned the asthmatic round in 5 to 10 minutes and broken the spasm. And by 20 minutes, you can either take the patient off it if you're using a portable anesthetic machine in the ICU. If you're in the operating theatre, you can obviously continue on to run it. Or there are certain devices you can bring into the ICU to allow you to deliver it through the ICU ventilator. But a lot of the times I've given it just for maybe 20 minutes and been able to take it away. And you've had a patient who's had a silent chest who's had a significant improvement to it. The important thing to remember is that obviously we can't transfer the patient on the volatile anesthetic agent, but again, that's not a big thing at the moment. That's not your goal. Your goal is to try and oxygenate and ventilate the patient, and we can worry about how we're going to transfer them later on. Like with the magnesium infusion, it's going to, as well as relaxing the smooth muscle in the airway, it's going to relax the smooth muscle in the vasculature, probably even to a bigger degree. So the chances are you are going to have to support the blood pressure with some drugs if you're going with volatile anesthetic agents. Up until this point, really all the treatment options that we have given have been directed towards bronchospasm. But we have to remember there's 3 pathological processes going on in asthma. The first is bronchospasm. There's also airway inflammation, for which we've given steroids, but there's increased mucus production. And particularly in a lot of patients who are labelled as viral-induced wheeze, once you intubate them and actually clear their chest out, the wheeze disappears. And that's because the airways, yes, they've been narrowed, and that's why the patient is wheezing, but they've been narrowed with secretions that you couldn't get before. Looking at our patient, I think this is less likely to be true, given we have a lovely clear x-ray. But like I say, in other situations, this is the common cause of wheeze, and you're going to get a lot more value going after them. Ways that you can go after it are chest physio. Obviously, this has pros and cons to doing in asthma. By actually doing chest physio, the risk of air trapping is incredibly high, and the risk of causing a pneumothorax is also increased. So there's risks and benefits to what you're going to have to weigh up. Your physio might be very reluctant to actually want to treat the asthmatic, and if you do get them to agree, you can't send them off to treat the asthmatic by themselves because they're likely to deteriorate during it. You're going to have to go with them and watch them very closely during the process. But I have had numerous asthmatics over the years who we've worked on the bronchodilators, and actually where we've turned pressures of 40 on the ventilator to 25 is with a single physio session. So it is certainly something worth considering at this stage. Other options to help with secretions are things like DNAs, again, a word of caution, that can increase bronchospasm, and bronchoscopy, again, is another option to consider. Obviously, if you have a patient you can't oxygenate or ventilate, you should be thinking about making an ECMO referral in a timely manner. So going back to reassess our patient, our airway is unchanged. We're still handbagging 100% oxygen, but we've added some sevoflurane into the circuit. That does seem to have had some benefit because from a silent chest, we've now got poorer entry throughout the chest and we can actually appreciate some wheeze. The SATs have improved to 93% and our bronchodilators are unchanged. From a circulatory point of view, things are a little bit worse. We're a bit more tachycardic at 152 beats per minute and our blood pressure has dropped to 77/37 with a MAP of 50. Cap refill is still 2 seconds, but we've given an extra 10 mL per kilo of fluid bolus, so 40 mL per kilo in total at this stage. From a D point of view, things are really unchanged on clinical assessment, but we have added in some fentanyl at 4 mics per kilo per hour and some ketamine at 1 milligram per kilogram per hour. Taking a look at our blood gas, and it again is also going in the right direction with the volatile anesthetic agent being added in. Our pH is up to 7.023, the CO2 down to 13.7 kilopascals, and our base X is also improving down to minus 7.2 with decrease in our lactate to 4.4. Other important thing to note on the gas is potassium is slightly low at 3.2. We are currently running 20 millimoles and 500 mils in the bag, but we might need to think about a central line and concentrated potassium infusion should that continue to decrease. So we now need to look at how we're going to treat the hypotension, and I put a few options on the screen. First of all, there's the option to reduce our sedation, which doesn't seem like a great option to me. The only reason our patient is turned round is probably because of the sevoflurane, although the ketamine infusion may well have helped as well. Fentanyl is obviously unlikely to have helped, so there is potential to drop the fentanyl slightly, but I would be very reluctant to drop the drugs that have potentially turned this patient round and would rather actually go after the blood pressure and leave these drugs around. As well as I've mentioned, the sevoflurane is going to have to come off when we go ahead and transfer the patient, so I do think it is certainly reasonable to have the patient loaded up on other infusions, so when we turn the sevo off, they're not going to wake up. Further fluid bolus is another option that we have, and again, I don't think it is a good one as well. Our patients already had 40 mils per kilo, which is half their circulating volume. We know the most recent they're likely hypotensive is from vasodilatation from the sevoflurane. So again, filling that increased space with more fluid doesn't make sense when you could actually squeeze the space. So that gives us a choice between adrenaline and noradrenaline. As we've already mentioned, adrenaline has other advantages in asthma. The beta effects are potentially going to help open the airways up as well as treating the blood pressure. So it would be my first line drug to use. The downside to using it is you've already got a lot of other drugs going which have beta effects and are going to increase your heart rate, and our patients are already pretty tachycardic. So I wouldn't use the adrenaline at more than 0.1 mics per kilo per minute, which is going to be given a good bronchodilator effect. And if we need something more than that for blood pressure control, I would add in some noradrenaline and use that to just control the blood pressure to where I wanted it to. So we're getting the advantages of bronchodilation from the adrenaline, but then using the NORAD to control the blood pressure on top of that if we need to. So I think at this stage we could probably try our patient on the ventilator. The oxygen ventilation has improved significantly, so I thought it was worth going through the settings that we would tend to use in asthmatics. In terms of mode, historically we would use pressure control, and the reason for that is the pressure control mode of ventilation has a decelerating flow pattern, which allows you to give the same tidal volume at a lower peak pressure than a mode of ventilation which is a continuous flow pattern, something like volume control. What I tend to use is PRVC because again it has a decelerating flow pattern like pressure control, but offers all the advantages of a volume control mode of ventilation. So that would be my preferred method. In terms of ITE ratio, for most of our intensive care patients we'll use an ITE ratio of 1 to 2. But as we've mentioned, asthmatics struggle to get air out of their lungs, so you're probably going to want to start somewhere 1 to 3 to 1 to 5. And what you want to do is look at the graph on the ventilator of flow against time. On the graph you've now got on your screen at the moment, this is the middle graph. Above the baseline you have inspiratory flow, below the baseline you have expiratory flow, and it's the expiratory flow that you're going to want to watch. That waveform, you're looking for it to reach the baseline before the next breath is given. If the next breath is given before the expiratory flow has reached the baseline, your patient is at risk of air trapping, and you should prolong that expiratory phase by lengthening your ITE ratio to prevent the air trapping. Going on to look at the other settings, from a rate point of view, obviously you want to keep a relatively normal I time, but a long ITE ratio, so that is going to limit your respiratory rate. And for our 8-year-old, I'm probably starting somewhere around about 15 breaths per minute. In terms of peak expiratory pressure, again, we're probably going to try and limit that to 35 centimetres of water if possible, although it's not always possible, and sometimes in asthmatics you have to use much higher pressures than what you're comfortable with just to move their chest and achieve satisfactory gases. In terms of PEEP, this is a controversial area. Some people would argue that because asthmatics struggle to get air out of their lungs and have their own auto PEEP, you can actually set the PEEP at 0. Others would argue you should actually match their own auto PEEP on the ventilator. What I tend to do is set a low normal PEEP, somewhere around about 5. If the patient's fine on that, that's good. If not, I'll try it up and down and try and find out what the individual patient in front of me actually likes. In terms of FiO2, in general, from a lung protection point of view, we do try to keep our oxygen at less than 60% if possible. And we will relax our oxygen saturation targets to either 88 or 85, depending on the individual circumstances. Obviously, this isn't going to be possible in our particular patient at the moment. We're only just about saturating, still on 100% oxygen. But it is something to think about as things continue to improve in our patient. In terms of CO2 targets, again, with these low rates, you will not have a normal CO2 pattern. If you were to put a healthy 8-year-old on the same setting, you would expect their CO2 to rise. In asthmatics, you are just about trying to get by with the ventilator. You're not trying to ventilate them to a normal gas. If you do that, you will cause air trapping. You will use higher pressures than what you need to, putting the patient at risk of air leaks. So you're just about trying to get by. Depending on the guidelines you look at, some will allow CO2 levels all the way up to 14 kilopascals. Obviously, that's going to result in a very low pH. We do try to keep the pHs above somewhere around about 7.2, some would say 7.15. And to do that, you often will have to buffer the patients with some bicarb to allow the CO2s of 14 to give you acceptable pHs. So as you can see, it's not a good place to be. And if you think back to, for example, an asthmatic you've looked after before in the paediatric ward, on high flow, 40% oxygen, SATs at 92%, and somebody's thought about should we intubate them. Remember, this is where you're taking them to. So actually that asthmatic, as long as they're not tarrying and their gas is okay, you should continue to sit on them. And that's why we recommend you pick up the phone and phone us before you decide to intubate them. Okay, so going back to reassess our patient, our airway is really unchanged. From a breathing point of view, we're on PRVC at 180 mils, which is about 6 mils per kilo, but only 79 mils of that is being delivered to the patient because the ventilator is ringing off at the high pressure alarm. So we're getting 35/5 in terms of pressures, rate of 15, IT of 1 to 3, and we've checked that middle graph on the ventilator and there's no signs of air trapping. We're still in 100% oxygen with sevoflurane in the circuit. Our air entry is still poor throughout with wheeze throughout the chest. Saturations have deteriorated since going back onto the ventilator. They're down to 83% in 100% oxygen. We have doubled up the salbutamol to 40 mics a minute. Aminophylline's unchanged, and we've also given the patient a bolus of Sodabek, repeated the magnesium load, and we've had a good check through the circuit, making sure there's no dead space, and we're happy that the particular ventilator we're using is appropriate for an 8-year-old. In terms of the cardiovascular system, things are better with the adrenaline running at 0.1 mics per kilo per minute. We've got a satisfactory heart rate of 142 and a MAP of 65. In terms of disability, things are mostly unchanged. The only thing that really has been done is the fentanyl has been halved. Taking a look at the blood gas after 20 minutes on the ventilator, and unfortunately it has significantly deteriorated. Our pH is down to 6.72. CO2 is up again to 19.4 kilopascals, and the base excess has also deteriorated down to minus 10.6, with the lactate having risen to 6.4. Potassium continues to fall down to 3.1, so we are going to need to think about starting to concentrate a potassium infusion. So what now? What I want you to do is go over to the YouTube chat and type in what you think we should do to turn this patient around. So just while you're typing your answer in, I want to just recap on our ventilator settings. So you haven't got your answer in, keep it coming and we'll take a look at it. So in terms of ventilation, we're on PRVC at 180 mils, about 6 per kilo, but only 79 mils is being delivered. We're on pressures of 35/5, a rate of 15, ITU of 1 to 3 in 100% oxygen. And I know probably what some of you are thinking, we've got no evidence of air trapping, so can we not drop our IT ratio to 1 to 2? That's going to let us lengthen our respiratory rate and hopefully improve our ventilation. Now that is really just touching around the edges as far as I'm concerned, and that's maybe going to improve our pH from 6.7 to 6.9, but it is not going to solve the underlying problem. And looking at those settings, which you can see on your screen, there is one glaring abnormality, and that is the fact that our ventilator is only delivering 79 mils, which is about 2.5 mils per kilo. So if you could imagine taking a healthy 8-year-old, putting them on 2.5 mils per kilo tidal volume at 15 breaths per minute, you're going to have a terrible blood gas. And that is the reason why our patient is not oxygenating or ventilating effectively. And that is just the pressure alarms are set too low. The reason we can probably oxygenate and ventilate the patient on the bagging circuit is we're probably using much more significant pressures and making sure the patient gets the correct tidal volume in on the bagging circuit. And if you were to put a manometer on that bagging circuit, you'd probably be surprised at what the pressures you were using actually were. We always seem very happy to use high pressures on a bagging circuit, but not on a ventilator. And I have seen this a number of times in real life where people will just not put the pressures up and the patient is not oxygenating or ventilating. So I don't advocate using high pressures if you can avoid it, but in this circumstance, we cannot leave the patient as they are. So what we do, we go ahead and increase the pressure limits to 50. On that, we actually are getting in about 5.5 mils per kilo of tidal volume. And over the next 10 minutes, our oxygenation improves significantly. We're able to wean the oxygen down to 80%, maintaining saturations of 88%. When we repeat our blood gas, things are going the right way. Our pH is significantly improving and our CO2 is down to 12 kilopascals. At that stage, the paediatric retrieval team come through the door and are delighted to see the patient is improving, just as delighted as you are to see them coming to take over the patient. So I want to finish off by just covering what I think the key learning points are from this talk, and the first speaks for itself. Don't intubate an asthmatic unless you really must, and if you didn't understand this at the start of the talk, hopefully this case makes the reasons behind that very clear. If time allows, before you intubate the patient, please discuss it with PICU or the transport team, whatever the local arrangements are in your area, because like I said, we may well be able to actually avoid intubation by altering the patient's treatment. I would strongly consider inserting an arterial line prior to intubation. Air trapping is what tends to kill these patients, and this is your best way to pick it up and treat it in a timely manner. For the patient who is peri-arrest or is actually arrested, remember air trapping, and that should be the first thing that you treat. If that doesn't resolve the problem, think about a tension pneumothorax. And then when you're into refractory asthma, don't just think about bronchospasm, think about increased mucus production and the treatment options that we've discussed on that. Okay, thank you for listening to me, and I'll now take any questions.
Hi everyone, welcome back. Hope you enjoyed those talks on management of asthma. We have had a few questions coming through, and we're going to go into them because I think there might be a bit of discussion around them. So without further ado, Andrew Hyde was asking, is there an argument for tubing these patients in theatre? Assume, I suppose, they have the presence of volatile agents to hand. Chris, with a bit of discussion around choosing locations for intubation, so maybe you'd like to comment on that.
100%. This is the patient who should be tubed in theatre unless there's a good reason not to. For example, the patient in extremis and the movement to theatre is not in their best interest. It's to have access to the volatile anaesthetic agents are the key. What absolutely drives me mad is taking all patients to theatre. Although we were chatting that the ED is a risky area to intubate a patient if you don't need to. One particular group that drives me mad is the febrile seizures or status epilepticus to any degree, because you're letting the kid fit for longer while you move them to a different environment, and the risk of doing that outweighs any benefit for me. But in asthma, you most definitely should take them to theatre where you're going to have a more controlled environment with volatile anaesthetic agents, a ventilator that the team there are familiar with. You should definitely do it.
Yeah. And there was another, with a bit of a discussion just when we were talking about the sort of a decision to insert an heart line prior to induction. I think on the panel, I suppose we have a show of hands for those who would opt to do that. Okay, and those who wouldn't. And then some here undecided, yeah. So we had a bit of discussion about that in the talk. Chris, you'd advised that you would go ahead and do that. Yes. You want to tell us your rationale behind that, but also other considerations as to when that might not be appropriate?
Yeah, so in the talk, I did flag this up as something you're doing out of the ordinary, because normally you don't want to put a child through a painful procedure that you can do when they're asleep. But air trapping happens so quickly. Within 10 seconds, you can have a normal blood pressure to no blood pressure and bradycardic and arresting, and you will not pick it up with a finger on the pulse or a blood pressure cuff that is cycling. And this is the most common reason these patients arrest. So I think if you have this, and this is what Costas brought this in, if you have the skills to do it, and it's not going to distract you from a human factors point of view, you should most definitely do it. And Costas, you would do the same thing.
I would do exactly the same thing,
yeah. But although recommending it to a team in the DGH is something slightly different, I do recommend it. And what I would advise the team is don't be messing about with it. You know, these patients normally have great pulses. If they don't, ultrasound guided femoral under some local is really easy and quick to do. And I think the benefits of you spend a little bit of time to do that are definitely rewarded for keeping the patient safe during induction. But again, it's not a standard. It would be my recommendations rather than something you must do.
Yeah. What I would say is don't become task fixated with it, you know, because you may well stay there 20 minutes while the patient is hypoxic trying to do an outline. So if you don't have the skill set to do it quickly, or if you think you do and it's still taking a lot of time, make someone to be checking on you. You know, don't take too long to do it, and make sure you're resuscitating this child enough in advance and have your inotropes ready or pre-running if you're worried that this child will arrest. And adrenaline is a good way to do it. You can have it running through an IO or peripherally, or you can have some dilute adrenaline to push if things start going in the wrong direction during the intubation process. So prepare this child adequately to sustain the induction process.
Thanks, Chris and Costas. And another discussion we were having amongst ourselves during the talk was regards to the use of nebulized salbutamol on top of, if you in the patient where you've decided to start IV salbutamol, BTS guidelines would recommend you continue to give the nebulizers. However, there is concerns about saturation and toxicity. I know, Costas, you were saying that you wouldn't, but one of the reasons maybe you would then choose aminophylline over salbutamol because it would allow you to give the nebs and with regards to side effect profile. Would you be happy to just expand on that a little bit?
Yeah, so if the listeners are waiting for a big quality study showing that aminophylline is superior to salbutamol, then they're not going to find that. What edges aminophylline for me as a first line choice is there's a much smaller side effect profile for it, and it's less likely. And salbutamol, I've seen it, especially in children, become very toxic very quickly. There's also some soft evidence to show that if you're giving IV salbutamol and nebulized salbutamol together, once you saturate those beta receptors, there's no added benefit of giving more and more apart from causing more side effects. So lactemia, hyperglycemia, anxiety, tachycardia, all those things which make you feel absolutely awful. So if you use aminophylline first line, you have the extra pharmacological benefit of giving salbutamol nebs as often as you can without causing that, with less chance of causing that significant toxicity that you would see. But you're not going to find big studies to say aminophylline is better than salbutamol, but you will use your common sense and say aminophylline has less side effects, therefore I'm doing less harm, therefore I'm starting with that one.
I think I would agree with that. It's you're using a different drug is the other thing, isn't it? It's like switching oral pred to IV hydrocortisone. How much benefit are you going to get by doing that? But here you're actually adding a completely different drug into the salbutamol that you're already on. So it kind of makes more sense to me. It's like adding vasopressin instead of another drug that works in alpha and beta receptors. When you've got a hypotensive patient, it works a different mechanism. You're more likely to get more bang for your buck with going with that.
Okay. Thanks, guys. And there was another someone else had mentioned at one stage on the chat about always keeping an open mind, and I think we touched on this at the end of my talk and also in Chris's. And I suppose that situation when you've got a patient with severe life-threatening asthma who is refractory to treatment, and always having sort of an open mind and thinking about whether or not you've actually got the correct diagnosis. Peter, you had sort of a few comments on that previously. Would you like to sort of take on from that and give us your thoughts on that?
Yeah, I'm happy to, Ben, just reinforce the points that yourself and Chris mentioned. Just being mindful of the audience that we're talking to here, generalists, people who have some experience with children, primary care physicians, EM, adult-based generalists, pediatricians. I mean, a child or young person with severe respiratory distress is an anxiety-inducing situation for lots of people, even the intensivists at times. And so I think it's important that it's just as a strong reminder of the importance of really careful clinical acumen in your history and in examinations, constant re-examination, constant correlation with your clinical findings, and just scrutinizing your findings, because treatment refractory wheeze could well be life-threatening asthma, but the important differentials include anaphylaxis, foreign body inhalation, cardiac conditions, and it's just to reinforce the importance of constant reassessments and scrutinizing your clinical examination and findings. So I think it's worth rediscussion and highlighting, just as we previously discussed.
All right, thanks, Peter. We do have a bit of time left. I think that's most of the questions. Chris, maybe I know you did talk in your talk. You mentioned sort of manual decompression risks versus benefits. Just wondered if you'd like to sort of re-emphasize those, because I know there is a bit of variation in practice with regards to manual decompression.
So I think comparing disconnecting versus disconnection plus manual decompression is very small. The biggest thing to remember is when your patient goes off, you must either disconnect the endotracheal tube or disconnect and do manual decompression as the first thing in an intubated asthmatic. That is the key learning message from this. It doesn't matter which of the two you do, as far as I'm concerned, as long as you do one. If that doesn't work, the patient's got a tension pneumothorax until proven otherwise. Which you do, there's no evidence to back it up, because obviously nobody has done a randomized controlled trial on that. Physiologically, again, the argument for decompressing the chest doesn't make a lot of sense because you're actually making the situation worse, as I did mention in the talk. I've always done this because the patients are about to arrest and I've never had a bad outcome from doing it. And it is really satisfying to see within 10 seconds the blood pressure and the heart rate been completely back to normal. The other option is just to wait. It will take longer for the situation to resolve itself, but you won't have that sudden increase in intrathoracic pressure for that half a second that you press on the chest. So I don't think it matters which of the two that you do, to be perfectly honest, as long as you do one of them. Peter, we'll better let you say something about it.
Yeah, so I mean, I get the arguments for it, and you know, I do it, but by a different name, to be fair. So yes, I will do a version of manual decompression, but I'm doing it for different reasons. So I'm doing it to do chest physio, which I would do on a patient myself. So it will achieve the same thing, but it's, you know, just to be pedantic about it, I'm not doing it as a manual decompression. I'm doing it to treat part of the pathophysiology of the condition. And I would suggest that you make sure that the patient is intravascularly as full as you can before you do it. So my personal take on it is to give a fluid bolus immediately preceding doing it, if you have the time to do so, just to make sure your IVC is as full as you can make it before you squeeze it.
The only time I'm pressing on the chest is in an absolute peri-arrest situation or arrest scenario. So I'm not advocating that a patient whose pressures are getting high on the ventilator, in that scenario, I'm just disconnecting them for a period of time, letting them decompress. I'm not pressing on their chest. It's the patient who has no blood pressure and has now bradyed. That's the patient whose chest I'm pressing on. If you're not in that scenario, you should not be doing it, as far as I'm concerned.
And then the counter argument to that is that if you've been doing chest physio and addressing the patient's pathophysiology, then you've already been doing a version of that before they get us to an extreme position of bradying and all the rest of it. So perhaps you've already done that.
Yeah, and that's why chest physio is one of those things that I am a big advocate for doing it, because like everybody thinks about the bronchospasm and ignores the other pathophysiology. But you must not send the physio to go and do physio on this patient, because you can have disastrous consequences. You have to go with them and be present during it, because the patient may very well go off during it.
In the interest of time, I think we could discuss that for a long time, Peter and Chris, but I think we probably do need to move on. Just a quick comment. Firefly 2020 has just commented they just missed a bit. Can anyone summarize any interesting information on asthma? It might be difficult to do that in the next minute or two, but the talks will be online again, available after. So do go back and rewatch the talks. Chris, I'm going to hand over to you now to introduce the next speaker.
Yep, that's great. So next we're going to have a case of drowning. Stephen Mullen is going to be starting off on that. And then Stephen McVea, who couldn't make it to the panel today, he's going to be talking about post-resuscitation care.
Thanks, Chris, for that introduction. So my name is Stephen Mullen, and I work as a consultant in the Paediatric Emergency Department in Belfast. And this presentation will cover some of the fundamental principles of drowning in children and young people. It includes epidemiology, pathophysiology, and our approach to initial resuscitation and how this may change if the patient is hypothermic. We will also look at some of the recent updated recommendations from the Research Council, which has filtered into our advanced life support algorithms. And for this case, we'll start off with our pre-alert, which in our hospital comes in the form of a very loud red phone. So the case that we have is a 2-year-old male who's found in water with no obvious injuries, but is in confirmed cardiac arrest with active advanced life support pre-hospitally. And he will arrive in your department in 10 minutes. And these 10 minutes are key to how you set up your team, discuss what potentially you're going to do, and what you may not do in this resuscitation. And when we think of drowning, the first question that comes into my mind is whether I need a medical or trauma team, as I will need probably a reasonable number of people in order to resuscitate this patient to the best of my department's ability. I need to specifically prepare my resuscitation room to receive a drowning patient, thinking of temperature and the number of people I'm going to need in order to continue to do CPR. One of the key pieces of additional information I need is this patient hypothermic or not? This will change how I actively resuscitate this patient with deviation from the traditional APLS cardiac arrest algorithm. Time is incredibly important in these cases. And if I can get a little bit of information about whether this case was witnessed or unwitnessed, when they were last seen alive, and how long it took them before CPR was started, I can think in my head about what is the potential outcome for this patient. In certain cases, we must think, is it appropriate to continue CPR when they arrive in the emergency department? And there's often this strange position we're in when we think of hypothermic cardiac arrest as requiring prolonged resuscitation. But in some cases, the outcome is always going to be poor. And we should consider prepping the team to say, when the patient arrives, we may do X, Y, and Z, or we may stop immediately. And it's important that this is discussed in those 10 minutes that you have, so you've got this shared mental model for how you're going to resuscitate this patient. Now, epidemiology and pathophysiology can be onerous topics, and I know all of you want to get stuck in to thinking about how you're actually going to resuscitate them, but we must know about what is happening in the UK and Ireland so that we can prepare for what may arrive in our emergency department. And that's where epidemiology is key. And pathophysiology is really important to understand the mechanisms of drowning, what the patients will go through before they arrive, and what stage we might see them when they arrive in our ED. In the UK, approximately 400 people die each year as a result of drowning, and an additional 200 take their lives in open or inland water. So overall, this is a relatively infrequent event in the UK, but one that we should be expected to see and manage well. If we look at the global data, the World Health Organization estimates about 250,000 people die each year due to drowning. We must acknowledge that this is an underestimate of the true prevalence. If we look at it from another way, it's responsible for 7% of all injury-related deaths. So it certainly is a global problem. If we look at some of the UK paediatric and young person caseload, one of the best databases we've access to is Tarn. And in their publication over a 2-year period, they recorded 46 cases with severe injury or an injury severity score over 15. Again, this underrepresents the problem, as they exclude all cases that died at scene. And there's also reasonably robust inclusion criteria, which means some cases wouldn't have fulfilled their requirements. And there are differences depending on the age of the patient, with those who are young being very little difference in terms of gender and supervision playing a huge role. And in their older population, it's much more young males who are affected. And we look at some of the themes surrounding it. Alcohol has a huge role to play in deaths in kind of young adults or adolescents and in the adult population. Supervision is a huge issue, and we've all been involved in those cases where we've had a young child who's been left unsupervised in a bath or close to a pond with either serious injuries or fatality. And unsurprisingly, epilepsy has a huge role. And it's up to us on discharging patients with first presentation of epilepsy in order to make sure that these children and young people are educated around the dangers of epilepsy in water, particularly around bathing and swimming unsupervised. And although we drill this over and over again, prevention is much better than treatment. So if we can stop children and young people drowning, that is much better for them long term. And it certainly feels over the last year we've seen a massive increase in the number of drowning cases, or there's more than being picked up by news outlets. We had an unbelievable summer in terms of temperatures and good weather, which essentially drove people to our beaches and our inland waterways such as rivers and reservoirs. And particularly during that hot spell, it felt like every single time I went onto the news website, there was more tragic cases of drowning. And this is an onus on us to be able to prepare our department and ourselves for how we resuscitate these cases.
And although these patients, these pictures are quite harrowing, they do tell a story of how other young children are drowning as they're being driven away from their home country, crossing large volumes of water, either the Mediterranean or the English Channel, often in poor conditions with very little regard for safety. And these children are dying in huge numbers. Drowning, in terms of the simplest definition, is when liquid enters the lungs. And this is usually in the form of water. And the recommendations is now to simplify the terms and adhere to fatal or non-fatal drowning, and also recognising that water rescue is a potential, in which case the patient is taken from the water and has no evidence of respiratory or cardiovascular compromise. Unhelpful terms include dry or wet drowning, or delayed onset of respiratory distress, or secondary drowning. And we should try to avoid these at all costs. Now, there is a difference between immersion and submersion. And submersion is when your head, or the whole head, is below the water. And immersion is when the head is bobbing up and down above the water line. And these will have difference in terms of outcome and in terms of the amount of water that can enter the lung. And while there is pathological differences about how salt water and fresh water cause damages to the lung and impair respiration and eventually cardiac arrest, these should be managed in the same manner. And it doesn't really matter in how I resuscitate a patient whether they've drowned in salt or fresh water. Your physiological response to water can depend on temperature. And whenever we enter into cold water, we can get this hypothermic or cold shock. When we start to shiver, we may increase our respiratory rates, we may peripherally start to shut down, and this can last for a variety of duration of time depending on how your body has been primed to it. But if we have a submergent injury where our head goes underwater, we have this usually breath holding reflex where we stop breathing, usually associated with tachycardia, but can be associated with bradycardia as well. After a period of time, the high CO2, low oxygen levels will trump this diving reflex, prompting us to inhale. Water enters into the upper airway, we get laryngospasm, which is there to prevent water entering into the lungs. Again, this only lasts a period of time before that spasm release, and we get a massive influx of water into the lungs, which can result in removal of surfactant, further respiratory impairment, cardiac arrest, and death. And this period can happen from seconds to minutes and will vary depending on individuals. So let's bring this back to a clinical point of view about how we're going to prepare. And we've already mentioned the case, but just to go over it again, is a 2-year-old male who has found submerged in water, no obvious injuries, has ongoing resuscitation of cardiac arrest, and will be there in 10 minutes. And drowning is one of those cases in which we can have unexpectedly good outcomes despite the history and the presentation that's in front of us. This was something that I saw on Twitter in the last few months with a pre-hospital crew who were called to a cardiac arrest. And this arrest involved a 4-year-old boy who drowned in a pool, and this was witnessed on CCTV camera with a downtime of 8 minutes. He then had advanced life support performed for 10 minutes before they got ROSC. And not only did they get a pulse back, but also this patient had an excellent neurological outcome. So hypothermic cardiac arrest can have particularly good outcomes in certain circumstances. And in this case, we had a 2-year-old girl who had a submersion time of 66 minutes, which was witnessed, who was profoundly hypothermic with a temperature of 19 degrees on arrival to the emergency department, who had 2 hours of active resuscitation, including the use of ECMO or extracorporeal membrane oxygenation, and not only survived, but did so with good neurological outcomes. And this challenges us and makes us think of those cases which have hypothermic cardiac arrest, that there can be a good prognosis despite all the odds that may be stacked against us. Now, it's important to share this information with your team. So talk about it before this patient arrives. Is this patient someone that we're going to do prolonged resuscitation based on the information that you have? What equipment do I need in place in order to perform this resuscitation? Do I have the use of cardiac bypass or ECMO on site, and would they use this in a paediatric or young adult? get that plan in place. So when the patient arrives, I want A, B, C to happen initially, and then I want you to feed back to me, so everybody's got that shared mental model that they're working towards. And before that patient arrives, try and assign either you or somebody else to get additional information which will help make decisions about how you're going to resuscitate this patient. So try and gain some additional information to help you run this resuscitation, and clarify, first of all, what was the exact mechanism of injury. Is this simply a drowning case, or is it also associated with significant trauma? Get some information about the temperature both of the patient, in whether this is going to be hypothermic cardiac arrest, and of the water. May have implications on how long you're going to run the resuscitation. We know those patients who are submerged in truly cold water, so anything below 6 or 10 degrees, can have some neuroprotective effects from this. And this is particularly true for young children or small adults. Whenever the water enters into the lungs, the heart cools, which slows the blood circulation and results in the temperature around the brain decreasing quite quickly. And as mentioned in the initial case, there's been some good survival for prolonged submersion times in hypothermic patients, up to 66 minutes. Whether this event has been witnessed and the duration of time in water is incredibly important. And the time was taken for CPR to be performed, whether this was initiated by a bystander or we had to wait for the pre-hospital team to arrive. We must recognise the physiology that's associated with hypothermia, which can often have similar presentations to death. So the patient will usually be profoundly cold, they may have very shallow or no respiratory effort, they may have low flow cardiac output as opposed to no flow, and their pupils will often be dilated and fixed in response to hypothermia. So appreciate that, take those variables on board and monitor them as you continue resuscitation. Now, who doesn't love a little bit of evidence-based medicine? And we're very fortunate that there is some amazing articles about drowning, both applicable to paediatrics and to our adult population. And this paper was published in the New England Journal of Medicine over 9 years ago, but answers some of the pertinent questions. One of the standout parts of this paper is this flow diagram, which tries to give us a little bit of evidence on prognostication. And this was based on a massive data set of over 41,000 patients in Brazil who were rescued by lifeguards. 6% required some form of medical intervention, with less than 1% requiring CPR. So if your patient was removed from the water and was able to answer and had a normal respiratory examination, they all survived. If they were able to answer and had some evidence of aspiration of water and a normal blood pressure, 95 plus survival rate, with a hypotensive or shock, survival rate was still somewhere in the 80% range. They were also able to offer answers for those more severely unwell. So those who had an absent pulse, who were submerged for over an hour, and who had obvious signs of death, none of them survived. And again, this has implications for how we may manage our department. If we know the submersion time was 2 hours, we may decide we'll look at the patient when they arrive and stop. For those who had an absent pulse, who had a submersion time under an hour, had no obvious physical evidence of death, the survival rate was between 7 and 12%. And those with a pulse who weren't able to answer but had a pulse present, their survival rate was between 50 and 70%, depending on some other parameters. When we look at some of the paediatric specific data, I think this is an excellent article published in 2012 in the BMJ of a study that was performed in the Netherlands. And this is specifically looking at children, so under the age of 16, who had a core temperature of less than 34 degrees and who had confirmed arrest at arrival of emergency services at scene and had over 30 minutes of active resuscitation. And these are the cases that we often worry about. So what will be the outcome for these cases? Should we stop when they arrive, or do we continue indefinitely? And this tries to give us some answers. So they had a total of 160 people who met their inclusion criteria, which is quite impressive, of which 30% were discharged from hospital, with 10% having good neurological outcome at 1 year. Of the 160, 104 had ongoing CPR on arrival to the A&E department, equating to approximately 65% of the population. And there's some excellent figures which offers us analysis of specific variables. So unsurprisingly, the longer duration of CPR, the poorer the outcome. So anyone over 30 minutes of CPR had incredibly poor outcomes in terms of death or long-term neurological outcome. Interesting to know, there was no statistical difference when they compared winter, where the water was colder, and in the Netherlands the water can go between 0 and 8 degrees in the winter compared to other seasons. And there was statistical significance in terms of presenting rhythm. Now, for most cardiac arrests that come through, if they've got a shockable rhythm, the outcomes are better. The opposite seems to be the case for hypothermia. Whenever if you present with bradycardia or asystole, there seems to be a slightly preferred outcome as opposed to VF. And often in the hypothermic patient, these VF patients have shock refractory arrest, and this may prompt you to think of ongoing CPR or the use of extracorporeal life support. They were able to provide some really good data on whether basic life support was performed at scene, and if it was delayed for over 10 minutes, the outcomes were incredibly poor. So we need to educate our population that if we remove patients who are in active cardiac arrest from the water, we need to start CPR straight away in order to improve some outcomes. So there's other variables associated with poor outcomes, including ongoing life support on arrival to the A&E department, low pH, so anything less than 6.8, or an elevated base excess. In this group of 160 patients, 12 were offered ECMO, none of which survived. On the back of this and other studies, APLS or ALSG is able to offer some advice on prognostication, which you can easily access from their website or having a look at this slide. So let's bring it back to the resuscitation room. So we talked about how key preparation is, that we all should have this shared mental model and that we're ready for the patient arriving. If they're hypothermic, I might be thinking of prolonged resuscitation, in which case I know I'm going to need lots of people. The data is consistently clear. After 2 minutes of CPR, the personnel get fatigued and you need to have enough people to be able to rotate through. If it's an older patient, do you have something like an autopulse that you can use to ensure good quality CPR is delivered to that patient continuously? Do you have access to cardiac bypass or ECMO, and is your centre set up to deliver that for children and young people? Think about how your team is prepared in order to actively rewarm this patient. And a scribe is key. Get times written down so that when you know exactly what's happening, who arrives when, and what the next step's going to be. And ALSG or APLS has given us some excellent advice about how we can actively rewarm these patients, both externally by removing wet clothes, drying the patient off, and having the temperature of the room to an appropriate level, as well as core rewarming by giving them warm gases, fluids, and lavage. And care has to be taken about how we rewarm them. We don't want to rewarm them too quickly, as there are some known complications associated with that. If the patient is normothermic, as in over 35 degrees, you follow the normal pediatric advanced life support algorithm. If they're hypothermic, as in less than 35 degrees, there is some variations. And this can often throw people off, as it can be difficult to remember. So either simulate this regularly or have access to this information in your resuscitation room in order to cognitively offload those changes to somewhere else. So remember, less than 30 degrees, no drugs, and only 3 shocks. Between 30 and 35 degrees, you can give drugs but double the spacing, and you can consider doing shocks. So if they've got VF or VT, you can continue to give your shocks as you would normally do so. Above 35 degrees is normal cardiac arrest algorithm. There's been some recent change in guidelines by the Resuscitation Council in the UK about how we undertake resuscitations in advanced paediatric life support settings, with some specific criteria or recommendations for those who are in hypothermic cardiac arrest. So one of these is that we can consider using delayed or interrupted CPR, and the other one is consider sending these patients to centres with extracorporeal life support or ECMO. When I looked at the delayed or intermittent CPR, this was really a new concept for me. And I tried to find any sources about it. This seems to be the paper that the data was taken from, which is a 2014 paper published in Resuscitation, and the data seems to come from 3 cases, a 29, a 42 and a 57-year-old, where the rescuers weren't able to remove the patient from the environment, such as a mountain or a river, while continuing CPR, and decided in that instance the most important thing was to move the patient and stop CPR. Whenever they were removed to a more suitable environment, active resuscitation continued, and all 3 patients had a good outcome. For me in the emergency department, this probably has little benefit, in that I should have the personnel and staff required in order to actively resuscitate this patient and continue CPR. It might mean in certain circumstances that gets to prioritise while I do other things, but my plan will be to continue CPR in my emergency department. But it'll be interesting to see if any other data comes through about this. In terms of extracorporeal membrane oxygenation, or ECMO, there is some good adult and paediatric data looking at improved survival outcomes. So out of hospital cardiac arrest in the UK, survival figures are about 7%, and with some of our Scandinavian cousins, these out of hospital figures are up to about 14%. With the use of ECMO in certain circumstances, in targeted populations, your in-hospital cardiac arrest survival rate can go up to 54% for decannulization and up to 40% discharge, which is incredibly impressive. Survival isn't the only thing that we need to be aware of, and good neurological outcome is important, and this is a publication in 2019 which answers this questions. Again, it's a small population involving paediatric patients with only 61 cases, of which 41% survived to 12 months, and a third of which had good neurological outcomes. A lot of these cases were post-cardiac or had specific complications, so therefore the time in order to get ECMO initiated was short. And my feeling is that this enhanced survival rate is really, and these recommendations, is pushing us to develop these services to see if we can get similar results from those who die pre-hospitally or arrest pre-hospitally. So when I'm leading these resuscitations, I treat them as a trauma and have my team prepped and set up accordingly. When the patient arrives, reconfirm that they remain in cardiac arrest and continue CPR. We look and ask if there's any catastrophic hemorrhage. While the patient is being intubated early, we also have a member of the team stabilising the C-spine. Someone assesses breathing, looking for alternative pathologies, particularly noted if there's any accessory noises when the patient is being bagged. It's often very difficult to establish access in these patients due to them being shut down and or hyperthermic. So therefore IO access is useful, and usually 2, one to allow the administration of fluids if required, and the other drugs. Think about rewarming that patient and remove any wet clothing, and to try and rewarm them externally and also increase their core temperature. While all this is happening, someone may be considering doing a secondary survey looking for other injuries which may help explain why the patient is so unwell, or alternative pathologies in line with our 4H's and 4T's that we're well versed in. So let's bring this back to this case. So before the patient arrives in the department, you're able to gather a little bit more information. So this was an unwitnessed event, but the parents report the child was missing for approximately 20 minutes before he was found face down in the pond. The bystanders who removed him from the water were unable to provide CPR, despite prompts and advice from their emergency services. CPR was started on arrival of the pre-hospital crew, which was 15 minutes from when he was removed from the water. When he arrived to your A&E department, he had ongoing CPR, which was already 30 minutes duration, and one of your amazing Regis managed to get a gas as soon as they arrived, which shows an initial pH of 6.8. So let's talk about our arrest management of this patient. So we followed the trauma algorithm. There was no catastrophic hemorrhage, which would be expected in cases like this. We had the patient intubated by our anaesthetist, who was using warm gases and was prepped to do so, so there was no delay. We immobilised the C-spine, given that we weren't 100% clear on the mechanism of injury. The patient was ventilated, and we got IO access. 2, done quickly, and we're given warm fluids. Our sugar was normal. Our pupils, which were fixed and dilated, which you remember may be a consequence of hypothermia and not solely related to an intracranial pathology or poor outcome. And the temperature of the patient was noted to be 32 degrees. with continued active rewarming. And as we continued this process, after 2 rounds of CPR, we got a pulse back. And in this case, the PICU team arrived and took over care. And the rest of this case will be discussed with my colleague, Dr. McVea. Thank you very much for listening, and happy to answer any questions at the appropriate break.
Hello, my name is Dr. Stephen McVea, and I am a consultant paediatric intensivist working in Belfast, and I am going to continue our case looking primarily at the management of the child post-cardiac arrest and of the post-cardiac arrest syndrome. So, a summary of our case to date and of the referral made to PICU at this point. We have a 2-year-old boy who has suffered an out-of-hospital cardiac arrest. He was found submerged in a pond with potentially up to 35 minutes of downtime prior to the onset of CPR. He received 30 minutes of CPR whilst en route to the emergency department, and when he arrived in the emergency department, he was intubated, ventilated, actively rewarmed, and received 2 further rounds of CPR before return of spontaneous circulation, or ROSC. At the time of PICU referral, he had a size 4 cuffed ET tube in orally at 13 centimetres. He was on the department's transport ventilator, receiving tidal volumes of 7 mils per kilo, pulling pressures of 28/8 to achieve this. He had a respiratory rate of 25 and was on 60% oxygen. His saturations were 93%, and he had coarse crepitations throughout his chest. His capillary gas showed a pH of 7.02, PCO2, which was high at 6.8, a base excess of -18 with a lactate of 14. His chest x-ray showed his ET tube was at an appropriate position at T2 and that he had bilateral lung infiltrates. His heart rate was 128 and his MAP was low at 45 with a prolonged capillary refill time of 4 seconds centrally. His pupils were large, but they were now reactive, albeit sluggishly. His GCS was 3. His temperature has now risen and is recorded at 32.2 degrees C centrally, and he has an IO in with no other IV access. So, cardiac arrest from drowning in children. If you look at the literature, drowning is a common cause of out-of-hospital cardiac arrest in children. Depending on the series, it may account for 25 to 31% of cases. Various series report variable survival rates from 9% up to 46%. A worse outcome is seen generally if the child is subjected to a longer submersion time or requires a longer duration of CPR prior to ROSC. And in general, the majority who receive over 30 minutes of CPR and then survive to 1 year do so with a poor neurological outcome. The Thapka studies were large, multi-centred, randomised controlled trials carried out in the setting of paediatric cardiac arrest. They assessed both in-hospital and out-of-hospital cardiac arrest for the use of therapeutic hypothermia versus normothermia. Of the out-of-hospital cardiac arrests identified in the Thapka study, 25% of cases were due to drowning. The survival for such cases in this large multi-centred randomised control trial was 46.4% at 1 year. And at 1 year, 24.6% of survivors had a favourable neurological outcome. Unfortunately, published data to date isn't sufficient to guide optimal management specific to the child who has suffered a cardiac arrest secondary to drowning. As such, clinicians are advised to follow general guidance for managing the post-cardiac arrest syndrome. Post-cardiac arrest syndrome is a syndrome with 4 major components which results from a global hypoxic injury to the body followed by reperfusion injury with the formation of free radicals. The major systems impacted by the post-cardiac arrest syndrome include the brain and neurological system, the heart and cardiovascular system. The other 2 major components are the generalised ischemia and reperfusion injury to the remainder of the body systems, and a component consisting of the pathophysiology which resulted in the cardiac arrest, which may be persistent. These components define our management priorities when looking after children post-cardiac arrest. Management of the paediatric post-cardiac arrest syndrome must begin promptly after ROSC. Typical indications for starting this management include the requirement for CPR for more than a minute in combination with a persistent comatose state post-ROSC or a requirement for mechanical ventilation post-ROSC. Contraindications to ongoing intensive care management and post-cardiac arrest syndrome management include the presence of an advanced care directive advising or necessitating an avoidance of intensive care management, when aggressive neurocritical care is deemed not appropriate at a consultant level. The management of the post-cardiac arrest syndrome requires a coordinated effort, systematic approach, and integrated approach. I have combined the early and the intermediate management of the post-cardiac arrest patient in the coming slides. This covers the first 72 hours of the post-ROSC time interval. The airway and breathing management of the patient post-cardiac arrest necessitates securement of the airway. If this hasn't been done during CPR, then this should be secured as soon as possible post-ROSC. If anaesthetic agents are required in order to secure the airway, then I would advise using as cardiostable an induction as possible, probably with reduced dose ketamine as an induction agent and rocuronium as the muscle relaxant of choice. I would advise against the placement of a nasal ET tube as post-cardiac arrest coagulopathy is frequent and a major epistaxis may significantly compromise ongoing management of these cases. I would also advise against electively changing from an oral to a nasal tube early in the post-cardiac arrest course, as this risks loss of the airway and rearrest, and also will detract from time spent managing other aspects of the child's case, as we're going to come on to. I would advise for a cuff tube in all cases, as these children are likely to develop an acute respiratory distress syndrome pattern necessitating significant ventilatory pressures, and if an uncuffed tube is used, significant leak may compromise ventilation and require an ET tube change in its suboptimal position. Otherwise, the airway is managed as per standard paediatric intensive care policies, including monitoring of cuff pressure and confirming of position on a chest x-ray. As I've alluded to, children post-cardiac arrest are at high risk of developing acute lung injury or paediatric ARDS. This is a combination of a reperfusion injury to the lungs and of aspiration. And management in these settings requires achievement of certain goals with avoidance of injuring the lung further. The key goals to achieve are normocapnia and avoidance of hypoxia. Both of these goals are significant targets for adequate neuroprotection and therefore must be achieved. With regards to ventilation, normocapnia is targeted with a PaCO2 of 4.5 to 5.5 to avoid either excessive cerebral blood flow or excessively restrictive cerebral blood flow. The times when you would deviate from this target would be in situations where the patient is known to have a chronically high PaCO2, when normal PaCO2s for that patient are targeted. In order to achieve normocapnia, a ventilation approach is taken which avoids ventilator-associated lung injury. This approach should be that in keeping with the management of paediatric ARDS, namely low tidal volumes, limitation of plateau pressure, titration of optimal PEEP, and avoidance of high levels of FiO2. The respiratory rate of the ventilator can be used to increase the minute volume and manage the CO2. In addition to this, placement of an NG tube to decompress the stomach and avoid an overinflated stomach compressing and splinting the diaphragm is important. Adequate oxygenation is key, and avoidance of hypoxia to avoid secondary cerebral injury. Targeting of saturations of 94 to 98% is a reasonable approach, unless the patient has chronic cyanotic congenital heart disease, in which case targeting normal saturations for the child is adequate. In adults, hyperoxia has been shown to increase mortality post-cardiac arrest and should be avoided. From a cardiovascular perspective, these children behave similar to a severe sepsis. They generally develop a low cardiac output state and, as a compensatory mechanism, raise their systemic vascular resistance through vasoconstriction. The low cardiac output state is secondary to a reperfusion injury to the heart, resulting in tissue edema of the myocardium. This results in a global stun with reduced contractility and reduced cardiac output. Onset of this dysfunction is early, within approximately 30 minutes of return of spontaneous circulation, and the nadir occurs approximately 8 hours post-ROSC. The situation generally lasts for up to 48 hours, and recovery to near normal function should be expected. During this period, our goals are to ensure that the body systems receive adequate oxygen through adequate, effective end organ perfusion. A major target is the avoidance of hypotension, which is associated with increased mortality and morbidity in these cases. In order to guide optimal cardiovascular management, the patient would ideally have an arterial line, a central venous line, and a urinary catheter inserted. On inserting the IV lines, baseline bloods should be sent as listed on the slide. This will allow multimodal monitoring of the patient, including clinical parameters such as heart rate, BP, and perfusion. Urinary output can also be monitored, as well as investigatory parameters such as lactate and the clearance of lactate, and the mixed venous saturations. In addition to these monitoring modalities, a 12-lead ECG is useful in order to assess for any arrhythmia, and a bedside echocardiogram, if local skills allow, is useful to assess for the degree of left ventricular dysfunction. Management of these children requires careful optimization of preload, contractility, and afterload. Preload can be optimized with judicious use of small aliquot boluses of crystalloid fluids, monitoring the effect clinically after each bolus to avoid fluid overload. Once euvolemia is obtained, cardiac contractility can be aided with the addition of low-dose adrenaline, which can be started peripherally prior to central venous catheter insertion. Adrenaline at low dose is a good choice as it has predominantly beta effects, resulting in increased cardiac contractility and increased heart rate, with avoidance of the alpha effects of increased vasoconstriction, which will increase the afterload on the heart. Often this is enough to stabilise the cardiovascular system early, and with time the PICU team will consider adding in additional agents such as inodilators, including milrinone or dobutamine if the BP allows. Pure vasoconstrictors such as vasopressin and noradrenaline should be avoided, as these elevate afterload and increase the strain on the left ventricle, but hypotension should be avoided at all costs. Hypotension in the first 6 hours post-ROSC was associated with reduced odds of survival in the THAPCA multi-centre randomised controlled trials, and therefore a key treatment target is avoidance of hypotension. If in doubt, early consultation with the local PICU consultant or retrieval consultant in order to help guide the management of vasoactive agents is indicated. The cardiovascular system can be further optimised by optimising oxygen carrying capacity of the blood, with consideration for red cell transfusion, and any arrhythmia should be treated in line with APLS guidance. Generally, we are aiming to normalise perfusion at the bedside of the patient, achieve a normal blood pressure for the patient, aiming for around the 50th centile. I've included some examples by age on the slide, and we should hopefully see that the child will begin making urine and that their lactate will begin to fall. From a neurological perspective, we are aiming for strict neuroprotection in these cases. The brain will have been hypoperfused, will have undergone a hypoxic ischemic insult, and then a reperfusion injury. This will have resulted in cellular loss and apoptosis, loss of cerebrovascular autoregulation, and developing cerebral edema. Neuroprotective measures that should be instigated in all cases include nursing the patient in the head-up position at 30 degrees and the head in the midline, avoidance of hypoxia and hypercarbia, as we've already discussed, and maintenance of an adequate mean arterial pressure and avoidance of hypotension, as already discussed. Addition of sedation should be considered in order to reduce cerebral metabolic demand, and common agents used in pediatrics include the combination of morphine and midazolam. Paralysis with neuromuscular blockers can be considered, but if possible avoided, and where available, monitoring should be instigated to identify seizures early using EEG, CFAM, or compressed spectral array monitoring where possible. Early neuroimaging with CT should be carried out to rule out major neurosurgical or catastrophic pathology. The post-cardiac arrest syndrome patient has a high incidence of pyrexia or hyperthermia in the hours post-ROSC. Hyperthermia, even a single episode of fever greater than 38, is strongly associated with a poor neurological outcome, and this was the major driver which resulted in the THAPCA studies being carried out to evaluate mild hypothermia of 33 to 34 degrees versus normothermia in the post-cardiac arrest population. These studies showed no benefit of mild hypothermia over normothermia, and for the most part, paediatric intensive care units now target a normothermic goal for their post-cardiac arrest syndrome patients. This normothermia needs to be actively and aggressively maintained through the use of servo-controlled mechanisms and devices which monitor core pressure and either cool or warm the patient to maintain normothermia. However, we are often faced with patients post-cardiac arrest who are cold, and in particular in this case of a child suffering a drowning episode who is hypothermic. Often these children are actively warmed, but care needs to be taken to avoid overshooting and resulting pyrexia in these children, given the strong association of pyrexia with poor outcome. To this end, I would suggest that active warming is indicated if the child's temperature is below 32 degrees C, and once the child's temperature is above 32 degrees C, then passive rewarming can be used until normothermia 36 to 37 degrees C is obtained. Once normothermia is obtained, then active normothermia via servo-controlled mechanisms should be used to maintain this goal. Often, as I've said, the fever occurs post-ROSC, so the servo-controlled mechanisms generally cool the child to maintain active normothermia. Shivering is common in this situation, and to avoid this, adequate sedation with morphine and midazolam with potential addition of muscle relaxants can be used to avoid the increased metabolic demand of shivering. Muscle relaxants, however, should be avoided if at all possible. The reason for this is that it obscures any clinical seizure activity. Seizures increase cerebral metabolic demand and result in impairment of our neuroprotective goals. Therefore, we, in the post-cardiac arrest syndrome patient, institute continuous monitoring for seizures via EEG, CFAM or CSA modalities, and treat seizures aggressively if they develop. Seizures are generally treated in lines with APLS guidance using benzodiazepines, Keppra. Phenytoin can be considered, but with newer guidance coming out that Keppra is as effective as phenytoin, and phenytoin carrying a higher risk of arrhythmia, Keppra may be preferred. And I would also caution against the use of thiopentone, which appears commonly in persistent seizure algorithms, given its propensity to drop blood pressure. Anti-epileptic drug prophylaxis generally isn't indicated, but can be reviewed on a case-by-case basis in line with local policy. Other systems also take a hypoxic ischemic insult. For example, the bowel is often underperfused, and this may be added to by the use of vasoactive drugs. In general, for the first 24 hours post-ROSC, the gut is protected by remaining nil by mouth with or without the addition of a proton pump inhibitor, and then enteral feeds are started with caution after 24 hours. In order to prevent against dehydration and hypoglycemia, isotonic IV fluids are started at 2/3 to 80% of maintenance levels, and dextrose is added at an appropriate percentage for the age of the child to prevent hypoglycemia. Hypoglycemia and hyperglycemia are both associated with worse outcomes post-cardiac arrest. We therefore need to target normal glycemia. Moderate control is adequate, as tight control is more commonly associated with hypoglycemia, allowing blood glucoses to be between 6 and 10 millimoles per litre. No definite threshold for therapy exists, but insulin should be considered if blood glucose is persistently greater than 10 to 12 millimoles per litre. Electrolyte derangement should be corrected and monitored. Generally, we keep the sodium at the higher end of normal to protect against the effects of hyponatremia on cerebral edema, and we generally aim to keep the potassium, calcium and magnesium at the upper end of normal to protect against arrhythmogenic risks with hypokalemia, hypocalcemia and hypomagnesemia. There is no evidence for the addition of hydrocortisone post-cardiac arrest syndrome unless there is refractory hypotension requiring 2 or more vasoactive agents. Acute kidney injury is common post-cardiac arrest, but there is no specific evidence for renal replacement therapy in this population, and the indications for instituting renal replacement therapy are the same as for other critically ill children. In addition, if an infectious etiology for the cardiac arrest is suspected, then cultures should be sent. Broad-spectrum antibiotics should be started pending the culture results. There is not any clear indication for prophylactic antibiotics post-cardiac arrest. Coagulopathy is common post-cardiac arrest, and general PICU thresholds for optimization of coagulation, platelet levels and hemoglobin are indicated. In our case, the boy was transferred to PICU from the emergency department. Prior to transfer, his ventilator rate was increased to achieve normal capnia. An adrenaline infusion was started initially peripherally and then transferred to the central line once this was inserted. With the adrenaline infusion, his mean arterial pressure rose from 45 to 60 within the target range for his age. Urinary catheter was inserted and an arterial line was inserted, and we saw over the next 12 hours an improvement in urine output and a slow clearance in his lactate levels. He was allowed to passively rewarm from 32.2 degrees in ED to 36 degrees, and then active normothermia was maintained. Cultures were sent from his blood and from a blind bronchoalveolar lavage specimen, and he did undergo a CT brain which showed no neurosurgical cause for his collapse, resulting in the fall into the pond. Over the next 48 hours, his ventilation actually remained relatively stable, achieving the goals of normocapnia and normoxia within safe ventilatory parameters. He did develop some gasping, spontaneous efforts on the ventilator, and he had a cough but no gag at this point. Echocardiogram on admission showed a moderately impaired left ventricular function, which resolved by echo at 36 hours, which was in keeping with the clinical picture where his mean arterial pressure improved and adrenaline had been weaned off by this point. An acute kidney injury did develop in this 48-hour window with a progressively positive fluid balance. This was managed with a furosemide infusion, and no need for additional renal replacement therapy was required. Transaminases were elevated and a mild coagulopathy was seen on his bloods. He did not develop any sign of overt bleeding, and the coagulopathy corrected with IV vitamin K. Cultures from the blind bronchoalveolar lavage grew a Klebsiella species, which was sensitive to ceftriaxone, onto which he was started. From a neurological perspective, his pupils were a size 2 and reactive. He had some extensor posturing to suction and no signs of any seizure. He was sedated with a combination of morphine and midazolam. I am now going to move on to give an insight into our later management of the child post-cardiac arrest. Generally, this is after 72 hours post-ROSC. And in general, we continue our management up until this point, and we start then to make a more prognostic view of the patient. It must be said, however, that in the first 72 hours, if it becomes clear that the patient may have already died, and in that I mean by death by neurological criteria or brain stem death as it used to be termed, then appropriate assessment for this should not be postponed. Otherwise, neuroprognostication should be postponed until 72 hours post-ROSC. In order to avoid clouding of the assessment, all neuromuscular blocking agents should have been stopped and allowed to wear off, and sedation should have been reduced to a minimum level for approximately 12 hours prior to assessment. The neuroprognostic assessment is a multimodal assessment, often carried out in combination with a paediatric neurology specialist. It involves a full neurological examination, an EEG, and an MRI. The timing of the MRI is important. Changes on diffusion imaging peak between day 3 and 5 post-ROSC. Prior to day 3, false negatives may be obtained as lesions have not yet developed, and after a week these lesions may disappear on imaging due to pseudonormalization. As such, an MRI is often conducted between days 3 and day 7 post-ROSC. Indeed, a normal MRI with normal DWI at 3 days post-ROSC is associated with a good prognosis. With the findings of our neuroprognostication, we then decide what approach to take. Options are that we relax neuroprotective measures, wake our patient up, wean them off the ventilator, extubate them and move them on towards rehabilitation. In more borderline cases, we may continue the neuroprotective measures for a few further days and then reassess. It may become clear that a very poor outcome is likely, in which case difficult discussions and shared decision making with the family with regards to reorientation of care may be indicated. And finally, it may become apparent as time passes that the patient may have already died by neurological criteria, in which case formal assessment is warranted. So what happened in our case? Well, sedation was weaned and stopped. He was breathing spontaneously on the ventilator. Pupils were equal and reactive. He had a good cough but a weak gag, and he had abnormal posturing to painful stimuli. His EEG was abnormal, and his MRI showed widespread infarcts in the cortex, the thalamus, and the basal ganglia. His parents were counselled regarding the poor prognosis and likelihood of severe disability. However, no agreement could be reached with regards to any limitation of his care or reorientation of his care. He was extubated to high flow nasal cannula oxygen, but required re-intubation 24 hours later because of hypoxia, likely secondary to poor secretion clearance or aspiration. In the 4 days following this, he was treated with antibiotics, but no positive cultures were obtained. He was weaned down onto minimal settings, started onto NJ feeds, and receiving regular chest physio in combination with glycopyrronium in order to manage secretions. With this combination, he was successfully extubated to mask BiPAP, which was gradually weaned over the next week to nasal cannula oxygen. He was discharged to the ward, requiring 3 times a day physiotherapy and NJ feeds. So in conclusion, I just wanted to highlight what I feel are my key messages for managing the child post-cardiac arrest. Post-cardiac arrest syndrome is a multi-system disorder requiring multi-organ support. One of the major systems impacted is the cardiovascular system, with impairment of left ventricular function. Early hypotension has a significant impact in morbidity or mortality, and therefore I would suggest early support of these children with low-dose adrenaline started peripherally in order to prevent hypotension. I would caution against electively changing an oral to a nasal tube early in the course of these children. First, it risks a chance of rearrest if the tube does not pass easily. Secondly, these children are often coagulopathic, and the changing to a nasal tube risks an epistaxis, which may be poorly tolerated. And finally, there are lots of other things that need to be sorted and need to be done in stabilising these children, and time may be better spent sorting these aspects out first. The majority of management of these children is preventing secondary injury, and to that end, avoidance must be made of hypoxia, hyper and hypocapnia, hypotension and hypoglycemia, with targets of saturations of 94 to 98%, target PaCO2 of 4.5 to 5.5, target MAP at the 50th centile for age, and target glucose between 6 and 10. Finally, hyperthermia is incredibly common post-ROSC. Actively rewarming these children risks an overshoot. So once a temperature above 32 degrees is obtained, I would advise that you allow the patient to passively rewarm from this point and then institute an active normothermia mechanism once normothermia is reached. Thank you for your time.
Hi everyone, welcome back to panel discussion. I'd like to start by thanking both of the Stephens, Stephen Mullen and Stephen McVea, for really interesting talks, dovetailed really nicely. A few questions starting to come through. One of the things we'd be quite keen to discuss really, and I suppose maybe start with yourself, Catherine, in this, because sort of from PEM's point of view and retrieval, obviously in such situations, you've got a situation maybe with a child who's cardiac arrest, but you've got the complicating factor of that they're very cold, and obviously that might influence your initial management in terms of what you do at the scene, but also where you're going to transfer the child. And so wondering if you could maybe just share a little bit about sort of that the cold as a complicating factor in making decisions in that situation.
Yeah, I think we often get ourselves tied in knots about these, and I like to separate in my head drowning versus drowning and profoundly hypothermic children who have drowned, who are in cardiac arrest. We will intubate and ventilate because they'll have copious amounts of secretions. They'll need airway management, suction. We'll often pass an NG tube because they'll have swallowed an awful lot of air before they drown to decompress their stomach. They will often be cool if they have drowned in water in the summer, and we had a lot of water accidents over the summer with the good weather. Your management of your drowning and your continuation of your CPR and where you go depends on whether you have drowned quickly enough to have, or whether you've cooled quickly enough to have neuroprotection. The water temperature in the UK is about 12 degrees for most of the year. It can get down to less than 6 degrees in the winter. You have a poor prognosis in drowning and cardiac arrest if you have asphyxiated before you've cooled quickly enough, and if you have associated trauma with your drowning. We would often measure the water, or we would measure the water temperature because it's going to aid our prognostication. You have a better chance of survival if you've drowned in cold water less than 6 degrees. There have been survivors who have had unwitnessed drownings with prolonged CPR with really good neuro outcomes, but they've all drowned in very cold water and they have cooled really quickly before they have drowned. That is possible or before they've asphyxiated. That is possible in Northern Ireland in inland water in winter, particularly in small children, particularly in rapid flowing water. Those children we would try to take to the Royal with CPR ongoing, with mechanical CPR ongoing if they're big enough. The children who drown in warm water in the summer who have asphyxiated because they've been submersed before they've cooled are a different subgroup. Your chances of survival in those children is very much less. And those are the children who it is okay to stop on once you have gathered information and you know where you're at. But collateral history is really useful, witnessed history is really useful, bystander CPR is really important. Water temperature and core body temperature is really important. You have to be very, very cold and are cooled really quickly to have good survival benefit.
Thanks, Catherine. And then Stephen, I suppose from an EUD point of view, then is sort of obviously the cold then and the idea that hypothermia can influence your decisions about calling an arrest, and whether you think there is a degree of neuroprotection there, or whether you think actually, the water hasn't been cold enough, there hasn't been adequate CPR. So what sort of things go through your head when you're trying to make a decision about whether it's the right time to call an arrest or whether to keep going with longer or more prolonged resuscitation?
I think the first thing to recognise is that there's probably nobody that's an expert in these cases, certainly in the UK, and happening in such small numbers. So it's to use your team. So as I said, it's trying to gain that additional information to try and decide whether active resuscitation is going to be in the patient or family's best interest, or whether you call them when they come in. So if you know the patient has been missing for, say, 90 minutes, that gives you that 60-minute window versus the longest case of submersion, where you know the outcome's going to be poor. If you know that they're pulled out of the water, there's been no CPR started for over 10 minutes for whatever reason, and they come into the department where they actually are cold and dead. So they're cold with the evidence of rigor mortis. For those ones, usually I would call that pretty quickly. For some of the other ones, it's a lot more difficult. Usually the history isn't particularly clear. They might have disappeared for a period of time. You don't know the actual downtime. You don't know when they're pulled out, and you don't know what happened beforehand. So I would use my team around me. The last one that we had in our department, we had a discussion with both cardiology, with ourselves, and with the intensive care team to decide when we should call it. And I think that's probably the best thing. It shouldn't be one single individual saying, let's stop resuscitation. Let's work as a team, get as much information as you can as possible, and then reach your hopefully correct conclusion.
Thanks, Stephen. And Chris Costas, we've been talking a little bit about, so just recapping some of the perils of the sort of post-resuscitative care, things like sort of warming, and there was a question that came in about permissive hypercarbia. Just wondering if either of you can comment on sort of some of the key messages to take in terms of post-resuscitative care.
So the challenge with drowning patients is that you have two physiologies that are at in contrast to each other. So you want a lung protective strategy, but you also want a neuroprotective strategy. So you want near normal CO2, but also you're saying you mustn't over ventilate because you're gonna worsen your lung injury. So we're forced to choose between which organ to protect the most. And like Chris said in our private chat earlier, you have to hedge your bets on the brain first and try and do as good a neuroprotection as you can. And that's what I normally do. The other thing I would say is that there's a couple of questions, A, on antibiotics and B, on ventilation. I would say that we would routinely give antibiotics to all these patients, but there's a lot more nastiness and bacteria in freshwater drownings. So that would be your priority. If you have, so in freshwater drownings, that invariably you have to cover with antibiotics. The other thing that's not been mentioned is use of surfactant. So surfactant, so there's slightly different mechanisms, but freshwater inactivates surfactant, leading to alveolar collapse, pulmonary dysfunction, whereas saltwater just dilutes surfactant, but again, it has the same physiological effect of allowing the alveoli to collapse. There's soft evidence to suggest that you will make your pulmonary dynamics a lot easier if you use surfactant early in drowning victims. But this is not a recommendation I'm making for use in district general hospitals. This is specialized pediatric critical care management. If you're in a luxurious ECMO center like Pete on the panel, then you might stick this patient on ECMO if they're really struggling with the lungs. But for those in non-ECMO centers, surfactant can prove to be a kitchen sink life-saving treatment.
Thanks, Costas.
I was maybe just going to say a wee bit quickly about a few of the pearls. I think Stephen mentioned some of these. We kind of discussed before Stephen's talk, but don't put nasal tubes in these patients. They will not thank you for it. You're putting them at a risk. Start adrenaline after you get ROSC. The bolus of adrenaline that you're given is 10 mics per kilo. The infusion that you're going to start is 0.1 mics per kilo per minute. So the bolus is actually 100 minutes of an adrenaline infusion. So when you get ROSC, all that adrenaline is in the circulation. About 20 minutes later, the reason these patients re-arrest again is that adrenaline has worked its way out and the patient has a lot of myocardial stunning. So when you get ROSC, I would start the infusion and leave it running, and then we can work about weaning it away later. Think about an echo. So quite often that adrenaline is not enough and you're going to need to add something else in. And the other key point I would have is about rewarming the patients. Now most of us aren't going for normothermia with these patients, but I think if the patient's cool, as long as they're above 34, I wouldn't be actively warming them. The reason for that is you can overshoot. And you really only should be doing that when you've got temperature probes in and can control the temperature, so you're not going to overshoot. I've had patients before where people have done that in the DGH with warming blankets. They've become pyrexic on transfer and they're 39 by the time they reach the unit, which is a disaster. So the patient is safe, cool, and it's no worse than normothermic.
Great, thanks everyone. I think that's our time up on this discussion. Next, I think it's lunch, but again, hand over to Chris just to introduce that.
Yeah, that's right, Ben. We're going to take a wee break for about half an hour for lunch. Again, over lunch, we're going to play some of our sponsors' videos, so please do take a look at those. If you haven't already made a donation to Helping Hand, please think about that. You'll find a link to that over on the Paediatric Emergencies website and the links in the YouTube description to that. After lunch, we're going to get straight into our next talk. It's going to be Costas speaking about sepsis, but we'll see you back then in about half an hour.
With reusable scopes, setting up a bronchoscopy can involve a lot of waiting. Waiting for the respiratory therapist to call you back. Waiting for a time slot. Waiting till a bronchoscope is available. The Ambu A-Scope 4 Broncho is ready when you are. You simply grab the scope and monitor and are ready to go. With reusable scopes, contaminants can hide in the bends and channels even after high-level disinfection, bringing risks to your patients. With Ambu A-Scope 4 Broncho, you get a brand new, sterile bronchoscope straight from the pack every time. With the Ambu A-Scope 4 Broncho, you get more than just a bronchoscope. It's a fully integrated solution with 3 scopes, a tailor-made sampling solution, and a high-definition monitor to help you deliver the very best in patient care. Ambu A-Scope 4 Broncho. Guaranteed sterility, ready when you are.
True Baby X represents the appearance, weight, size, and movement of a 5-month-old. The Pediatric Clinical Skills Training Model is ideal for anaesthetists, nurses, and other pediatric emergency medical professionals practicing directly observed practical skills, pediatric advanced life support, and critical emergency medicine. Techniques and skills which can be taught include infant airway management, CPR, peripheral venous cannulation, PICC line insertion, needle thoracentesis and chest drain, intraosseous infusion, urethral catheterization, and lumbar puncture. The model has been designed to be fully interchangeable. All the parts are cost-effective and can be replaced quickly when required. The initial setup time is less than 5 minutes. This model is part of the AirSim X range, which provides realistic and durable training and comes with a 5-year warranty on the airway and 1-year warranty as a standard for all other parts. For more information or to speak to a product specialist, email info@truecorp.com or call 4428 3888 2714.
GlideScope Core, the most comprehensive and flexible airway visualization system for video laryngoscopy, bronchoscopy, and multimodal airway procedures. GlideScope Core is an all-in-one system offering immediate access to the tools you need to visualize the airway and tracheobronchial tree. Designed around a high-definition touchscreen monitor and comprehensive workstation, GlideScope Core delivers elevated visibility and improved workflow with both the 10-inch and 15-inch GlideScope Core monitors. Now you can see more and do more. With dual connection ports, GlideScope Core is the first airway visualization system to offer live multimodal imaging, picture-in-picture on GlideScope Core 10 and dual view on GlideScope Core 15. You can now view the airway via a GlideScope video laryngoscope and B-Flex single-use bronchoscope simultaneously, helping to navigate routine and difficult airways. Record, take photos, and annotate through one device. Display, play back, and export captured videos, images, and patient notes from the monitor's gallery. Completely redesigned based on user feedback, the comprehensive workstation features an adjustable arm for optimal monitor placement over your patient, putting the monitor and SpO2 and pulse rate reading in your direct line of sight. The cable organizer and convenient prep tray ensure easy access to the airway tools you need right when you need them. The GlideScope Core workstation adapts to your space and offers the flexibility you need to fully focus on your patient. GlideScope Core is compatible with GlideScope's extensive portfolio of angulated and Max-style video laryngoscope blades and B-Flex single-use bronchoscopes. GlideScope Core is always ready, with everything in reach. No more having to use multiple systems or vendors for video laryngoscopy and bronchoscopy or when utilizing the multimodal airway approach. Now, your airway visualization system does more by supporting bronchoscopy-assisted procedures in OR, ICU, and ED. From the brand you know and trust, GlideScope Core gives you the power to see more and do more.
The A-Scope 4-Rhino-Laryngo Endoscope is a flexible, high-quality, single-use rhino-laryngoscope. It is sterile and easy to use right out of the package. The A-Scope 4-Rhino-Laryngo comes in two configurations, Slim and Intervention. The Rhino-Laryngo Slim has a 300 mm long insertion cord with a diameter of 3 mm. It features two LED lights and a CMOS camera at the distal tip of the cord. The Rhino-Laryngo Interventions insertion cord is 350 mm long with a diameter of 5 mm. It features the same LED-assisted CMOS camera on the distal tip, but also offers a 2.2 mm working channel for passing tools and endoscopic accessories up to 2 mm in size. Additionally, the handle of the intervention has a suction button, suction connector, and working channel port, which allow for the installation of fluids and the insertion of endoscopic accessories like forceps and brushes. The intervention comes packaged with a luer lock introducer, which facilitates the introduction of forceps and other endoscopic accessories. Before using the A-Scope, visually inspect the pouch to ensure the seal is intact. Open the pouch carefully and remove protective elements from the handle and insertion cord. Check to make sure that there are no rough surfaces or sharp edges which may cause harm to the patient. Connect the A-Scope to the A-View by aligning the blue arrow on the white male connector into the corresponding blue female connector on the A-View. Press the power button on the top of the A-View once and verify that a live video image appears on the screen by focusing the distal end of the A-Scope towards an object. Carefully slide the control lever forward to confirm that the bending section of the cord operates fully and smoothly. If applicable, prepare suction equipment according to the supplier's manual and attach the suctioning tube to the suction connector. Press the suction button to check that suction is applied properly. Verify, as needed, that endoscopic accessories of appropriate size can be passed through the working channel without resistance. To begin a procedure with the A-Scope 4-Rhino-Laryngo, lubricate the insertion cord to the gray mark using a medical-grade lubricant. Take care not to get any lubricant on the tip of the camera. Holding the handle of the A-Scope in either hand and guiding the insertion cord with the other, advance the cord into the patient's nose following standard procedures. The control lever is used to flex and extend the tip of the A-Scope in the vertical plane. Moving the control lever distally will make the tip bend anteriorly, and moving it proximally will make the tip bend posteriorly. Rotating the handle controls horizontal movement. Fluids can be instilled through the working channel of the Rhino-Laryngo intervention by inserting a syringe into the working channel port at the top of the A-Scope. When using a luer lock syringe, make sure to utilize the included introducer. Insert the syringe completely into the working channel port or introducer before instilling fluids. If a suction system is connected, suction can be applied by pressing the suction button with the index finger. Make sure to not apply suction during the installation process, as this will direct the instilled fluids into the suction collection system. To expel fluid left in the channel, flush with 3 to 4 milliliters of air. When working with an endoscopic accessory, make sure to select one 2 millimeters or smaller and inspect the accessory closely before using it. If there are any irregularities in operation or appearance, replace it. Insert the accessory into the working channel port and advance it carefully through the working channel until it can be seen on the A-View monitor. After the procedure and before withdrawing the A-Scope, ensure the control lever is in the neutral position. Slowly withdraw the A-Scope, checking progress against the live image on the A-View. Remove the A-Scope, unplug the blue port on the A-View, and discard. As the A-Scope is a single-use device, It must be disposed of after use in accordance with local guidelines for collection of infected medical devices with electronic components. Do not soak, rinse, or sterilize this device, as these procedures may leave harmful residues or cause malfunctions. The design and material used are not compatible with conventional cleaning or sterilization procedures.
Alright, Steve, get ready. He's got good technique though, I have to say. Okay. Okay.
Uh-oh. It's good.
It's good.
Right.
Either way.
True Baby X represents the appearance, weight, size, and movement of a 5-month-old. The Pediatric Clinical Skills Training Model is ideal for anaesthetists, nurses, and other pediatric emergency medical professionals practicing directly observed practical skills, pediatric advanced life support, and critical emergency medicine. Techniques and skills which can be taught include infant airway management, CPR, peripheral venous cannulation, PICC line insertion, needle thoracentesis and chest drain, intraosseous infusion, urethral catheterization, and lumbar puncture. The model has been designed to be fully interchangeable. All the parts are cost-effective and can be replaced quickly when required. The initial setup time is less than 5 minutes. This model is part of the AirSim X range, which provides realistic and durable training and comes with a 5-year warranty on the airway and 1-year warranty as a standard for all other parts. For more information or to speak to a product specialist, email info@truecorp.com or call 4428 3888 2714.
Hi, I'm Kostas Kanaris. I'm a consultant in Paediatric Intensive Care Medicine at Cambridge University NHS Foundation Trust, and today I'm going to talk to you about stabilising a child with sepsis. The intention is to make you manage this patient from home by me giving you a number of clinical details and observations. So Charlotte is a 6-year-old girl born at 25 weeks. She has diplegic cerebral palsy, but is cognitively entirely normal and goes to mainstream schooling. She is still PEG fed due to some swallowing difficulties, and she presents to your emergency department having been brought in from home via ambulance following 24 hours of diarrhea, vomiting and a high-grade temperature as reported by the family. I would like you now to have a look at her initial sets of vitals. This is within minutes of her being brought into the emergency department, and the venous gas is down before any active management had been done, so pretty much from the get-go. And I would like you to write down what your initial steps would be. I'll give you 15 seconds to go through everything and think of a plan. So hopefully by now you will have spotted how high her heart rate is, how reasonably relatively low her blood pressure is in relation to her age. Remember, she's 6. How hypoxic she is. This is a child without any chronic lung disease or long-term lung issues despite her prematurity. She's very febrile and she's got a very low GCS with a prolonged capillary refill type. Her gas shows a significant metabolic acidosis and she's already hypoglycemic. Her potassium is also on the high side, as is her sodium. So hopefully by now you have decided to give her some fluid. You need to ascertain if the heart rate is sinus tachycardia or not, and we will go into how you do that in due course. And you would have put some oxygen on and got some access and start some antibiotics. So within 15 minutes of giving fluid, she received 40 mL per kilo in total of a balanced solution. Balanced solutions is the new research guidelines for managing children in shock, and you have to give them in 10 mL per kilo aliquots. You have made a dent in her heart rate, so it's no longer above 200. A very slight dent in improving her blood pressure. The oxygen improved her SATs. She's still very febrile. Her GCS is no better, but you notice that her gas is getting much worse. You've also given some dextrose to improve her blood sugar, but that's only managed to go up to 2.9. She's even more lactemic with a much higher base excess. So now you need to decide what your management plan is from home. So much like in your clinical lives, you now have to approach this patient systematically in an A, B, C, D, E fashion, and you will decide the trajectory that this patient takes depending on what you answer in the next 5 questions, which will be related to airway, breathing, circulation, disability, and exposure management. In order to join into the poll, which is anonymized, please scan this QR code using your mobile devices, or type in slido.com and use that code to get to the 5 questions that we will use for this session. Remember, these are anonymized, so no one will know what you have answered. You now have 1 minute to decide what your best airway plan is based on those choices. Okay, so let's break down the number of choices you have. So the first choice would be to intubate with propofol and succinylcholine using an uncuffed tube. This is probably the most wrong out of the 4 choices. Propofol is known to be a potent vasodilator, and you have a child already in warm shock that is vasodilated. So if you intubate using propofol, especially if you do not resuscitate the child adequately in advance, then there's every possibility that the child will arrest on induction. So use drugs that are the least cardiovascularly unstable in these situations. And really what the experts do more and more is use ketamine and rocuronium. Ketamine at 1 milligram per kilo dose, and rocuronium also at 1 milligram per kilo dose. The doses sound reasonably small, but that is because shock is its own anesthetic. So a child in a shocked state needs a lot less sedation in order to be adequately sedated and anesthetized to be paralyzed in preparation for intubation. Okay. The second choice, the choice of paralysis, is succinylcholine on the first answer. Now, one of the known side effects of succinylcholine is causing a hyperkalemic surge. This child clearly has sepsis. We haven't clarified the source of the sepsis yet. Therefore, has a degree of probably acute kidney injury already. Succinylcholine administration to a child with a potassium of 5.8, which is what the latest gas has shown in this child, is likely to push this child into dangerous hyperkalemic levels and may precipitate an arrhythmic or a VF arrest. The next choice in the first answer is an uncuffed tube. Now, this child has sepsis, and we know for a fact that children with sepsis get a lot of vascular leak, a lot of capillary leak, and therefore are at increased chance of having pulmonary edema. This makes ventilation harder. So your best choice of tube would be a cuffed tube. If you use an uncuffed tube first, it is likely that you will need much higher ventilatory pressures and might need to change the tube again, and that in itself is a patient safety issue, because you have an unstable child which is hard to ventilate, is likely to need inotropes, and you want to change the tube to make things better, and changing that tube is a high risk procedure. So make your first tube the best tube. The second choice is less wrong. We've gone through why propofol and sucks are wrong choices, but the cuff tube would be correct. The third choice is partly correct. So we would use ketamine and rocuronium, which have a very narrow side effect profile and are more cardiovascularly stable agents to use in very sick children, but the uncuffed tube would be wrong. And similarly, the final choice obviously is the correct one. So you have another minute to decide the breathing plan. Those who have not done any critical care or any retrieval before may be slightly disadvantaged, but it is important to understand the principles behind what we do, why we do, and why we do it in very sick children. Okay, so hopefully by now you would have made your choice, and I can tell you the correct answer would be the first answer, and I will justify it. So we know we have a child with sepsis that will need lots of fluid and is likely to have pulmonary edema. We need good oxygenation in order to be able to stabilize the child. Hypercarbia is secondary. No child dies
from becoming hypercarbic, not least if they're invasively ventilated. So oxygenation is our priority. Oxygenation is most efficient if the PEEP is high, not least if you have lungs that are affected by ARDS, which are full of fluid. So you need a high PEEP to cause the alveoli to be more stretched. This makes the alveolar membrane thinner, which then makes the oxygen transfer from the transalveolar membrane into the vasculature more efficient. Similarly, you need a high inspiratory time. Most of the oxygenation happens during the inspiration. Therefore, the longer you inspire, the longer your alveoli are stretched, therefore the more efficient your oxygenation is. Obviously, this child is very hypoxic already, which in itself is highly suggestive of sepsis. Therefore, you would start on a FiO2 of 100% until you get a gauge of how much oxygen you need. If you go into the realms of hyperoxia, it's equally important to back off and titrate the oxygen levels, because too much oxygen is also bad in terms of acute lung injury. This child is septic, that may or may not have an acute abdomen as a cause of its sepsis. It might have ileus as well, which would cause abdominal distension. That would mean that there's a degree of diaphragmatic splinting coming from the intra-abdominal cavity as it is. So pressures of 15 over 5 are not going to cut the mustard. You're not going to get enough tidal volumes to push that diaphragm down enough to give you enough ventilatory requirements and enough tidal volumes that you need for effective ventilation. Therefore, going with a high PIP and a high PEEP strategy is probably what's initially needed for these patients. The rest rate, almost always, with the exception of children with severe bronchospasm or air trapping, needs to be matched to the age, therefore is 18, and the eye time needs to be on the higher side if you're that hypoxic. So the key in this situation is to know the illness, to beat the illness. The more you see these children and the more you manage very sick children with ARDS, the more you will be able to plan ahead in terms of what problems is this illness going to throw at me, at the patient, and how do I beat it. So pulmonary edema is a big problem in children with ARDS. Therefore, we need a high PEEP strategy and a high eye time strategy in the beginning. Okay, so this now brings us to circulation. You have 1 minute to answer the following question to see what your plan is in terms of managing this child's circulation. Okay, so your time is up. So I can tell you the best answer out of that lot is the second answer. So I will break it down. So initially, we need to give more fluid. Now, the new research guidelines state that we need to give the fluid in 10 mL per kilo aliquots, and it's important to do dynamic monitoring whilst we give the fluid. So what I mean by that is we don't delegate the giving of the fluid to a member of usually the nursing team, and we walk away whilst we do other things. We either take ownership and give that 10 mL per kilo whilst watching at what the heart rate and blood pressure are doing in real time, and you need to have your blood pressure cuff cycling every 1 minute at this junction,
to get real-time feedback unless you have an arterial line in situ. And then if the child needs more because there's been a good response and a good rise in blood pressure or a good drop in heart rate, then you know in real terms whether what you're doing is working or not. Now, there's also been a shift by the research guideline from using saline, not least because the high chloride content in saline will render this child hyperchloremic, thereby making the acidosis even worse. And we know for a fact that inotropes do not work very well on the myocardium in a very acidotic state. So ideally the pH needs to be more than 7, and on a child with a pH of 6.7 already or 6.8, giving chloride is a bad idea. So you need to give a balanced solution, which is Plasma-Lyte or Hartmann's. Some might say, why don't we, Hartmann's and Plasma-Lyte have potassium in, and this child is hyperkalemic, is that safe to do? The answer is absolutely yes, because both Plasma-Lyte and Hartmann's are base in nature, so they can use as a buffer and they can push the pH up. We know acidotic states make hyperkalemia worse, whereas bases make hyperkalemia better because they can draw potassium from the extracellular space to the intracellular space. And also the content of potassium in Plasma-Lyte and Hartmann's is much less than that of the potassium concentration in your hyperkalemic patient. So you can never make a solution more concentrated by giving a more dilute solution. So it's entirely safe to bolus Plasma-Lyte and Hartmann's in a child with hyperkalemia. Have a low threshold of thinking and giving blood products. Now, again, this is where knowing the illness to beat the illness comes into play. This child is septic. They will have a coagulopathy, so you are likely to need FFP and blood in order to resuscitate them. You're going to give lots of fluid, which then would hemodilute them. So you need to target the hemoglobin to be ideally more than 100 to improve the oxygen carrying capacity of this child as well. So make any volume you give as useful as you can. So have a low threshold about giving blood and blood products. Now, we also know that this child is in warm shock. Now, I would say at this junction that don't get too hung up about inotropic choices. If you're stuck and don't know what to give, adrenaline is almost always a right first choice. In some parts of the UK, dopamine is still preferred. The evidence shift is slightly going away from dopamine as first choice inotrope, but if that is what you are used to, that's what you need to use until you adopt the more up-to-date evidence. Some inotrope and an inotrope is better than no inotrope at all. In warm shock, we know that gold standard for now is using noradrenaline first, which is a strong vasopressor, then using vasopressin, and if we need a third inotrope, we automatically trigger the need for hydrocortisone because it is then defined as catecholamine-resistant sepsis, and we know this already because this child is already hypoglycemic, so therefore they've lost the ability to have a stress response per se, and that's always a red flag in septic children. So we will certainly add hydrocortisone after we pass the 2 inotrope mark, and then if you need a third inotrope, then probably adrenaline would be the third good choice. Okay, but don't get too hung up on the nuances of inotropes. If you're stuck, adrenaline is almost always a first choice. And the next slide I will show you will hopefully help you consolidate this notion. Now, this is a useful slide. I will not dwell too much on it. I suggest you screenshot it to refer to it back. So initially, depending on what you do locally, you should start with adrenaline or dopamine, depending what you use locally. What I have said earlier is that some places within the UK still use dopamine as first line. That's fine as long as you use either or. Don't forget that lots of children can present in warm shock, in which case you need noradrenaline as first line and vasopressin as second line. Aim for your hemoglobin to be more than 100, so have a low threshold of thinking of blood products. If you have reached the 2 inotrope mark, don't forget to add hydrocortisone, and then the hidden inotrope is ionized calcium. So ionized calcium has a double whammy. It's doubly useful. Firstly, it's vital in the coagulation cascade. So if your ionized calcium, which is the useful calcium, is deplete, then your coagulation is going to be even worse. But also your myocardium will not work very well without an ionized calcium of more than 1.1-ish. So make sure you give calcium gluconate or calcium chloride, whichever you have, and keep rechecking that ionized calcium that comes up on your gas machine. Okay, this is different to the lab-based calcium, which isn't very useful in this situation. So by now you have already given a lot of volume, more than 120 mL per kilo, combination of balanced solutions and blood products. This child is already on 2 inotropes and hydrocortisone, and you notice on the X-ray that you've got dilated loops of bowel showing on the lower aspect of the chest X-ray, and you realize that this child's abdomen is quite tense. Your colleagues say it's probably septic ileus, but you're not sure. She's obviously very unstable. Would you CT her abdomen? Is the question. And how would you sedate her? So let's break down the various answers. So my approach would be, obviously this child is very septic and we need to do the basic neuroprotective measures, because with sepsis comes multi-organ system failure. She's already got a low GCS, so obviously we need to try and protect the brain as well as we can by doing the basics right, keeping bringing the temperature down to less than 37. The hot spot is between 36 and 37 degrees, or the sweet spot, I should say. Have her at a slightly elevated angle of 35 to 40 degrees. Try and keep the sugar normal. Try and have a high normal blood pressure if possible, and try and keep the CO2 as normal carbic as possible, ideally between 4.5 and 4.8 as a PCO2. So those are the basic measures of neuroprotection. We talked about propofol earlier. It causes potent vasodilation, and in children, especially shocked children, it has a much higher association with propofol infusion syndrome. So I would definitely avoid it for a long-term sedation of a very septic, unstable child. And most colleagues would use morphine and midazolam for sedation and analgesia. And if we are thinking an acute abdomen, morphine would be a reasonably good analgesic to address that, whereas propofol on its own wouldn't. The question is, do we CT before we transfer her to our intensive care unit or our PICU? Could be in or external hospital ITU. And the answer is, hey, I probably wouldn't CT her. So it is likely, with a rising lactate despite aggressive intervention, that we have a time-critical abdomen in our hands. And like any time-critical transfers, time is gut, time is survival, time is morbidity, time is brain. So we need to have ideally thought about leaving our unit and going to a place where they can immediately operate on her and then look after her within 60 minutes of arrival to our hospital. This is obviously easier said than done, but an abdomen CT would just delay the process. What this child needs is source control and a surgeon. She's likely to have necrotic gut, and therefore she needs to go to somewhere where they can operate on her. She is 6, so even if you don't have on-site PICU, many surgeons would be able to operate on her because she's bigger in size, and what she needs really is a scalpel and to have a look into her abdomen if she's made stable enough. So in this case, I would not CT her abdomen and I would try and mobilize. So in terms of the correct answer, I would choose the third answer as the correct answer in this situation. So what is your best exposure plan? I'll give you half the time because it's an easy question to decide. Okay, so if we're thinking this is an acute abdomen, my best choice of antibiotic would probably be a cephalosporin and some metronidazole to cover for anaerobes. If we were thinking along the lines of toxic shock syndrome, for example, in a teenager who's retained a tampon, or a child following burns injury, then we would need to add clindamycin in to mop up all those toxins. And if we couldn't get control of cardiovascular stability, then IVIG, given slowly, may have a role to play in managing children with toxic shock. But given that this is likely to be an acute surgical pathology, we would need to cover with KEF and MET. So this is what we saw when we exposed the patient about 30 minutes in to examine the abdomen, when we realized it might be an acute abdominal cause of the sepsis. So this shows a strangulated PEG site with lots of necrotic gut. So unless you expose your patient fully to examine, especially the critically ill child, you will lose lots of visual cues to reach the right diagnosis. So if this had been picked up earlier, then mobilization and time to theatre would have been probably much faster, and then the outcome would likely to be better too. So never forget to expose your patient fully when you're examining them. So a quick summary of our management thus far. We agreed that we need a CAFT tube to ventilate efficiently. We're avoiding propofol and thiopentone, both of which are potent vasodilators because the child is shocked and they're likely to send them into an arrest if we use them for induction. And we will ensure that we resuscitate the patient adequately by using fluid and also anatropes running through an IO or peripherally prior to intubation. We are going to use a high PEEP strategy, starting with a PEEP of 10 and titrating upwards to improve oxygenation. Similarly, we opt for a long I time, starting with an I time of 1.2 and titrating up to 1.5 if needed. And since we're dealing with an acute abdomen with lots of air within the gut, we may need a manual abdominal air decompression from the top or from the bottom to try and remove some air from the intra-abdominal cavity to make the diaphragm splint less and make our ventilation easier. In terms of circulation, we are in warm shock, so the gold standard would be using noradrenaline first, vasopressing second, and if we need a third trope, we can use adrenaline. Once we reach the 2 inotrope mark, we will introduce some hydrocortisone, and never forget your calcium boluses. If you need volume, make it useful volume in the form of blood products, and don't make it harmful volume in the form of saline. So prefer your balanced solutions. If we're thinking this is a time critical abdomen, then there's no time for CT. What this child needs is a surgeon. So you don't need to CT. Make sure the child is adequately sedated and paralyzed and analgesed, and mobilize ASAP. And first explore if the surgery can be done in your own hospital, because that is by far the fastest way to fix the gut. And obviously, in terms of antibiotics, KEF and MET would be the gold choice, gold standard in this situation. So what are my top tips in terms of stabilizing a child with sepsis and mobilizing quickly? Firstly, always remember to fully expose the patient for examination, as you tend to miss lots of visual cues, whether this is an abnormal mark in cases of late diagnosis of non-accidental injury or acute surgical abdomen, or a rash that might point towards meningococcal disease. If in truly time-critical cases, such as trauma or acute abdomens or hyperammonemias and metabolic disorders, don't wait around to do a central line on an art line. No one dies by not having an arterial line or a central line. You can stick an IO in, you can have the blood pressure cuff cycling on 1 or 2 minute cycles, and that gives you more than enough information to do a safe transfer. If you're in shock, make sure you have some dilute adrenaline with you to use. So use the rhesus dose of adrenaline and dilute it in 10 mL, and then you can use it as a push in 1 ml aliquot, so essentially 10% of the rhesus dose, and that can be used as a inotrope and a chronotrope to push the heart rate up if the child is peri-arrest. Source control is key, so in cases of a retained tampon, in children with toxic shock or dead gut, then the key is to remove the source of infection. So time to theatre is crucial. The faster you get the child to theatre, the better the outcomes. But you can't learn all these on the job purely, because they're not common scenarios. So make sure you've practiced them in simulated scenarios in advance. Obviously, these are very stressful scenarios, so make sure you debrief after every time you encounter this at work, regardless of how well or bad you felt the situation went. And I would say that probably the most important intervention is to keep the family in the loop, because remember, this is a bad day at the office for you, but this is almost certainly the worst day in that family's life. So they will not remember what inotrope you used or what fluid you chose, but they will remember how you made them feel and how much in the loop you kept them during the resuscitation process. Thank you for listening to me today. If you have any questions, you can ask me the questions on Twitter, and these are my references I use for this talk. Thank you very much.
Hi everyone, welcome back. I hope you had a chance to get some food, refresh a little bit, and then join Costas's talk. Thank you for engaging with it. We're using the Slido. Hope you find it interactive and enjoyable. Certainly lots of learning involved. Not that many questions coming through in the chat. We have a few within the panel. So I suppose the first thing we were going to do was maybe just, Costas, you talked about sort of high PEEP strategy. I'm wondering whether you could maybe elaborate a little bit on that and just give us a bit more information on how you would actually approach and use that in a case, real life case.
So obviously, because of the degree of pulmonary edema and ARDS you get with very septic children, you would usually need a high PEEP strategy. What maybe I should clarify, and thanks to Chris for bringing this to my attention, is that you start with the middle of the range PEEP, so not too low and not too high. Don't go straight for 10. I'd start usually around 8, and then slowly crank it up depending on how your oxygenation is doing and how your blood pressure is doing. And you need to try and balance the two, because the higher the PEEP, the lower the blood pressure, because it really does affect your venous return and your cardiac output. So if you go straight in with a high PEEP, you might cause it quite an acute hypotensive sort of crisis. So I'd start around 8, have the inotrope running, and then slowly crank things up. It's not unusual for an experienced intensivist to crank it up as high as 14 or to 16 on retrieval to try and get them alive to a center or an ECMO center if that's what they need, basically. So don't go all guns blazing. Start middle of the line around 8, and then slowly go up, trying to balance blood pressure and adequate ventilation.
Thanks, Costas. And talking about, I suppose next thing was fluids. So we'll just see a comment come in the chat about use of Hartmann's, whether to use that or not, and obviously you talked a little bit about fluid choice. Even within the panel, I think there's a bit of sort of variation in thoughts on this. So Costas, Peter, maybe ask you just to comment about fluid choices in these scenarios.
So I'll start because there's also a relevant question on the feed by my friend Mohammed Iqbal. The research guidelines have changed. They've not said don't use saline, but they said you can use balanced solution. That's an important transition. There's the question on the group says, isn't Hartmann's, also known as Ringer's lactate, detrimental if you've got a lactemia? The answer is no, because the lactate component of the solution essentially gets metabolized to a base. So you're giving a base to an acidic child. So it does not get metabolized to lactic acid. It gets metabolized to bicarb. So if you've got an acidotic child, it's far superior to saline physiologically, which would then precipitate a hyperchloremic acidosis further, and all the badness that comes with that. Ultimately, it depends on the cause of your shock. In traumatic cases, you need to replace what is lost. You need to replace blood and blood products. In septic shock, you're often coagulopathic, you're often anemic for a number of reasons, including dilutional. So again, you need to be targeting an HB more than 100. So I like using blood products, but it's unrealistic for them to be the first port of call. What you can do is not make the acidosis worse by giving chloride-rich solution, which is what I'm doing. The other question we often have is, balanced solutions have potassium in them. It doesn't matter. The potassium concentration is much lower than that of a hyperkalemic patient. So you can never make a solution more concentrated if you give a more dilute solution. Equally, if you give saline, you make them acidotic. Acidosis drives potassium into the extracellular space, thereby rendering them more hyperkalemic. Whereas if you give an alkali solution, you have the opposite effect and you shift potassium intracellularly. So it's superior physiologically than saline, I would say. There's a paper we can share, actually, that's recently been published in archives about that very conundrum.
Okay, and we'll share that in the discussion. Peter, I can see you raring to go.
Yeah, I mean, I just think, I would dispute anything that anybody tells me, right? So I think you have to keep an open mind to most things. I don't necessarily buy that saline will cause an acidemia in a patient who's already acidemic, to be clear. What we do know is that a high lactate is associated with mortality and it kills people. What we do know is that if you resuscitate people with saline, they might still be acidemic, but the cause of the acidemia will transition from a lactic acidemia to a chloride acidemia. We know that clearing that lactate is associated with improved survival. Some papers will come out and tell you that the chloride causing an acidemia results in increased kidney injury and renal replacement therapy. For every paper that you show me that says that, I will show you a bigger one that says it doesn't. And the reason I bring that up is because I don't think necessarily we have all the answers, and we're very quick sometimes to move to something because it's the new best thing or everyone thinks it's great. I'm not necessarily saying that it's right or wrong. I'm just saying that both are absolutely possible options and both are reasonable. So I won't tell you not to use it. There aren't many studies out there, certainly none that I'm aware of, that will show how good Plasmolite is at clearing lactate in the same way that it has been done for saline in the past. I would also say that saline as a recipe has changed and evolved over hundreds of years. I don't know very many industries that they'll take something that's been perfected and change it to something else without a good, strong evidence base. And we have done similar things like this in the past with albumin or with Gelifusion, and then we subsequently had to come back and retract and go back to saline. Now, the physiology behind Plasmolite, I totally buy into that as a concept. I totally buy into that. I'm very happy to use it. All I'm saying is that I'm not quite as negative about saline as other people might be, and I'm happy for people to use either personally.
Thanks, Peter. And I think it is important. We don't have all the answers, and there's no right or wrong answer sometimes in medicine, and it is about keeping abreast of evidence and reflecting it and changing practice appropriately.
Apart from saline, which is the wrong answer.
I was trying to be diplomatic, Costas. We'll move on again. So we talked about, I suppose you've got this case, you high lactic acidosis, sick child, and the question, I suppose, around time critical intervention or surgical intervention, and whether you delay that for CT or imaging. Any thoughts or any sort of a guidance or advice around that, Kostas?
Now, again, this depends on the patient, and Chris and I disagree on whether we would CT this patient or not before theatre. Again, it depends on the individual setup of your hospital, whether you have surgery on site, whether you have pediatric surgery on site, whether your surgeons, if they're adult surgeons, if they're happy to operate on a 6-year-old or not. So all those dynamics we can't account for. But ultimately, if you need to mobilize this child, he needs to go to a surgeon as soon as possible to try and stop the degree of gut necrosis you're getting, because that's the culprit. You need source control. A CT is not going to fix that. So in a child who's increasingly lactemic, despite aggressive intervention, and you have primary gut surgical pathology, I would label that as a time-critical transfer. You need to go into theatre. You need to get a scalpel on that patient ASAP, because the longer you leave it, the more the dead gut you have, the poorer the prognosis. That's my take. I think I'll pass it on to Chris, who has a slightly different approach.
I think we have a very similar view. We want to get this child to theatre and the surgeon's knife on skin as quick as possible. For me, I think actually having that CT is the quickest way to persuade the surgeon to do that. And I've had similar cases where we have, again, this child might be too sick for the local team to want to move away from theatres down to CT, waiting for the retrieval team to go out. But in the past, I have run this child out to the ambulance via the CT scanner, maybe adding 10 minutes on to the journey. Haven't hung about and waited for the CT report, have headed down the road towards Belfast. On the way down, we've got a call from the surgeon, don't go to the ICU, come straight to theatre. And that has actually been a quicker way to get that child knife to skin. Rather than arriving onto the ICU, moving over off the transport equipment onto the ICU bed, surgeons come and assessing, we'll need a CT, back out down to CT, up and down, and then ultimately a decision for surgery, waiting for that to be reported. So I think we want to get to the same thing, definitely, but just from some few experiences I've had in the past, I've found actually that CT is a quicker way to twist the surgeon's arm in the operating.
Thanks. And we probably have 1 minute left just to have a quick discussion. So there's questions coming through. And DGH, do we time critical transfer using the district general hospital staff themselves, or do we wait for a retrieval team in this situation, knowing the child that it may be time critical?
So time critical implies you need to crack on. Yeah. So time critical transfers in children are trauma, acute abdomens, hyperammonemias, or acute metabolic decompensation. Those are the situations where you cannot wait for the pediatric critical care retrieval team to come and save your bacon, unless it's based within your own hospital or based 5 minutes away, and they'll come and do a faster job than you. Okay. They also pediatric critical care retrieval are often out with a different patient. So you cannot afford these children to be in a DGH without definitive management, which is usually surgical, in order to be able to move. Now, I understand the anxiety, and this is why we need these courses and you need hands-on experience, that the more, in the UK at least, you centralize care, the more the skill set is taken away from the teams, and that's a problem. So there's a valid argument to say, well, you don't let us look after well enough kids, why do we have to do this? But in terms of commissioning and in terms from time of presentation to theatre, by far the fastest time to theatre is if the local team mobilizes, unless they're based in the same hospital as a transport team, in which case they'll come and do it for you. And that's the reality of the matter.
Thanks, Kostas. And you'll be glad to hear that Peter in our group chat has said that he actually agrees with you on this one. So it's nice to end on a note with everybody in agreement. So at that point, I'm going to hand over to Chris to introduce the next talk. Thanks.
Okay, thanks. So Peter's actually our next speaker. He's going to be talking on something we're probably all seeing a lot of at the moment, bronchiolitis.
Good afternoon, everyone. My name is Peter. I'm one of the consultant paediatric intensivists from Glasgow. Thanks to Chris and the organisers for inviting me to give a talk about bronchiolitis. Before I start, I should probably give a bit of a disclaimer that I'm a bit of a controversial character, apparently. You know, I'm a strong believer in challenging the norm, challenging dogma. I like to put the cat amongst the pigeons. And that's because, you know, to keep with the cat analogies, I think there are many ways to skin a cat. I think part of the strength of healthcare and the NHS in general is that we recognise that flexibility is important, adaptability is important. There's loads of different ways to do things, rarely a right or wrong answer. And I think it's important that we have those sorts of conversations, discussions about how to do things and what the options are. And my way of doing things might be different to yours or to others, and a lot of the time that's okay. I can only talk from my own perspective and a little bit about the evidence base. But how controversial can I be about bronchiolitis, right? Well, let's see how we go. So bronchiolitis, it is everybody's bread and butter in the world of paediatrics. And from a paediatric intensivist's point of view, actually it's part of our bread and butter as well. We see this every year. It's one of the most common viral lower respiratory tract infections that we see in children, you know, under 18 months, 2 years of age. And the vast majority don't need to come as far as ICU, but we do see it a lot. And that's why it's important that we talk about it. How big an issue is it in terms of our systems? How does it affect us? Well, bronchiolitis is responsible for around 1 in 6 of all UK hospital admissions within paediatrics. Worldwide, it's the second largest cause of death in children under a year of age. Within the UK, approximately 30,000 babies and children under 5 are estimated to be admitted to hospital because of RSV, which is, you know, the most common virus associated with bronchiolitis. But we do know that there are others, such as human metapneumovirus, enterovirus, rhinovirus, and others. That has a knock-on effect in terms of PICU admissions, around 2,000 a year approximately. And also children do die from bronchiolitis. And if you look at the data, it ranges between sources between, you know, 30 children to 90 children even per year may die from bronchiolitis. So it is a really important clinical condition, and every year it causes a lot of strain and stress within our healthcare services and within ICU as well. The elephant in the room here is about COVID and how that has impacted upon us, and it certainly has. And we all know that last year we didn't see much bronchiolitis. It was a relatively quiet winter for us, but things have changed. And the reason that we didn't see as much bronchiolitis is because of hand hygiene and because of social restrictions. You know, there wasn't the same mixing of people as there was previously. Now we're in the circumstance where we've got schools reopening, cafes, bars, shops, all of those things are opening, and people are coming into contact with each other again. And now we're seeing a real change in terms of our patient mix. So we wouldn't expect necessarily to see a spike in bronchiolitis within PICU just yet. Normally that's a little bit later. But you can see from this data from Australia that they're getting spikes happening at times of the year that they wouldn't normally. You know, we all look towards Australia to sort of anticipate what type of bronchiolitic season we're going to have. And the data from Australia is certainly pointing towards a spike out of season. Is that something that we think we are seeing? Anecdotally, absolutely. The past few weeks have been super busy in terms of bronchiolitic presentations, and we wouldn't expect to be seeing that for at least another 3 weeks or so. In and around the time of this conference, that's around the time that we'd be starting to see bronchiolitics. So it's a bit early for us. And if you look at this graph from Public Health Wales, again, this is looking at the recorded RSV incidence year on year with a different coloured bar for each year. You can quite clearly see that to the right of this graph, 2020-2021 season, we are seeing a spike that is out of keeping with what we would normally see for this time of year. So there is data that backs up what we feel we are seeing. So that is causing a lot of anxiety within healthcare, that we already feel we're in the peak of season, yet we're also anticipating that things are going to get worse in coming weeks. So that is a bit worrying. So bronchiolitis, it is a huge pressure on us, but in terms of the patient, what does it look like? Well, there's a range of symptoms, and it can start with upper respiratory tract symptoms like coryzal symptoms, your runny nose, lots of nasal congestion that might lead to poor feeding, and then that can progress into coughs and wheezing, low-grade temperatures. So it progresses, and it's just, the condition is one of progression and changes over time. But it's important to note that these symptoms can also be features of other clinical conditions as well. So it's really important that you keep a very broad differential open within your mind when you see somebody that you think might have bronchiolitis. So when we talk about the pattern of disease, the pattern of presentation, as I said, commonly it starts with upper respiratory tract symptoms for the first few days, and then it progresses into lower respiratory tract symptoms as your bronchioles get more edematous and you get more secretions, and then you start getting more work of breathing, more wheeze, heterogeneous changes within your lung fields, and usually things get worse between sort of day 3, day 5. And it's not until day 10 to 14 that you start to see sort of resolution of symptoms. Now that's really important, because what that should say to you is that if you have a patient who is approaching 10 days who's not clinically improving, you need to start thinking to yourself, actually, is something else going on here? And I've had that recently where a patient was referred down from the ward who wasn't improving. And actually it might be that their underlying cardiac condition has a bigger role to play than was previously thought. It's also important because sometimes as a retrieval team, you might get a phone call to say, listen, we're quite worried about this patient and they're only day 1 of their illness. And that is an important consideration, because you would then expect them to potentially get worse. In Scotland, that might mean that we need to think about where that patient is, because if they're on an island with limited provisions for paediatric care, then we might need to think about moving that patient earlier rather than later. So knowing the pattern and the progression of symptoms within bronchiolitis is super important. So in terms of the management, the treatment of bronchiolitis, what do we do, or what are the key considerations? Well, a lot of the time we do have to practice the art of actively doing nothing. It's about supportive care, it's about good quality nursing, trying to sit on your hands and not over-egg it a little bit too much. But there are important concepts. So, thumbs up for hydration. Hydration is really important. So what might that look like? Well, if we think somebody is getting behind in their hydration or is clinically dry, then we can feed them via an NG tube, and that might be bolus feeds initially, 1 hourly, 2 hourly, 3 hourly. It might be that we move them towards continuous feeds, or it might be that we don't think they'll tolerate feeds at all and they need to be kept nil by mouth and put on IV fluids. The amount of IV fluids I'll talk a little bit about later. But hydration is important, as is oxygenation. So we need to make sure that we are able to provide oxygen to these patients to maintain their saturations. What saturation should we target? Well, again, that depends what your guidelines say. You might have a local protocol or guideline for that. NICE guidelines would say above 90% or above 92%, depending on whether you are over 6 weeks of age or under 6 weeks of age. And you have a number of options on how you deliver that in terms of wafting oxygen or nasal cannula oxygen or high flow oxygen or CPAP, or progressing to more invasive modes of treatment. In terms of broad brushstrokes with bronchiolitis, when they get referred to me as an intensivist, usually it's following down either one of 2 streams. It's either those who've become increasingly apneic, or it's those who are becoming progressively distressed towards respiratory failure in terms of work of breathing and desaturations and bradycardia or lethargy. So there is a role for a pokey finger. There are no RCTs that have been done about this yet. I don't know if there ever will be. But if apneas are a bit of an issue, then people who work in paediatrics will know, sometimes you give them a gentle prod and they remember to start breathing again. That is obviously not a long-term solution, and if apneas are a continuous issue or a progressive issue, then they do need consideration of escalation in treatment. So you've decided you need to escalate treatment. Well, what kind of therapies might you think about? What might that look like? So let's think about nebulizers. So we have thought before in the past about salbutamol, ipratropium, adrenaline, saline, hypertonic saline. Essentially, there isn't evidence for nebulizers within bronchiolitis. So the guidelines, the NICE guidelines, certainly do not recommend their routine use. The same goes for steroids, not recommended. And then in terms of caffeine, we all know that it's used in neonates for apneas of prematurity and those under 32 weeks or so. And there is no evidence for its use in apneas associated with bronchiolitis. So although it might help us at 3 in the morning or whatever time you are reviewing these patients, not so much for the patient themselves. The other consideration is nasal suctioning. Now, this picture in the bottom right-hand corner, I don't know how you guys feel about it, but to me, I have never seen a child that happy when they're about to have their nose suctioned, so that's a bit worrying. But anyway, there is no evidence for routine nasal suctioning, but it should be considered in patients with apnea or patients with difficulty feeding. Certainly in intensive care, it's something I advocate for. But routinely, there's not a lot of evidence for any of these things, and they're not recommended. So, how helpful have I been? We've presented the case or the scenario of bronchiolitis. We've said the need to escalate in terms of therapies and treatments. And then I've gone through a list of things and told you not to do them. So that's super helpful, right? Well, I guess we need to go back to think about why, first of all, why do they need an escalation in therapy? What's the thought process here? And I think that's super important to put things into context. So sometimes we get a phone call from a district general hospital or from an island or from wherever saying, I'm worried about this child because I think they're tiring or I think they're getting tired. Now, I personally do not know what that means, and I struggle a little bit with that because language is important. And I think, it's like working in a district general hospital where they ask you to review a patient because a patient is lamenting. It's a phrase that I'm not used to. A year later, I'm still not going to know what lamenting actually means. So it's really important that we put these terms into context. Like, what do you mean when you say that? Is it grunting? That's worrying. Is it increasing apneas? That's worrying. Is it desaturations despite oxygen? Worrying. Are they tachypneic? Are they tachycardic? What else is going on? Head bobbing. What we need is a bit of a picture. Now, sometimes it's a case of they seem okay, but they're not progressing. I just have a bad gut feeling about it. And that's okay too, because we can discuss that. That's absolutely fine. And having gut feelings about patients is really important because there is an art to all of this as well. So I think having a discussion around that is really, really useful. It is worth noting that a patient can be tachypneic for days. A child can have a respiratory rate in the 80s for days and not have any issues. But there is a difference between a patient who's sitting up tachypneic but interacting quite nicely with you compared to a child who's really struggling. And there is a difference between the two. Recently, I've been video called from an island to look at a patient directly because it's really difficult on the end of the phone to make those judgment calls whenever you can't see the patient. And on a video call with the patient, I was able to see that they were sitting up on their mum's knee. They definitely had subcostal recession and intercostal recession, but they were bright, they were looking around them. When somebody tried to put an oxygen mask towards them, they swung a left hook and nearly took them out. So that patient was definitely somebody that wasn't going to need intubation and ventilation at that moment in time, but equally they were definitely somebody that would need moved off an island to a safer place of care. So that's really useful. So think about what you mean, or try to put in terms what you mean, because it's quite difficult as a retrievalist trying to ascertain where the concerns are. If you think a child clinically has respiratory failure and you genuinely think that this child needs to be escalated in terms of intubation and ventilation, fair enough, absolutely. You're there at the bed space, you know better, you're at the bed space, you're looking at them. I don't need a gas to prove to me that you think that they need that. If you feel that they clinically are in respiratory failure, I'll support you in that. A gas won't change my mind, and I'm not going to tell you not to escalate treatment based on those numbers. You know, I'm more interested in the patient than the numbers. So what can you escalate to? Well, things to think about are high flow oxygen or CPAP, depending on what's available to you, and that would be different depending on where you work. So high flow, it's humidified, which I think is one of its, you know, biggest benefits, because if you keep these secretions loose and easy to suction or cough out, I think that's really powerful. I think if they get dry and crusty and sticky, then that's much more of a bigger issue. So I like the humidity from high flow. It does overcome a bit of dead space because it's fire and oxygen in under a bit of, you know, higher flow, obviously. And it theoretically is providing a little bit of PEEP as well. Not much, but a little bit. So I can see the benefit on that theoretically. And I personally have seen it work. If you're able to use CPAP, whether that's bubble CPAP, mask CPAP, non-invasive ventilation of some description, then that is worth a go as well, as long as it's tolerated and you can get a good seal and the baby isn't continually opening their mouth and not, you know, it might not work that well. But both, if you have them available, you know, they are worth a try. That will be different in each place, but I would be supportive of that as a escalation strategy. But what does the evidence say? Most of you will know about the sheer number of trials that there are looking at oxygen, high flow oxygen, CPAP, and actually you probably all have slightly different interpretations of them, and that's fine. You know, we all take away different sort of take-home messages. If we look at the Capriates study, first of all, that looks at high flow oxygen versus standard oxygen, what they were looking at was 1 litre per kilo of high flow in over 200 patients, with the end point being the time to wean off oxygen. Now, there wasn't a significant difference between the high flow group and the standard oxygen group, but what they did report was that less children in the flow group needed to progress to more invasive intensive support. So that says to me that actually maybe there is a benefit here of high flow, and they only used 1 litre per kilo, so not even that much. When you then look at the Tremontian studies, Tremontian 1, Tremontian 2, Tremontian 1 was a non-inferiority trial that was trying to again evaluate 2 litres per kilo of flow, and this time against CPAP in over 140 infants, with their primary endpoint being percentage failure of treatment within 24 hours of randomisation. So not powered to show things like the need for intubation or ventilation, PICU, things like that. Now, interestingly, their take-home message at the publication was the effectiveness of high flow was not equivalent to CPAP, but actually the confidence intervals basically left you unable to conclude non-inferiority within those two arms. They also performed a superiority analysis that suggested a relative risk of success with CPAP. But what's very interesting about that is that those in the CPAP group who needed rescued, 82% of them were rescued with high flow. So to me, there's still a few questions that come from that study that aren't necessarily answered. Tremontian 2, it compares 3 litres per kilo of flow with 2 litres per kilo of flow, essentially looking at percentage treatment failure within 48 hours, and found that having 3 litres per kilo of flow did not reduce the risk of treatment failure. So no real perceived benefit from that. And that's why most places will start with 2 litres per kilo of flow. Sometimes a retrieval team might ask you to put it up to 3 because it will buy you time to activate people, to get them in, to consider what you're going to do as next steps. Maybe by that stage it has had a beneficial effect, but if it hasn't, you might have hopefully bought yourself some time to get the team in and be prepared. Now, the other two studies within this slide, in terms of the CSER study and the Belfast study, they're slightly smaller studies with sort of 50 patients or so, again looking at CPAP versus flow, no real difference between groups. But one that is worth talking about is the Paris trial, which I'm sure many of you will know. So the Paris trial, this is the one on the bottom left, is an RCT of high flow versus standard oxygen therapy. Or that's what they would tell you. But actually, it's not really, in my opinion, because the rescue strategy for the standard oxygen group was to go into high flow. So if you think of those patients who needed rescued in some form or another, all of those rescued patients at some point in the trial were on high flow oxygen. So I don't think you can really compare high flow oxygen to something else when all of the patients pretty much were on high flow. It's not quite as easy as that. And the escalation of care within the two arms was different. So obviously the standard oxygen treatment group could escalate to high flow, the high flow group couldn't do that. So there was a different escalation. Actually, what PARIS probably is, or probably more accurately described as, in my opinion, is a trial of immediate flow versus rescue flow, and then looking at the number that ended up having to go to intensive care. And those rates are something like 9% versus 12%, so not significantly different. This paper would claim that the number needed to treat in terms of flow versus standard therapy to prevent an escalation of care is 9, but actually my interpretation of this is more, using high flow is superior for preventing you from then needing rescued onto flow. It just doesn't quite make sense to me, so I'm not sure that the take-home message is quite what I would take from it, albeit I do think the trial itself is conducted really well. I think there's a lot of strengths in it. You then need to look at where we're going in the future a little bit beyond bronchiolitis. So the same group, the PARIS trial team, if you like, the PARIS and PREDICT group, they are looking at the PARIS-2 and looking at the role of high flow in one trial and looking at that in terms of hypoxic acute respiratory failure. So there are other studies that are being done that look at it slightly outside of the bronchiolitis sphere, but it might also influence what we do in the future. So keep an eye out for PARIS-2. The other trial mentioned there, they do have some results, again, looks at high flow in terms of safety and conclude that high flow is very safe to be performed on the wards and that you get less escalation of care when you do use it. So many of us are fans of high flow being used on the ward because it is safe, and I think we should be doing that. That needs to be a standard of care if it isn't already. So let's move on to talk about intubation. Intubation is important. So we've talked about this scenario of a patient that is deteriorating, that you want to escalate, you've maybe done that onto high flow, you've maybe done that onto CPAP, but despite that, they still need some further support. So the question is, what do we need to think about, or what are our considerations with regards to intubation? So there's a couple of different considerations from my perspective. So let's first of all think about the team that we have. So you are going to have a different skill mix. That depends again on the time of the day that this is happening at and who's around. Do you have paediatricians, neonatologists, anaesthetists, emergency department physicians? You'll have a broad spectrum potentially of people, and that will also vary depending on your unit, whether you're a DGH, tertiary unit, whatever that might be. So think about what the skill mix is and think about the roles that people might take within the intubation scenario. Who's going to be the team lead? Who's going to be intubator 1? Who's going to be intubator 2? Who's going to be the airway assistant? Who's going to give drugs? Who's going to start chest compressions should they be needed? There are a number of roles, and it's really important to have a checklist. If you don't already have one, I would really recommend that, so that you have a plan in place for how you might approach this. Now remember, just because you're an anaesthetist doesn't mean that you should feel that you have to do the intubation. If it's a smaller child, you might find that the paediatrician or the neonatologist is more comfortable to do that. So have that conversation within the team. Then think about location and ergonomics. So where is this going to happen in terms of the procedure itself? In resus, in the ward, in theatres, in NICU, different people will have different levels of comfort in different places. So it's worth performing simulations on this and doing it in different environments to see what it's like. How do I get to place X, Y, or Z? Where does the kit live if I go to place X, Y, or Z? All those considerations are important, and they will be different. So having simulations is one way of improving familiarity with it. Another consideration is the drugs. What drugs will you use? They might be protocolized where you work, or they might not be. You may wish to use drugs that you're more comfortable with rather than following a protocol or a guideline. My personal drugs of choice that I use, because I work in a cardiac unit, we keep a relatively safe approach for all of our patients of fentanyl, ketamine, and rock. 2 mics per kilo of fentanyl, 2 milligrams per kilogram of ketamine, and 1 milligram per kilogram of rock. I find that safe, I find that effective, that works where I work, and that's what I would recommend if I'm on the end of the phone. In terms of equipment, there's a lot to consider in terms of equipment. So first of all, monitoring. Is the monitoring that you have on the patient currently, so your ECG leads, your saturation probe, are they compatible with where you're going to be doing the procedure? You know, is the monitoring in theatre, does that use slightly different equipment or not? Make sure the monitoring equipment is set up and ready to go before you do anything else. Then think about your procedure. What are you going to do? Can people see the monitor? Where are they going to stand? Can they hear the tone or the beeps on the monitor? Do you have access? Do you have the drugs that you want? Do you have rescue drugs? Do you have fluid bolus? Do you have adrenaline? Do you have atropine? So part of your drugs is thinking about when things could potentially go wrong. IV access wise, 2 peripheral lines in case of lung tissues in the middle of the procedure. You should not need a central line or an arterial line for a standard bronchiolitic. Suction catheters, I would have flexible suction catheters and a yanker because secretions are a big issue in bronchiolitis. And then when you get down to the actual intubation, obviously you need to think about your laryngoscope and blade and your ET tube. Now this may or may not be controversial to people. I've deliberately chosen these pictures for a reason. So textbooks might tell you it's a small baby, therefore you must use a Miller blade. People at this conference might tell you it's a small baby, use a Miller blade. I don't buy that at all, actually. I don't use a Miller blade very, very rarely. I'm happy to, but my go-to blade of choice is a Mac for every patient of every age. Happy to use a Robert Shaw, a Cardiff blade, a Miller, it doesn't matter, I'll use whatever, but I routinely reach for a Mac. I think there is a little bit, I personally have an issue with us telling you at a conference, you know, this is going to be outside of your comfort zone, so as much as possible, keep some element of familiarity, whether that's the environment you're doing it in or your team, you know, simulate it out so you're used to each other and used to how it's going to play out. I think it's a little bit disingenuous for me to say to you, try and keep familiarity, but when it comes down to the crux of doing the procedure, go and use this blade that you don't normally use. I don't think that's fair. So my take on it is to use a Mac if that's what you're familiar with the caveat that have other options as a backup. Okay, so happy for you to use a Mac, but have other options. That's my perspective on it. With regards to the ET tube, people will have very strong beliefs in terms of a cuffed ET tube or an uncuffed ET tube. The vast majority of units are probably using cuffed ET tubes, and I've deliberately put an uncuffed ET tube on this slide for a couple of reasons. I personally do not care what type of ET tube you put in, as long as it is size appropriate. Whether it's cuffed or uncuffed, as long as it's the right size, I'm happy with that. Oral tube, absolutely happy with that. I do not want or need you to change it to a nasal tube if you've got a secure airway in place. Now, the reason I am happy with an uncuffed tube is because if you go to a cuffed version, you will reduce the size by 0.5, and we know secretions are a big issue in bronchiolitis. Therefore, you know, a big internal diameter, good suction, good clearance, that works for me. It makes sense to me. And for a long time, we were able to ventilate patients with uncuffed tubes without any problems. So I don't buy the argument that all of a sudden, you know, oh, you'll not be able to ventilate them if you don't have a cuffed tube. I don't buy that at all. For some patients that need high pressure ventilation, like asthmatics, absolutely. For bronchiolitics, you can ventilate using either. My other issue with cuff tubes in general is that you need to be really careful what your cuff pressure is. So we know in adults from studies that have been done in the past that your cuff, you know, your tracheal capillary pressure, roughly in terms of perfusion, 25 to 30-ish, 20 to 30 even. The manometers that we use aim for, you know, a green area and a little dial of about 20. But to be honest, you know, we know that the blood pressure in children is a lot lower. The map of a child is lower than the map of an adult. So it makes sense that we would expect the, you know, capillary pressure of a child's airway to be lower, but we don't know what it is. So why would we target 20? It doesn't make sense to me. So, you know, if you're going to use a cuff tube, have that cuff pressure as low as humanly possible to actually, you know, ventilate the patient. But you should be able to ventilate them without a problem. So I don't mind which you use. There are strengths and you know, weaknesses to both. I don't want you to feel that you must only use one over the other. Both to me are acceptable. So in terms of ventilation strategy, once they are intubated, obviously make sure your tube is secure, have it x-rayed so you're okay with the position of it. That's really important. Use the ventilator that you're used to using, and pick a mode. Now, for me personally, I tend to use a pressure control mode of ventilation rather than a volume control. That's because it is more physiological, so therefore it makes sense to me to use it. In terms of baseline settings, put enough peak pressure in to move the chest. Now, that should definitely be less than 30. I would normally start at 24 and see what I need to do. But if you see the chest moving, that's enough. It might not be that much. I would start with a PEEP of 5, an I time of 0.7, and a rate of about 30. And I'd look at the patient and see what their entitled CO2, etc. was. The CO2 might be high. It might be sitting 7s, 8s, 9s. If it's less than 10, I don't chase it, because I'll be doing things when I get to ICU to move the patient forward. Things like clearing those secretions and physio. We'll talk about those a little bit later, but I tolerate slightly higher CO2s depending on on how the patient is. So that's the baseline settings that I would use. I would keep the patient asleep with a morphine infusion. Usually that's enough for a small child. If you need to add in a second agent, my agent of choice would be IV clonidine for a number of reasons, rather than using anything else. But again, follow your local protocol. Other people I'm sure during this conference will have talked about dopes, so I'm not going to go into it too much, but just to be aware of it, that if you have any issues when your child's being ventilated in terms of desaturations or instability, to think about tube displacement, have a look under direct laryngoscopy and see where your tube is, and think about obstruction, particularly with small babies and small tubes. Secretions are an issue. Think about pneumothorax, clinically examine the patient. There are things that you're not going to see in terms of tracheal deviation, but examine the patient. Think about your equipment, take the patient off the vent and handbag them and see if you get a quick resolution of things, and then get somebody to walk the circuit back and see if there's any sources of leak. Make sure your filters are not waterlogged, because we're using a lot of filters now in the setting of COVID and they're getting absolutely saturated and then they're causing ventilation problems. And then also think of breath stacking. So, I think of bronchiolitis as part of a spectrum, with viral induced wheeze and asthma all being there's some overlapping similarities in terms of pathophysiology. So you need to make sure that with bronchiolitics you equally give them enough time to expire, which is why you need to be careful about what I time and rate you have the ventilation set up. So just keep an eye on your ventilator and make sure there's no breath stacking happening as well. So from a retrieval perspective, then the question is, what do we want as retrievalists, and what's our wish list? I hope that we don't ask too much, to be honest. I don't want loads done to a bronchiolytic to allow me to move them to an ICU. When I arrive, we'll take handover from the patient in terms of recap the presentation, and then get an update in terms of how they've been with you guys. What you have done, the airway details, where you are currently in terms of ventilation, hemodynamics, and we'll have a look at the x-ray. Once we've got all of that detail, then we will do a clinical assessment of the patient and try to do as little as we have to before we can get out of the way and move, So things that can help us out, obviously when the tube's in, if it's nice and secure and x-rayed and in a good position, that's great. An NG tube in before the x-ray is super helpful as well. 2 peripheral lines in, working, flushed, good to go, that's great. Some IV fluids, now that can be whichever fluids you use, whether that's plasmolite and 5% dextrose or 0.9% saline and 5% dextrose, I don't mind. Again, I put them at 50% maintenance in terms of the rate. If you can have sedation running, most places know what their local ICU uses and has that protocol. So if you've got some morphine running, that's great. Speeds up the process of us just moving the pumps across and going. I would stay away from things like SIBO that can cause issues with hypotension and instability in smaller patients, so morphine is a good choice. If you've sent secretions, that's great. Otherwise, we'll do them in ICU. It's not a problem. And essentially, we just want to get going. We don't really need to do anything else. I don't want to stay and put in a central line. I'm not going to stay and put in an art line. I'm not going to electively change that tube if the tube is absolutely fine. So if those things are all done and the paperwork is there, photocopied, ready to go, then I'm more than happy. So when I get this child to ICU, how would I manage a bronchiolitic? So if a retrievalist brought me a bronchiolitic, what would I do as an intensivist? Well, I would get the handover, I'd get the monitoring changed, to get the patient over into our bed, and then I would start working towards moving them forward. So I would change the tube from an oral tube to a nasal tube at that point, because nasal tubes are better tolerated. I do not want to leave this child with an oral tube for 24 hours, where anytime we wake them up, they get distressed, they get lots of oral secretions, their tapes become loose, then we resedate them, then we put more tapes on. I don't want to get into that scenario. So I'll be very, very quick in the first night, if possible, to change that to a nasal tube. I will wean the ventilation as quickly as possible, based on end-tidal CO2 and how the patient looks clinically. I will allow them to wake up as much as I can, because that movement and being active is the best physio that they can actually get, as long as they tolerate the tube. So minimal sedation. IV morphine is fine, but I try to avoid anything else IV, and if they're sleepy with IV morphine, we can transition that to enteral morphine. If I need a second agent along with morphine, again, I'll go with clonidine, or I would go with alamemazine. I avoid midazolam and I avoid chloral. Midazolam, because it's a negative inotrope and I work in a cardiac centre, I don't see a role for it outside of epilepsy. Personally, I think there are other better alternatives. Chloral I avoid because it's an alcohol-based drug, and if I was to give any of you guys enough alcohol to make you sleepy, you would not wake up feeling very well in the morning. It's the same for our kids. Clonidine I like because you have the side effect of a bit of a relative bradycardia. A lot of my patients have congenital heart disease, they have diastolic dysfunction, and keeping them a little bit slower allows their heart to relax and therefore fill better, and they get better stroke volume, better cardiac output as a result of that. So that's why I use clonidine. Physiotherapy is not recommended. There's sort of emerging evidence coming through that physio is maybe not beneficial. I struggle with that one a little bit because secretions are one of the main issues within bronchiolitis. If the secretions are easy to clear, easy to suction, and the patient has a strong cough, fine. If there's any issues, or they're sticky or thick or difficult, or they're not progressing as I would expect, then I'm very keen on physio actually. So that might be becoming a controversial standpoint, but I'm very keen for that. Fluids, I restrict to 50% whilst they're on any sort of ventilatory support, because they will get an element of SIADH with bronchiolitis. I do not want to get into this scenario where we give them fluid, then they look a bit edematous, then their lungs are a bit wet, so then we give them some diuretics, and then because we've given them diuretics, their electrolytes are a bit low, so then we put them on some potassium replacement. That's all crazy to me. I don't do it. So just restrict them, keep them on the drier side. You know, a standard bronchiolitic should progress quite quickly for over a couple of days. I do not need a patient to grow in 2 days. It's totally unrealistic. None of us, if we're unwell, would, you know, want to go and eat a 4-course, 5-course, 10-course dinner. We just wouldn't. You wouldn't feel like you wanted to. Children are the same. So keep them very restricted. Much preferable to be on feeds than fluids, just to be very clear. You know, feed them as soon as you can and move the patient forward. We do have options if they're not progressing or if they're deteriorating. It would make me think, is there something else going on here in terms of the diagnosis? But other things you might hear people talk about are oscillation. Now, anyone who knows me knows, big disclaimer again, I am not a fan of oscillation, absolutely not. There are a very few finite circumstances where I think it's useful, namely if somebody is ridiculously wet or has a load of chest tissue edema. I think just getting a big bit of pressure in with an oscillator will help push that out of the lung fields. Within 15 minutes, 30 minutes, you'll basically be back to normal ventilatory gases and you can go back onto conventional. That is the rule, in my opinion, for oscillation. Outside of that, I don't buy it, and I very, very rarely use it. I don't think it's exactly what people think it is, and that will be controversial to a lot of my colleagues who love it, but that's my personal feeling on it. ECMO, I love. I think it's amazing. I think it works. I know it works. You know, not everywhere can offer it, which, you know, is a bit of a shame, but for understandable reasons. Bronchiolitics, very, very rare to need to go on to ECMO, to be honest. But if they did, you'd expect them to have a good outcome because it is a reversible condition and they'd be offered ECMO as a bridge to recovery. The question would be, and the controversy would be, whether you put them on VA, cardiac ECMO, or VV, respiratory ECMO. Because if they're sick enough to go onto ECMO, usually they're on a couple of inotropes, they might have a little bit of impaired ventricular function as well. My opinion on that is that if you're going on for respiratory disease, you should not be cannulating the carotid artery. Therefore, you should be on respiratory VV ECMO. And if you oxygenate the coronaries, the function will get better and you'll likely find your inotrope requirement goes down. One of the issues in the UK is the lack of availability of dual lumen venous cannulas. So a lot of units are thinking about, well, do we go VA? Is that a better strategy? I think there are alternatives to that. So my personal opinion is that for respiratory disease, VV ECMO should be the modality of choice, but you shouldn't realistically need it for the vast majority of bronchiolitics. Is there evidence for what we do? Well, this study was led by Becky, and it was done, I was involved in this when I was in London, and we looked at the bronchiolitic treatment, if you like, across 3 London centres. And what we were able to see from associations in the data was that if you used benzos, opiates, a more liberal fluid strategy, and left tubes orally rather than nasally, you did end up with a longer mean duration of invasive ventilation. So that, to me, supports the use of no MDAS, get the tube changed to a nasal, and be very restrictive with the fluids. Now, the basis of this study is that we're now looking at a larger UK-wide similar retrospective cohort study. So we'll look and see what the results of that show, but that's an explanation, if you like, for some of what I do. I've mentioned before about the importance of keeping an open mind to what might else be going on if it doesn't fit the pattern in terms of symptoms, or if it doesn't fit the pattern in terms of progression. And that's really important. So what I wanted to do was just put up this x-ray of a bronchiolitic that was referred to me, 5 days, cough, coryzal symptoms, saturations in the 80s, responded nicely to oxygen, clinically deteriorated, ended up intubated and ventilated, and post-intubation they reported that they had a bit of right midzone consolidation, and this is their x-ray. So I just wanted you to have a look at that, just even for 10 seconds, and see if anything glaringly points out to you. So this is, an x-ray of a presumed bronchiolitic. Yes, there's right midzone changes. ET tube's a bit low, just at sort of carina level. But what I find interesting on this x-ray is that it's not massively rotated at all. But look at the displacement of the NG tube. It's quite marked, isn't it? It just deviates right over to the right-hand side. So that, to me, is, some sort of atrial enlargement until proven otherwise. Something else going on here. And the heart's quite big. So when the patient arrived, examined them, they had a systolic murmur, they had hepatomegaly, an ECG showed ST segment changes. So on the basis of that, we asked for an urgent echo, and the echo showed that the patient had Al-Kappa, so an anomalous left coronary artery, and that evening the patient had to go for surgery to get that left coronary artery reimplanted. So I bring that up as a case of sometimes you just need to look at the whole picture and don't just assume a bronchiolitic is a bronchiolitic, because every year there's 1 or 2 that's referred in as a bronchiolitis that isn't. And cardiomegaly on a bronchiolitic x-ray should send alarm bells a little bit until you prove that it's not something else. What does the future hold? Well, there's a number of trials that are underway within critical care that might influence how we approach things in the future. So trials like the OxyPICU trial that's looking at what oxygen saturations we should be targeting in unwell children, ventilated children. We've got the first ABC trial that's 2 RCTs studying if high flow is as effective as CPAP, and that's in terms of acute illness or as a step down post-extubation. Because it's important to know that you can extubate to nasal cannula oxygen. It doesn't always have to be high flow. The BEST trial, an RCT looking at the safety and efficacy of surfactant compared to air in bronchiolitics. And also, as a broader concept, there's a global genomic study looking at genomes in terms of critical illness across the world. So that might have some exciting findings that might influence how we do things in terms of personalised medicine moving into the future. So things to look out for there. So I hope that talk wasn't too controversial. It might be to some of you and not to others. Again, I just think it's really important that we think about things, challenge things, accept that there's many ways of doing things, sometimes not any right or wrong answers, but I'm happy to take any questions. Thank you.
Hi everyone, welcome back to the panel discussion. Firstly, Peter, thank you for that talk on bronchiolitis. Again, a bit like the status one we talked about earlier, something that we see really commonly in practice, but actually it's really good to take a step back, look at our current practice and the evidence behind it, and think about what we're doing and not just do it in autopilot, because that's what we've always done. So really useful to consider such a common topic. There's a few questions came up on the chat and amongst ourselves as we were watching that. So we'll maybe start. I know there's a bit of variation in practice amongst the panel as well, and thoughts in regards to the use of cuffed versus uncuffed tubes. Peter, hand over to you to plead the case for uncuffed, and then we'll see if anyone wants to come back with a counter argument.
Okay, so both tubes are fine. There's a caveat to this. So I've worked in units that routinely use cuffed tubes and routinely use uncuffed tubes. Both of those units are within, standardized national data whenever you're auditing how they are in terms of their performance. So both work as long as you use them well. I have a bit of a concern that, like Plasma Light, everyone is now moving towards cuffed tubes as if they're the best thing, and they're not necessarily so. So you can use an uncuffed tube quite safely. For the vast majority of bronchiolitics, they do not necessarily need high pressure ventilation. You can ventilate them absolutely perfectly with an uncuffed tube. Yes, they'll have a bit of a leak. That's what you want. That is okay. People feel that cuffed tubes add a little bit more security to the airway, and you can sort of get away with a bit less pressure. Maybe, but I don't have any experience that it causes me a particular issue using an uncuffed tube in the bronchiolitic setting. Asthmatics are different. One of the other things that people will say is that, there's more chance of, micro aspirations and all the rest, that when you use uncuffed tubes, there's no evidence that there's any clinically demonstrable effect of that, nor were those same patients assessed without any ET tube in. So it's really difficult to say whether that is actually meaningful or not. The key with bronchiolitics is to get them awake as soon as you can. They should have a very short ICU course. They should come in, be woken up, get better, get extubated. You don't need a cuff tube. And there's loads of issues with cuff pressure and what people are aiming for. They think they're doing the right thing, aiming for the green part of the manometer, and we don't know that, and they're probably not. So I think for safety reasons, you can say that it's safer, but there are just as many arguments to say that it's not. So use whatever you're comfortable with, but use it safely.
Thanks, Peter. Anyone like to counter that, or any stronger advocates for cuff tubes?
Yeah, well, I'll certainly make a few comments to that. I don't want to say too much because we could be here all day, I think, debating this. I think the majority of us are now putting cuff tubes in. And certainly whenever I was working across in Birmingham, you were going like uncuffed tubes were very common, and quite often you had to re-intubate the child before you would transfer them. And I think I was probably doing that in about 1 or 3 of the transfers. Northern Ireland is universally cuff tubes, and I hadn't heard until recently Tudor says actually our ED doesn't stock any uncuffed tubes at all. I didn't realise, but I've never asked for an uncuffed tube in the ED. The big advantage of a cuff tube is you intubate the patient once and you don't need to change it. You're not going to get a leak around it, and you can't really predict, I think, when you're intubating the patient, which of the patients you're going to have to use high pressures and struggle to ventilate the patient on at that stage. And it's an absolute nightmare if you've got that kid to the ICU on 90% oxygen, not saturating well, and you have to do a tube change. And having that on-cuff tube or on tube in, there's a risk of that. Having the cuff tube in, it just rules that out. The other slight issue is if you're not going to oscillate that patient, that's going to give you real trouble, because that's the one thing that gets you out of trouble with an on-cuff tube. If you put them on the oscillator, the leak around the tube will actually clear more CO2. And that's one of the things I would tell people. If you're struggling, you've got an on-cuff tube in, but you don't want to do that tube exchange, you can actually try and oscillate them, and it'll avoid needing to do the exchange. And I think some of the studies, it's 1 in 3, 30% you're having to do an exchange on. So I would be a strong advocate for a cuff tube. The other thing is, in terms of the different sealing, the cuff tube seals in the trachea. It's a smaller diameter, passes through the cricoid cartilage without causing pressure. And that's a pressure you can monitor, albeit Peter said there is lots of issues with monitoring cuff pressures. I'll be the first to admit that we've struggled with actually a good way of doing that. That uncuffed tube is slightly bigger. It puts more pressure on the cricoid cartilage, and it's a pressure that you can't actually measure. It's unknown. And because the cricoid cartilage isn't actually circular, it's elliptoid, the tube can actually be putting pressure on the walls and still have a good leak around it, despite causing significant pressure. So again, I think we could debate this all day, but there's many right ways of doing the same thing. And I think the more you do intensive care, I think you have to become more accepting of different ways of doing the same thing. And if you can do it safely and have similar results to somebody else, I think that's okay.
I think, as you say, we could discuss that all day. So we might move on just to get a few other questions. So there was also a question came through on the YouTube chat about the use of chloral in a patient who you're trying to start CPAP who's maybe not tolerating it, and whether we feel it's safe to use a small dose of sedation. Not sure anyone wants to chip in. I think Costas, you had commented on that when we discussed it, but whether you want to address that.
So the answer is dose dependent, really, because I've seen liberal use of chloral, and then we know bronchiolitis can cause apneas without the chloral. So you double up on that with chloral, then you make things worse. So I've seen up to 10 milligrams per kilo, I'd be okay. There's people giving 25 and 50 per kilo. That's not okay. Unless you're in a controlled critical care environment, in which case you can react quickly and tube. So small doses, fine. If they're apneic, have a higher threshold for doing that. Large doses, regardless of age and whether they're primary apneic or primary hypoxic, I wouldn't use high doses full stop.
Right. And I suppose then the question you touched on in your talk, Peter, on the use of caffeine and how no real evidence from bronchiolitis, but I suppose the question would be in those sort of ex-prems very young, is there a role for considering this in those patients who are maybe ex-prems, young, contracted gestational age, who have presented with apneas and bronchiolitis?
So the evidence-based answer to that is no, but there's no evidence for use of caffeine in apneas associated with bronchiolitis. However, a vast majority of people in a small baby, less than 3 kilograms, or a very young baby, will try it and give it a go if their back's against the wall. And I don't think anyone would really object to that or have any strong issues with that. There isn't an evidence base in that particular patient cohort, but I don't think any of us would object. But going back to the chloral comments, I don't use chloral. I've said that already. I think there are other drugs that you can use that are cleaner drugs. So that's what I would be supportive of. And in terms of oscillation, nah, not a fan. Wouldn't do it. If they're that bad, I'm questioning the diagnosis. I'm optimizing the conventional ventilation, and then I'm thinking about ECMO. That's my personal take on it.
Thanks, Peter. We've probably about 1 minute left. If has anyone else any comments or any questions before we move on, and if not, we'll move on to the next section.
We've touched upon caffeine briefly. Now, there's no strong evidence for caffeine apart from a very small population. So if they're premature and not term yet, or peri-term, if they're less than 3 kilos, then and the primary problem is apneas, then you might get a slight advantage from you having a big loading dose of caffeine and then using it regularly. Anyone else outside that population, I wouldn't bother. So prem, which is not term yet, or just about term, or anyone less than 3 kilos, I would use. Anyone outside that, I wouldn't bother.
I'll sometimes use caffeine. I think it depends on the type of apneas the patient's having and the cause for them. If you've got a baby who's having apneas and then is absolutely fine again, and then has apneas, that'd be sort of baby I would think about caffeine. But the baby who's having apneas because they're in respiratory failure and there's no recovery between them, you're wasting your time on those ones. Has somebody got the chat on just in the background?
Grand. So I think that's probably our time up for this discussion. Hand over to Chris. I think it's time for a coffee break now before we resume in about 15 minutes.
That's right. So 15 minutes for coffee, and then we're going to come back with 2 talks. So I know it's a long day, but please do stick with us because we've got 2 great sessions to follow. So Tom Waterfield, who some of you will remember from previous courses, and Tom's just joined the chat there, is one of our paediatric ED consultants, and he's going to be talking about something we're actually seeing quite a bit of at the moment in PIMS-TS. Following that, we're going to have our first pro-con debate, and Seana and Simon are going to be debating the use of video laryngoscopy to intubate critically ill children. So like I say, it's 15 minutes break now, and then we'll get straight in with Tom's talk.
Alright, Steve, get ready. He's got good technique though, I have to say. Okay. Okay. Uh-oh. It's good. It's good. Either way.
True Baby X represents the appearance, weight, size, and movement of a 5-month-old. The Pediatric Clinical Skills Training Model is ideal for anaesthetists, nurses, and other pediatric emergency medical professionals practicing directly observed practical skills, pediatric advanced life support, and critical emergency medicine. Techniques and skills which can be taught include infant airway management, CPR, peripheral venous cannulation, PICC line insertion, needle thoracentesis and chest drain, intraosseous infusion, urethral catheterization, and lumbar puncture. The model has been designed to be fully interchangeable. All the parts are cost-effective and can be replaced quickly when required. The initial setup time is less than 5 minutes. This model is part of the AirSim X range, which provides realistic and durable training and comes with a 5-year warranty on the airway and 1-year warranty as a standard for all other parts. For more information or to speak to a product specialist, email info@truecorp.com or call 4428 3888 2714.
The A-Scope 4-Rhino Laryngo Endoscope is a flexible, high-quality, single-use rhino-laryngoscope. It is sterile and easy to use right out of the package. The A-Scope 4-Rhino Laryngo comes in 2 configurations, Slim and Intervention. The Rhino Laryngo Slim has a 300 mm long insertion cord with a diameter of 3 mm. It features 2 LED lights and a CMOS camera at the distal tip of the cord. The Rhino Laryngo Interventions insertion cord is 350 mm long with a diameter of 5 mm. It features the same LED-assisted CMOS camera on the distal tip, but also offers a 2.2 mm working channel for passing tools and endoscopic accessories up to 2 mm in size. Additionally, the handle of the intervention has a suction button, suction connector, and working channel port, which allow for the installation of fluids and the insertion of endoscopic accessories like forceps and brushes. The intervention comes packaged with a luer lock introducer, which facilitates the introduction of forceps and other endoscopic accessories. Before using the A-scope, visually inspect the pouch to ensure the seal is intact. Open the pouch carefully and remove protective elements from the handle and insertion cord. Check to make sure that there are no rough surfaces or sharp edges which may cause harm to the patient. Connect the A-scope to the A-view by aligning the blue arrow on the white male connector into the corresponding blue female connector on the A-view. Press the power button on the top of the A-view once and verify that a live video image appears on the screen by focusing the distal end of the A-scope towards an object. Carefully slide the control lever forward to confirm that the bending section of the cord operates fully and smoothly. If applicable, prepare suction equipment according to the supplier's manual and attach the suctioning tube to the suction connector. Press the suction button to check that suction is applied properly. Verify, as needed, that endoscopic accessories of appropriate size can be passed through the working channel without resistance. To begin a procedure with the A-scope for rhinolaryngos, lubricate the insertion cord to the gray mark using a medical-grade lubricant. Take care not to get any lubricant on the tip of the camera. Holding the handle of the A-scope in either hand and guiding the insertion cord with the other, advance the cord into the patient's nose following standard procedures. The control lever is used to flex and extend the tip of the A-scope in the vertical plane. Moving the control lever distally will make the tip bend anteriorly, and moving it proximally will make the tip bend posteriorly. Rotating the handle controls horizontal movement. Fluids can be instilled through the working channel of the rhinolaryngos intervention by inserting a syringe into the working channel port at the top of the A-scope. When using a luer lock syringe, make sure to utilize the included introducer. Insert the syringe completely into the working channel port or introducer before instilling fluids. If a suction system is connected, suction can be applied by pressing the suction button with the index finger. Make sure to not apply suction during the installation process, as this will direct the instilled fluids into the suction collection system. To expel fluid left in the channel, flush with 3 to 4 milliliters of air. When working with an endoscopic accessory, make sure to select one 2 millimeters or smaller and inspect the accessory closely before using it. If there are any irregularities in operation or appearance, replace it. Insert the accessory into the working channel port and advance it carefully through the working channel until it can be seen on the A-view monitor. After the procedure and before withdrawing the A-scope, ensure the control lever is in the neutral position. Slowly withdraw the A-scope, checking progress against the live image on the A-view. Remove the A-scope, unplug the blue port on the A-view, and discard. As the A-scope is a single-use device, it must be disposed of after use in accordance with local guidelines for collection of infected medical devices with electronic components. Do not soak, rinse, or sterilize this device, as these procedures may leave harmful residues or cause malfunctions. The design and material used are not compatible with conventional cleaning or sterilization procedures.
So thank you very much for inviting me along to Paediatric Emergencies 2021. I'm Thomas Waterfield, and I'm going to talk to you about paediatric multisystem inflammatory syndrome. This is also known as multisystem inflammatory syndrome in children, or MIS-C in the United States, and more internationally. For those of you who don't know me, I am a paediatric emergency medicine consultant at the Royal Belfast Hospital for Sick Children, and I'm also a lecturer in paediatrics at Queen's University. And my research interests are all around paediatric infections, including COVID-19. So we're going to build this around a fictitious case of a 12-year-old boy who's had multiple attendances to the emergency department and has some ongoing diarrhea and abdominal pain. He's pretty lethargic, and he looks dehydrated, and he's commenced on some IV fluids by the junior doctor. When we think about PIMS-TS, it's actually got a lot of overlap with common conditions. So it will be typical for these children to present multiple times to either GP or hospital. It is typically a kind of slower developing illness than some of the differentials such as sepsis and toxic shock. And they do have a tendency to kind of creep up on you, just gradually deteriorating. And I certainly think back to some of the first cases that I'd seen, certainly admitted, and there was some kind of discussion and debate about whether they were PIMS before they were finally treated. The symptoms are common, so gut symptoms are really common. As part of the SARS-CoV-2 research that we conducted last year looking at the symptoms of SARS-CoV-2 infection in children, we actually found that abdominal symptoms are really common in acute infection, and they seem to be a really common feature in PIMS-TS. Then also conjunctivitis, and alongside that rash, the skin changes are really, really common. So you're seeing about half will have conjunctivitis or rashes. Persistent fever is there in all. And then commonly kind of a big difference between this and say Kawasaki's disease, which is a vasculitis in childhood, which we would see and we would be familiar with, is the acute cardiac compromise. So whilst coronary artery aneurysm formation is well reported in Kawasaki's disease, the kind of hypertensive cardiac shock, which is pretty typical of PIMS-TS, isn't something that we would see in Kawasaki's disease. Other sides, so laboratory findings, you usually see evidence of hyperinflammation with very high CRP levels, raised ferritin, profound lymphopenia, thrombocytopenia, neutropenia, and abnormal cardiac enzymes and D-dimers. For anyone that's looked at the UK guidance from the Royal College or the Lancet paper on the kind of consensus guidelines around PIMS-TS, you'll see there's an awful lot of investigations listed. Investigations that myself as an acute paediatrician and certainly many of my emergency medicine colleagues wouldn't be familiar with in children. So that includes interpreting results such as D-dimer, troponin and BMP. So before we send those investigations on children, we need to to consider whether they're necessary and what we're going to do with the results. So a bit more information on our case. So our 12-year-old child actually was COVID positive a month ago. He was fine. It was through the whole family, and he was actually probably the least affected. But now he's had 6 days of fever, and he just feels pretty groggy. He's a little bit tachycardic. His cat refill's okay, but he's hypotensive, 88/60. Now you've done this 6 times because he's sitting there chatting to you. The junior doctors gave a fluid bolus, but it has made no difference. But despite this, he's sitting there chatting away, and this is really completely typical of cases that I've certainly seen, and very reminiscent of a case I saw when I was working in Dublin Temple Street, one of my first cases of PIMS, which is a child sitting there chatting away with me despite having a pretty awful blood pressure. And then the blood results come back, the CRP is over 300, the child is hyponatremic, lymphopenic, and there is a coag, got a fibrinogen of 7. So at this point, you actually pretty much have your diagnosis of PIMS-TS. And your first line investigations are nearly enough to give you the case. Now, not all cases of PIMS-TS are this clear cut, and certainly there'll be lots of querying and further investigations needed in many, but this would be pretty typical. So we go back to those diagnostic criteria that we talked about. So you must have evidence of inflammation, that's prolonged fever over 38, and really you need to have laboratory changes as well. If a CRP is less than 100, it's either very, very early or just not PIMS-TS. I'll bring some data up later on, but the kind of median CRP values are up over 200. You should have a neutrophilia, and you'll typically see a lymphopenia with lymphocytes less than 1. And then there'll be single or multi-organ involvement. Cardiogenic shock, and I'll bring up some numbers on the frequency of this, but certainly cardiac dysfunction is fairly common, as is abdominal upset and respiratory failure. Now, you will not typically see respiratory failure at all in Kawasaki disease. That is unusual. Abnormal neurology, I'm slightly skeptical about. This is reported quite a lot in the literature, but I wonder if this just relates to actually delirium secondary to being acutely unwell. I'm not, my personal experience and from what I've seen for the children coming through in the study that we're running, I wouldn't say that's a key feature, but certainly delirium would be. So where can we get some data from? So let's have a think about where the sources are. So certainly in Northern Ireland at the early stage of the pandemic, we weren't seeing large numbers of cases of PIMS-TS, and that probably reflects the fact that we saw very few children during the first wave. Our first wave in Northern Ireland was quite muted compared to that of England, Scotland and Wales, and we're certainly seeing now a more sustained kind of wave, and we're seeing far more cases of PIMS-TS coming through the Children's Hospital. If we look back at data from England during the kind of early stages of the pandemic, that first wave, there were 268 PIMS-TS cases over really kind of 3 to 4 month period. Now, the median age of these children were 8 years old, so this is a little bit older than what you would see with things like Kawasaki's disease. And it was more common in males, more common in children with Black and Asian heritage, although that reasons for that aren't really clear. That may just represent kind of socioeconomic groups rather than a genetic predisposition. More work's needed on that, really. And what's really striking is that nearly half of these children needed to go to intensive care units, but thankfully very few died. So this is actually a brand new illness that we're seeing that causes really quite significant harm in children. And we do have to be vigilant for it and try and understand what's going on. Now, there's different ways of categorizing this, and it has an awful lot of overlap with Kawasaki's disease and also toxic shock syndrome. And actually, they talk about the phenotypes of PIMS-TS in that way. So there's either the toxic shock type, which is the one I think we think the most about because they are the ones who are hypotensive, who look very, very well and are most likely to need ICU. There's those that look more like a typical Kawasaki's disease, and it's now very, very hard to really be certain of Kawasaki's disease certainly during this current wave of infection, where nearly everyone will have been exposed in the last couple of months to SARS-CoV-2 with the increased infection through schools, and then there's a kind of in between neither. And talking to my colleagues in infectious diseases at the Royal Hospital, that would be their kind of description that these different kind of phenotypes exist. The symptoms, and this is actually just taken from the supplementary material from the same paper from Public Health England, but that you see there, 2/3 of children will have a rash, about half will have conjunctivitis, abdominal pain, diarrhea, vomiting, really common. So certainly if you have a child that looks very unwell, has persistent fever, is an older child, and they have gastrointestinal symptoms, you should really be tuning your radar towards, could this be PIMS-TS? So our under fives, yes, we used to have being quite labile with a temperature, but we're not used to seeing that in children at 8, 9, 10 years old. So high fevers, GI symptoms during, or kind of several weeks after a COVID surge or COVID wave, you should really be mindful of PIMS-TS. Hypotension, so it's really important to get blood pressures as we get busier and busier. If they're not a standard part of your triage where you are, then you need to ensure that they are done in these children. Evidence of mucositis is pretty common. Lymphadenopathy, and I've certainly seen a case of a child who presented with a neck swelling and had concern from kind of ENT colleagues that it was a retropharyngeal abscess who actually had PIMS-TS. Cough is in there probably to represent some of the respiratory failure that can happen, but I wouldn't say it's a key presenting feature of PIMS-TS, and that would be more in keeping with acute COVID infection. So laboratory findings, again, just taking from actually the supplementary material within that PHE paper, your median, these are median values. So your median CRP is over 200. So although we've said actually over 100, most will be over 200. Ferritin over 500, D-dimer over 3,000, fibrinogen over 5.5, lymphocyte count less than 1. And these would be the kind of typical values. So we're talking about a very, very deranged set of blood results. So our case, we go back. So he's sitting there, he's hypertensive, hyponatremic. He's got a very, very high CRP. He's no chest pain, there's no cardiac history. You're in a district general hospital, and actually you're just not able to get anyone to perform an echo there and then. So you perform an ECG. So ECG changes are fairly commonly reported in PIMS-TS. And the most common findings that you see are a flattening of the ST segment, T-wave segment initially. You can see that in slide A, and this is all taken from a really nice paper from the Evelina Hospital where they looked at around 60 different children with PIMS-TS and their ECGs. When you'll see a gradual change of that with T-wave flipping through B and then through resolution, you'll see in C and D with that returning to normal. Occasionally you'll see ST changes, which you'll see in E and F. Despite having ST changes, there haven't been any myocardial infarctions reported that I'm aware of in PIMS-TS. The insult is all around a kind of myocarditis with significantly impaired ventricular function on echo. So we've got our case in front of us, and we're getting very excited that this could be a PIMS-TS, but we just have to be mindful that this is actually an older child who is hypotensive, looks very, very unwell and has very deranged bloods. And actually before COVID, we would have been thinking about sepsis or intra-abdominal sepsis. And certainly we have to keep our minds open in that. So we're thinking about your surgical consult, thinking about giving your broad spectrum antibiotics to cover for serious infection. We're thinking about your sepsis management. Kawasaki's disease, again, so Kawasaki's disease has some overlap. And you'll see this is a really nice figure taken from a French paper. It's been, I think, referenced nearly 800 times now. It's an incredible paper. But it's looking at features from Kawasaki's disease. You can see there conjunctivitis, mucositis, cervical lymphadenopathy, skin rashes, pericarditis, coronary artery dilatation, which are common to both. But then you'll see actually the neurological signs certainly more common. As I said, I wonder if that's to do with delirium and just how well they are. Respiratory signs, just not a feature of Kawasaki's disease at all. Left ventricular dysfunction, which was very high, reported much higher than it is here in the French studies. Shock, and actually needing ECMO, which is, again, none of our children online have needed ECMO as far as I'm aware yet. GI involvement there really high as well, as you'd see. So some really key differences between Kawasaki's and PIMS, and also with sepsis. And again, there's also toxic shock on there. So you need to keep a broad diagnosis in mind, not just jump to a diagnosis of PIMS, and make sure those different conditions are covered. So what's happening? So we don't really quite know what's happening in PIMS-TS. So one of the reasons I was invited to give this talk, I'm an emergency medicine physician, so I'm not an infectious diseases consultant, but my research is around COVID-19. We have an ongoing study looking at symptoms and antibody kinetics in children, but we now actually, with the recent recruitment, we've got a study ongoing looking at PIMS-TS, and we're looking at a kind of multi-omics approach to try and understand the immune response in children with PIMS-TS and how that compares to other common paediatric illnesses. So different theories have been put forward. This is a really nice figure taken from an adult paper, just showing how you kind of initially become exposed, you're asymptomatic, doesn't really affect you, and then kind of initial viral stage, fever, cough, those symptoms that we're all kind of aware of. In children, we get a little bit of that, but then it quickly drops away with no kind of hyperinflammation, and then a really tiny blip at the end where you get the MIS-C, and then you'll see between the adults and the older adults in between getting that hyperinflammatory stage in the middle. And I'm not going to dwell on adults because I don't think it's the same illness, and I'm a paediatrician, but I think there's certainly good evidence around endothelial involvement and a kind of endothelitis, which is probably multifactorial. It probably relates to kind of pre-existing injury. So certainly if you think about your risk factors for severe COVID infection in adults, they are people that are predisposed to kind of inflammatory changes within the vasculature already, and to have kind of damaged or sick endothelium. And I think endothelitis is a big part of acute COVID-19, but also in PIMS. This is a figure just from one of our papers we're putting together, Just kind of summarising, we performed a literature review and just looked at studies that were looking at the mechanisms behind PIMS-TS. And there's lots of different kind of theories. It's hard to tie them all together. So one of the things that's been put forward is around the antibody response. So you're getting your kind of antigen percentage or kind of B-cell antibody response, and you're producing non-neutralizing antibodies as well as auto-antibodies. And it has been shown an antibody to endoglin, which has a really key role in the maintenance of endothelial cells. That's been identified in recent autoantibody studies, so showing that there's probably some sort of potential autoantibody mediated injury to endothelial tissue as part of this. But then these non-neutralizing antibodies can also then become kind of self-stimulating, which leads to a cytokine storm. And the kind of cytokine profiling showed it is slightly different to infection and also to Kawasaki's disease. You get very high interleukin-6, and you'll remember that interleukin-6 blockers have been considered as treatment. You also get high interleukin-17A. This cytokine storm probably is responsible for some of the kind of toxic shock appearance that you see. So we've got a cytokine storm ongoing, we've got leaky endothelium. We may have a role for autoantibodies. And then there seems to be, from some really small but neat studies looking at single cell RNA sequencing and looking at flow cytometry, that something is happening with natural killer cells and kind of exhausted CD8 cytotoxic T cells, leading to some sort of chronic inflammatory response. Now, all of this hasn't really been fully worked out, but it seems that there's the environmental trigger, which is SARS-CoV-2, probably some underlying genetic predisposition to a pro-inflammatory immune response that leads to antibodies that are produced that include autoantibodies, but also self-stimulating, non-neutralizing antibodies. This leads to kind of direct endothelial injury through autoantibodies, but also through a cytokine storm, which is then kind of perpetuated by abnormal kind of regulation or dysregulation between cytotoxic T cells and the other major cytotoxic cell, which is natural killer cells. But more work's needed to really understand this properly. So the case was referred on. So we know that around half of these children are needing to go to the intensive care unit. We know that acute surgical pathology is often a common differential. We know that many will need echocardiograms and will need input from cardiology. So the place really for PIMS-TS to be primarily managed is in the Children's Hospital, where there's a multidisciplinary team to manage them. I know from working very closely with them as part of the study, they're happy to always take calls on patients with possible PIMS-TS. This child was transferred across by NISTAR, was commenced on immunoglobulin, commenced on high-dose steroids, and made a reasonable recovery initially. Follow-up has showed that they've got some ongoing coronary artery the abnormalities are very prominent, but no dilatation and no aneurysms, and some ongoing fatigue. And certainly as part of the study, we have formed a patient public group, and one of the young people involved in that was a very keen athlete prior to PIMS. And although kind of some of the key markers around echocardiogram have shown kind of return to normal function, he still has significant ongoing fatigue. His exercise tolerance is significantly reduced. And that raises some really interesting questions, because is this just recovery from a severe illness, or is this some sort of ongoing inflammatory response? And that probably hasn't really been looked at yet in terms of is the actual inflammatory side of this going on and on. So I think just to kind of close up and summarize, PIMS-TS at the moment is fairly common. We're seeing 2 or 3 cases a week coming through the study, through the Children's Hospital. Diagnosis is probably tricky initially. These children that have had fever for 5 days might present when they've had fever for 2 or 3 days, and I certainly myself find that a tricky group. You've had a fever for 3 days, you're over 5, you don't look great, you've got some tummy upset. My threshold for blood tests at the moment for those kind of children is a little bit lower than it was pre-pandemic. I don't do all of the Royal College Royal College investigations because I'm reluctant to interpret, for example, a D-dimer, a troponin, and a BMP in all the children. So I will typically do my first-line investigations. If that points towards PIMS-TS, then I'll have that conversation with my colleagues in infectious diseases, and then perform my second-line investigations with their support and also the support of cardiology. So I think at the moment, keep an open mind. We are seeing lots of cases. We don't really understand the mechanism. I think if you're vigilant and you're discussing them early, then they do pretty well. They can be challenging to manage and are probably easier managed where we have a mixture of teams, including ID and cardiology. And that's really kind of a short summary on PIMS-TS. So thank you very much for inviting me along, and I'll be around for some questions. Thanks. So hi, I'm Tom Waterfield. I'm a paediatric emergency medicine consultant in Belfast and clinical lecturer in paediatrics at Queen's University in Belfast. And my talk's just finished there around paediatric multisystem inflammatory syndrome, temporally related to SARS-CoV-2, or MIS-C as it's known outside of the UK. I'm really lucky to be joined by members of our infectious diseases team here in Belfast with Lynn Spears, who is a paediatric infectious diseases consultant at the Royal Belfast Hospital for Sick Children, and also joined by Claire McGinn, who is a research fellow, paediatrician, and interested in paediatric cardiology. And we were hoping to have a little bit of a kind of discussion around some of the kind of nuances in the management of PIMS. So we're going to kind of put Claire and Lynn on the spot a little bit like real life. So I'm a emergency medicine consultant, so we're used to seeing kind of lots of febrile children. Anyone that works with children at the minute is seeing lots and lots of febrile kids, and it can be difficult sometimes when they've had a temperature for 3 or 4 days, and we've heard about the symptoms there, but gastrointestinal symptoms, temperatures, diarrhea, vomiting, all really common. So I guess one of the first things is really, from your experience of seeing these children come through the department and onto the ward, when would you suggest that we think about PIMS-TS in children attending the emergency department beyond just the temperature, rash, tummy pain? And that's I mean, that's open to the panel, but definitely, Lynn and Claire, I'd be really keen to know what you think.
Thanks, Tom, and thanks to everybody for letting me be on this panel. So I think the thing that we see as infectious diseases doctors is that, these children are quite unwell looking, and they have been generally unwell for a number of days. Now, we've had a few who have presented and they're really only 48 hours into their illness, but they're not the well child who has an intermittent fever. They're an unwell child. They're red generally. Like the rash is something that we've seen with, I think, pretty much all our patients. Often they're, they have conjunctivitis and, they've got the tummy pain and whatever other systemic symptoms, but it is just, they're unwell. Now, the other thing that I sort of always say is consider your differential diagnosis. You really don't want to miss a septic child or a perforated appendix or something else. So, PIMS is an inflammatory condition, and, although we want to manage it quickly and all, I've had phone calls in the middle of the night at 2 a.m. going, this child just walked in the door, we think they've got PIMS. You're like, well, okay. Just take a step back, take a deep breath, don't panic, do your ABC, do your, you can give some cautious fluid resuscitation, you can, give your broad spectrum antibiotics. And then if your bloods are very, very abnormal, then, you're starting to think, should I do the extra bloods? Should I talk to yourselves? And we're always happy to take calls.
And so I know you were saying there, there's obviously talk about the different phenotypes. It is a spectrum. The toxic shock kind of presentation is probably the one that we're more likely to pick up on. But I have seen a couple, and I'm sure you've seen this too, where multiple kind of ED attendances, now not in Belfast, kind of slow burn, difficult to pick up. I guess that always, when they're diagnosed at the kind of third or fourth attendance, you do always think, could have done better, could we have found them somewhere else? Is it that that's what happens? They sometimes take a while to become obvious, or is there something that we could be doing at 2-3 days where we could be spotting these children a little bit earlier? And does it matter if we don't spot them early?
That's a good question. To be honest, I don't know that there is anything you could do. You could have done a blood test on that child the first day that they presented and their CRP was 30 and, fits with the tonsillitis, fits with potentially a bit of a urti or something, and you wouldn't have been that worried. So there's no tests that you're going to be able to do early on that will actually differentiate this syndrome apart from, and that's where you safety net all the time. You say, if you're not happy with your child, that your child's condition can change. And it's not that I'm sending your child home from the emergency department because they're completely fine. They're clearly got something wrong with them, but we don't think it's too serious at the moment, but please do come back. And we don't know.
I think that's just nice as a PEM person to hear that, because the toxic shock type presentation, you kind of said to you, you've been thinking of sepsis, you've been thinking of a toxic shock. It's the Kawasaki's type 1s who are partial Kawasaki's who, kind of not got all the features, have had a couple of attendances, and actually they are really tricky to spot. So if it's something though that's just part of the progression of the disease, then that's probably okay. You mentioned about investigation, so that's the other thing. So obviously there's the list from the Royal College, there's the consensus document which is in the talk. My kind of view on this is your full blood count, your coag to get your fibrinogen, your ferritin, and your CRP. But I don't rush to a D-dimer on a cardiac enzymes unless I would have spoken to the ID team or the cardiology team or both before sending them. What do you think about that in terms of a first and a second line investigations? The children are coming in maybe 5 or 6 days of fever, you've got a concern, you're obviously looking for your other causes, but to help you make a diagnosis of PIMS.
So I think that's very sensible. Like, we do not know what a BNP means in children, I think. And I asked this at a PIMS conference with some of the guys from Great Ormond Street, and like about 6 months ago, and one of their cardiologists said, well, we don't check them in febrile children, so BNP is an inflammatory marker and can go up. But so I think you do your first line, you see what they are, and then I don't know any other viewpoints on cardiac enzymes, but
no, I would agree, Lynn. Even in children with congenital heart disease, we don't really use BNP and troponin regularly, so using them in an acutely unwell child aren't particularly helpful. I think they're useful when they're raised and the picture fits with PIMS already, but it doesn't change the management really. If we have a really high BNP, we'll not say, this child needs to go to intensive care or something. It doesn't really change the picture in front of you. So I think it helps with the diagnosis of PIMS-TS and that guideline of all the different markers pointing in that direction, but actually the number doesn't matter if it's raised at all. It makes us think PIMS-TS, and there's not really much point doing serial BNPs and troponins. They will improve once the child starts treatment, but if they don't improve and the child is clinically better, that doesn't probably change management either. So yeah, I think the jury's still out on how useful they really are.
And there's a nice paper in the talk from the Evelina, I think it was, with the ECG findings, and they were talking about how obviously talk about the common findings, which Claire, you'd be better than me, but the site you get kind of your ST changes with flattening of your T waves and a kind of a reduction in the size of your QRS complexes. But some of them get the ST elevation, but none of them had infarction. It was all secondary to myocarditis. So even if you are seeing abnormal enzymes, is it right to think that actually it's reflecting that kind of myocarditis, which should improve? It's not, an ischemic type injury, which I know sounds silly, but we'll have that will be a concern for some people, I'm sure.
No, absolutely, because the cardiac myocytes, which are obviously producing these markers, are stressed, and they're stressed because of inflammation rather than necrosis. And we don't have a marker for kind of inflammation versus necrosis in children anyway. So I think you have to put the whole thing together and look at the ECG changes and look at the echo and kind of monitor it that way. And in the children that I've seen recently, there's been some subtle ECG changes, but I haven't really seen any real marked ST elevation. It's mostly whenever they have their echo that you go on and notice, yeah, they definitely have reduced LV function and evidence of myocarditis, and plus or minus some coronary involvement as well. Although not every child with PIMS-TS will have echo changes, as Lynn will know. So we do quite serial monitor and other echoes as in patients to see if there's a change in their echo or if it stays stable or improves. And what we're finding is actually once they start treatment, their echo is improving very quickly, kind of by day 2, day 3 post starting treatment. Echo's improving and the child is clinically improving as well. So once treatment started, actually the echo was quite quick to recover, which is good.
So, and with the investigations, I'm going to put the kind of median values from the PHE paper, which is kind of one of the biggest cohorts, but there really are really deranged. So, you know, CRP, we talk about over 100, but the median's over 200. Fibrinogen's up around 6, you know, so these are not children who are going to have, CRP's 50, and this Lynn's going to tell me, no, we've had loads of CRP 50s, but hopefully not CRP of 50 or fibrinogen's 3 and 1 of 4, you know, we're not sure. They're really kind of markedly deranged. We might have lost Lynn. So while we're on the cardiac side of things, so we're thinking more about this. A child I saw very early on who was sitting up chatting to me, despite having a kind of, you know, systolic in his boots, and was a PIMS-TS, was quite a slow diagnosis because it was early on in the, you know, one of the first when we were down south, and we weren't sure. But you know, what do we do? So we gave him a bit of fluid, and it didn't, you know, this again would be interesting to know, but it didn't make any difference really, is what I found. We gave him a bit of fluid and it didn't do anything, and he was quite well, so we just kind of watched him for a bit. But you know, what should we be doing? You know, should we be giving fluid? Should we be starting vasoactive drugs early? You know, what's the kind of the right approach?
I suppose cardiology has been working quite closely with the intensive care team whenever these children are hypotensive, rather than kind of solely taking on responsibility. But I suppose the reason they're hypotensive is usually partly because of reduced LV function. We've had function down as far as kind of 30-40% in some of these kids presenting acutely. And then obviously the systemic response as well, and all the vasodilation. So it makes sense to start inotropes early for that reason, because you can give them all the fluid in the world, but that's not going to help their ventricle to pump any better. If anything, it's going to put extra pressure on things. So yeah, what we've been doing is starting inotropes quite early when they're admitted, and having a low threshold for, it's usually milrinone, which obviously has some issues with hypotension, so often going along with adrenaline as well in the first instance. So that's what we've been finding works well, and then able to kind of wean the adrenaline and keep them on milrinone for a day or two until the blood pressure is better and the ventricular function.
Sound really...
The other thing is that, you know, we've had about 40% of our children have had to go to intensive care, and quite a few of them, and I don't have all the data in front of me right now, but it's been pulmonary edema. And, you know, probably because we give them fluid because they need fluid for resuscitation. We then give them a whacking dose of immunoglobulin, which is quite a large volume of fluid, and it kind of just, on top of an impaired cardiac function, it just tips them over the edge a little bit, and quite a few of them needed diuretics and PICU. So I think we do have to be quite cautious with our resuscitation, but I wouldn't say don't resuscitate, because I think you have to, but just be aware that if you are thinking a child has PIMS-TS, you know, maybe go 10 per kilo with your boluses and all, and that's certainly been played out across the UK. Other centres have seen similar things, you know, with over.
And in ICU, if you you know, just thinking about that, do we have to give them lots of fluid? Does it actually improve the numbers, or does it actually affect the child? I understand it's a silly question, but I'm just thinking back to my one kid who sat there chatting to me with his low blood pressure.
Yeah, I suppose the fact is that, you know, there's still a differential for these children. So if it's a child who has sepsis, and I guess there's a debate about that as well, as in how much fluid you should give a septic child, isn't there, you know, boluses and outcomes and things. But, you know, actually, I would say you do have to start off with fluid, but just be cautious.
And then you can see why you need ICU input then, in terms of, you know, if you're thinking about the challenges of fluid management going forward. So I don't think we've solved that one, but it is tricky. So it's kind of, you know, judicial use of fluids and trying to get your echo early and thinking about your vasoactive drugs. Time-wise, I'm just thinking, because we've had a few things in the chat, but I wanted to just find out a little bit about how are they doing at clinic. So we're obviously seeing them in ED, you know, and then we lose them. And you know, are they all coming back to you at 2, 3, 4, 5 months saying that they're 100%, or is it lingering, or you know, what's happening?
So we are seeing them all relatively regularly, and certainly cardiology are doing echoes on them all after about 6 weeks. And I would say the majority of children, now we've had about 34, I think, in our cohort, and I would say the majority of them came off their aspirin at 6 weeks because their echo had almost completely normalized. And maybe Claire can talk a little bit more about the echo. But from a medical perspective, I saw a child last week who had gone back to school the week after she'd been admitted. Now, she'd only managed 1 day in school, but then she'd ridden her bike the next day and had, you know, had just done amazingly well compared to how sick she was the week before. There are a few who will sort of have more of a chronic fatigue, you know, types afterwards, and it just takes them a while to recover to their energy levels and things. But you know, the majority of children that I'm seeing, once you get that inflammation turned off, a week or two later, they're better, and that's what's lovely to see actually in the outpatient clinic.
Yeah, we're seeing a similar picture then. Actually, from an echo finding and a cardiac function point of view, most of the children before their discharge are back to baseline with their cardiac function. So really that 6-week check is to make sure that things are continuing that way and that there's no signs of coronary artery dilatation or something new that we weren't kind of going to see in the acute phase. And then at that point, we're stopping the aspirin or ACE inhibitor if they're on it as well. But I suppose one of the questions we don't really know the answer to is then how long to follow these kids up from a cardiac perspective. And if we treated them all like we do with Kawasaki, it would be lifelong, actually. So that's still something that's out for debate, and whether or not we should be doing follow-up MRIs, cardiac MRIs on these kids as well. So the short answer is that they do look much better in clinic at 6 to 8 weeks. But what the long-term impact is going to be, it is hard to say right now.
Yeah, remember this is a disease that we've only seen since April 2020. So long-term follow-up is like a year and a half at the moment. So
don't know.
And just there was something in the chat about, you know, which children would we admit and observe. I would say just from a pragmatic point of view, we don't have much of a luxury at the moment, certainly in Belfast, to have much in the way of observation of children that are quite well. So I think from my take home from what I've heard from Lynn and Claire and my own experience, and I'm happy to hear what the others on the group think, but I think if you've got a concern, you do the first-line investigations, you think about other causes, and if the first-line investigations point away from it, you know, certainly get some advice from your friendly ID consultant, but we probably, you could be observing them for quite a long period if they're well to see if this develops. So actually it's probably about safety netting and finding a way for them to come back. So I think if you've got the concern, you do the first line investigations, you keep a broad differential, and you either admit for kind of treatment of something, or you're going to have to accept that you're going to manage them in the community.
I'm happy to pick up on that, Tom, just from like an ID point of view. I suppose that thinking about the wide differentials in your pre-test probability of hyper of infections versus inflammatory. I suppose if you've got a child presenting with persistent fever for a few days, plus some non-specific signs and symptoms, but including conjunctivitis, your likelihood of a possible PIMS-TS is increased compared to other infections or inflammatory causes. So the suspicion of a hyperinflammatory state would be heightened in that regard. And as you say, absolutely do your first live blood tests. But in those instances, you would have a lower threshold to discuss with your ID team about a period of observation plus or minus ID review, because that, whilst there are obviously bacterial, viral and other inflammatory causes, your suspicion of a PIMS-TS would be heightened in that regard. So I think that's a really good question from Jamie.
There's a question as well about aneurysms. Now, I've got some data from the study, but Claire would probably have a knowledge of an even bigger cohort. So I don't know if you want to take that question, Claire.
Oh, mine's going to be personal experience, so if you actually have some data, that's probably more useful.
So I mean, well, the literature data and the data that we're seeing from so we've got about 20 of the 30, 35 kids that Lynn was mentioning in the study, but we're not seeing aneurysms.
No, we're not.
And we're seeing less aneurysms than you would expect for Kawasaki's disease. Would be what I've read and what I've seen in our data, and Claire's nodding and Lynn's nodding, so that's good.
No, definitely. If anything, the only thing is people keep commenting on the echoes that they might be prominent arteries, but sometimes I think that's just everyone covering themselves because they can actually see the coronary arteries, and often they're quite hard to see on echo. So if someone sees them at all and setting up myocarditis, are just covering themselves by saying they're prominent. But no, we're not really seeing that. They're actually quite different to children with Kawasaki's. And they're much older as well. So yeah, with that, we're not really seeing much coronary artery involvement. But again, that's what we're watching for when we're bringing them back to clinic, because we don't know the long-term effects, the same as we don't know with Kawasaki's.
I guess are you finding that all of the children are coming to the children's hospital, or are we, as our confidence increases, are we managing more of these children away from the tertiary centres?
So we have been basically bringing most of them up to the Children's Hospital, and the main reason for that is that in Northern Ireland, you can't get a tertiary cardiac opinion apart from in the Children's Hospital, so they need an echo. They're going to have to come here. Occasionally, there's been a few that have been younger children who have been quite clearly much more of a Kawasaki phenotype than a PIMS phenotype, and I've advised to give the immunoglobulin in the DGH because we have had no bed, and there's been a bit, there was going to be maybe a day or two delay, and I think that has been the right thing to do. But there's just a bit of caution about giving immunoglobulin in their DGH if there's a potential for fluid overload, on top of a fluid bolus and whatever that they might have received in an ED department. So we occasionally we have said giving steroids first line, because we know the recovery trial looked at the PIMS-TS and has looked at, is going to hopefully guide us towards whether is steroids, AVIG, or both, and that analysis is ongoing. I think it's been a lot more complicated than they thought, because I think we thought we were going to have answers in October, and we still at the end of November now, and we still don't have any. But hopefully by the end of the year there'll be some guidance on that. But yeah, I think from a practical point of view in Northern Ireland, we're trying to get them all transferred here.
And that leads, there's not long left, it leads also in with Stephen's question. So I mean, that's a good point. Our treatments for this are based on Kawasaki's disease. It's not a specific PIMS-TS treatment as such. It's experience with other conditions, but although they seem to work from what you said, from the clinical experience. And Stephen just said about Kawasaki's disease. So as an academic, it's almost impossible for me to be certain that I'll ever get a Kawasaki's disease for comparison, for example. Currently, at least, while we've got so much COVID around. I know there has been some cases of Kawasaki's diagnosed by the ID team. How do you do it? How do you know it's not PIMS-TS?
I mean, I suppose it's a phenotype and it's a spectrum of a disease, and I think, what is Kawasaki disease? Well, Kawasaki, we don't even really know what the trigger to Kawasaki disease is. It's probably a viral trigger. And what is SARS-CoV-2? It's a virus, and a response. And probably as we look into the genetics of the children who are affected by PIMS-TS, there's probably going to be something that predisposes them to be hyperinflammatory and whatever, and that may come with time. But I think it's the younger children, the babies, and there are a few babies around there who actually are COVID antibody negative that we have seen. So we think that they're probably just Kawasaki. But yes, I don't know, as you say, when the
younger children,
seropositivity,
antibody negative,
yes,
who look like Kawasaki's.
Yeah.
So I think we're coming to the end of the time, which I'm sure we could keep going, and I really enjoy that. But I think we're kind of last few seconds.
Can I make a quick point, Tom? Yeah, just to say that something you mentioned at the start of your chat, Tom, was that people all worry about these kids going home and should we, act or do something different when they come in. I think that's a fair concern that we all have about everything we do and every patient that comes in. And I just want to take the opportunity to point out that everybody who works in healthcare and anybody who works with children does a phenomenal job. And we all have a tendency to be quite self-critical of ourselves, no matter what we do, and always wonder, could we have done better? I actually think it's really important that people remember to be kind to themselves as well. We all set out to do a good job. We all do a good job. And we all reflect on things and think of how things have gone and whether we can improve and whatever. But it's important to be kind to yourself as well and to be kind to your team. We have a big tendency to be harder on ourselves, and we would never speak to our friends and colleagues the way we sometimes speak to ourselves. So it's just to remember to be kind to yourself as well.
Peter, and thanks to Tom for your talk and for
something before you go on to that.
Sorry, yes, Chris.
Just slight change to what we were doing. I had put a poll up onto the chat and I've seen Simon's face because 25 votes were in already. This is the poll that you're meant to fill in at the end of the pro-con debate. Simon was worried he was losing already, so he's hopefully going to change your mind if you voted already. I'm going to put the poll up. Please don't vote until we tell you to, and Simon will change some of your minds. If you voted already, you're going to have to vote again when we tell you to. Okay, Ben?
Thanks, Chris. Yeah, and listen, thanks, Tom, for your talk. Really appreciate it. Really interesting. Obviously, very topical. And as you say, we're learning lots. There's still lots to learn. And thanks also to Lynn and Claire for joining us for this session in particular. It's really good to get your insight from the worlds of ID and cardiology. We're going to, last session of the day, really something slightly different. We haven't done this before. It's a pro-con debate, looking at the motion that critically ill children should be intubated using video laryngoscopy. And we've got Dr. Seana Molloy and Dr. Simon Jackson, both PICU grid trainees, originally based from Belfast, but now both doing their training in Alderhay. And I'm going to leave it over to Chris to introduce on a video the format of the debate, and then we'll come back for questions and discussion. So we'll go ahead and we'll play the video.
So we've now reached the final session of today's event, and we're going to be ending with the pro-con debate. The topic up for debate today is critically ill children should be intubated using video laryngoscopy. And we've got two of our PICU registrars, Seana and Simon, are going to be arguing this out. Seana is going to be arguing for the use of video laryngoscopy, and Simon is going to be arguing against. In terms of the rules, they've both got up to 10 minutes to make their arguments to you. At the end of those 10 minutes, they're both going to be available to answer your questions and also questions from the panel. In terms of getting your questions in, again, do that just in the YouTube chat, just like you have been doing over the course of the day. But I would encourage you to put your questions in nice and early as they're still giving their talks. That means we're more likely to get to your individual question. At the end of all that, we're going to be asking you guys to pick the winner. So if you look over in the YouTube chat now, you should notice that a poll has appeared at the top of the chat where you're going to be able to get your vote. So again, importantly, you have to be signed into YouTube to vote. So if you're not signed in, make sure you get yourself signed in now, so you're going to be able to vote at the end of the session. So as well as being the winner of this, which is very prestigious, it's our first pro-con debate on paediatric emergencies, we have also got a prize. And a big thank you to AirTrack for donating it. So AirTrack have donated one of their Wi-Fi cameras and a whole range of paediatric and neonatal AirTracks for the winner. We've got some demo models, so the winner is going to be able to practice their video laryngoscopy skills at home. And then we've got some models that can actually be used on patients, so then going to be able to put those skills into practice. So it's a great prize, and a big thank you to AirTrack for donating it. Okay, we should get on with the event, and going first is going to be Seana, and she's going to be arguing for the use of video laryngoscopy to intubate critically ill children.
So hi, my name's Seana Molloy. I'm a paediatric intensive care trainee, and I'm here to tell you why the video laryngoscope is superior. It's a fact. But also, and most importantly, I'm here to kick Simon's butt. And I hear on social media there might be a wee AirTrack prize, so I'm hoping for this scope. So video laryngoscopy has been available for a little more than 20 years. It provides a fab view of the glottis that you can take the credit for and can show off to your colleagues as you intubate the most difficult kids and you walk away feeling good. Seriously though, they are so versatile. You can use them according to airway difficulty, choose the shape of the blade you want, an acute angle versus a Macintosh blade versus a Miller's type blade. And you can even be lazy and choose the scope with a channel to hold and guide the tracheal tube through the cords. I mean, there's so many options. Over the last decade, the video laryngoscope has emerged with a bang in adult training and is being labelled as best practice amongst the most highly regarded clinicians. I mean, I think it soon will be considered standard of care when intubating kids, especially those with the more challenging airways. Look, we all know we work in PEDS, those little faces and mouths have all been major stumbling blocks that companies have had to overcome, having to formulate devices of a suitable size to facilitate our teeniest and tiniest. From a difficult airway point of view, the emergence has enabled anaesthetists and even us little paediatricians to intubate the most difficult of airways. Its introduction has provided us with an all-inclusive view of the airway, resulting in a superior appreciation for the anatomy and offering an expanded, high-resolution view for all in comparison with a blind, tell me what you see approach. So I reckon video laryngoscopes are up there in our paediatric artillery, standing tall beside the almighty Calpol and Nurofen. We know the differences between the paediatric and adult airway exist. Big head, large tongue, anterior cords. Now, we'll not explode their heads, as we know the humble anaesthetists would just get too shy, but you have to admit, they are knowledgeable and experienced in the techniques of direct laryngoscopy. I mean, they spent 7 years perfecting their skills. Granted, probably 6 of them is in the tea room on their coffee breaks, but nevertheless, if you're taking the time to become clinically adept, a paediatric video laryngoscope should we as paediatricians now follow by example. Like, the skill does differ between direct and video, and I'm not alone in thinking that video laryngoscopy mainly is easier. The technique of mouth opening is similar and henceforth can be as striking as the work of David Attenborough. The humbling video laryngoscope is inserted midline, safe from the wrath of the giant floppy tongue. You view the monitor as the blade gently lifts and you advance until the larynx just becomes beautifully visible. Now, you might need a wee bit of burp to perfect the picture, and you might need a wee bit of training in the fine details of hand-eye coordination, but the nuances of video laryngoscopy can be acquired quickly with a bit of practice. Now, there are stacks of video laryngoscopes commercially available for the use of PEDS. I'm going to talk about a few that I've used and a bit of the boring evidence. Warning, disclaimer now, I'm categorically 100% not getting any money whatsoever for the promotion of any scopes talked about today, unfortunately. But I suppose just beating Simon is probably a reward enough. The McGrath, I love it. Familiar and transferable skills. There's been numerous case reports documenting the successful intubation in neonatal and paediatric practice. Ross and his mates reviewed its use in anaesthetic practice and found it superior in infants down to as small as 800 grams. They particularly liked its similarity to learned practice in terms of blade, device and technique, and allowed for the magnified view to facilitate training among even the most junior of colleagues. It has been used successfully in kids with extensive burns and scarring to the face and neck, resulting in grade 1 views. Tell me, when you think of a difficult airway, I mean, I always think of things like Treacher Collins, and this scope has been successfully used when previous conventional attempts have failed, converting the grade 4 view into a grade 1. Mannequin studies have demonstrated encouraging results, considering the McGrath to be faster and allowing a higher rate of first attempt intubation success rates, even during ongoing chest compressions and in immobilized cervical spinal patients. They recommend McGrath as the first intubation option for the endotracheal intubation during paediatric emergencies. It is an enhanced direct laryngoscope which allows me, the operator, to see a direct and indirect view of the airway using the traditional curved Mac blade. So boom, there you go, Simon, double whammy. This scope even does both. Your case is closed already. The CMAC, well, it's amazing. We've all used it. It's a non-channeled video laryngoscope that can be fitted with various Macintosh and Miller-style blades, including the Miller 0 and 1. You know those wee toy blades that the neonatologists play with? But among the literature, success has been highlighted in kids with challenging genetics, difficult airways like Tudor Collins, as we mentioned, and C-spine injuries and limited neck extension. It's lightweight, compact system, which we still get the familiarity of the Miller and the Mac blades, but it has an amazing picture. It's even able to facilitate a handy pocket monitor that Dr. Chris Flannigan has promised going to get me when I become a consultant. Overall, there was better success rates in various neonatal studies, even down in this stage to 500 grams, helping to prevent repeat attempts due to likely an improved anatomical view. I mean, a grade 3 view with direct has been magically transformed into a grade 1 with the video. Our ED colleagues, even without extensive anaesthetic training, prospectively looked at their success rates over a 10-year period and found that children less than 18 years in an emergency intubation situation, the CMAC was associated with higher first pass success without adverse effects when compared with the direct. I mean, we've even been able to diagnose vocal cord paresis in tiny preemies with the CMAC, which, let's face it, when you're using a direct in a 500-gram kid, you're just so happy you're getting through them non-functional cords that you're not noticing anything else. Next up, the AirTrack. Now, I must admit, I wouldn't have as much experience with these, but I'm sure I'll become established when I won one later. It is a channeled video laryngoscope, which can be used as a direct or indirect with a wireless monitor. It comes in 2 paediatric sizes and can pass as small as a 2.5 ET tube. Unique to the AirTrack though, there's a channel for directing the ET through the vocal cords, so it does the job for you. I mean, some people do say it's tough going in kids with limited mouth opening, like in Pierre-Robin, because of its relatively large blade. But in simulated mannequin studies of paediatric patients with grade 4 view of the glottis, the AirTrack proves superior to the standard Mac. Furthermore, in a study of novices using Pierre-Robin simulated mannequin design, the AirTrack led to shorter duration of intubation attempts as compared with even the Kaleidoscope. Various studies have reported less time to intubation, improved visualization, and smaller number of esophageal intubations. Granted, the evidence regarding the utilisation of the AirTrack is mostly in normal airways rather than the difficult airway in the paediatric cohort. So I look forward to creating some evidence when I win this prize later. Don't worry, Simon, I'll give you a wee go. And finally, just to touch on the almighty Kaleidoscope. Introduced in PEDS in 2005, it has evolved massively. The non-channeled Kaleidoscope is a camera mounted on a specially shaped laryngoscope handle with an acutely angled blade, utilising indirect vision. The shape of the blade allows intubation without neck movement and making it a class choice for intubation in patients with limited neck movement. In the recent Paediatric Difficult Intubation Registry assessing the efficacy of the Kaleidoscope and the direct for intubation in near 1,300 kids with anticipated difficult intubation on initial attempt, Kaleidoscope flew it, the higher success rate, a far higher success rate than direct without increasing complications. I'm delighted to say that myself and many of my colleagues have incorporated the use of video laryngoscopy into routine and emergency airway management in the intensive care environment. Based upon mannequin studies, even beginners can achieve high success rates for intubation, 95 to 100% when using video laryngoscopes. Intubation skills gained can be transferred to the use of the standard laryngoscope when the video scope configuration is similar. It just permits effective surveillance of trainees performing endotracheal intubation, and especially amongst us paediatricians. Like, I don't know about you, but my first attempt at intubation was on a 500-gram premature baby, and it was basically consisted of being handed a laryngoscope and being told to go. Like, it was not a success, and as a very high achiever, and I don't like to lose, Simon, it was tough. Therefore, the scope of educational practice is immense, unique, and essential for my confidence in all around us. Now, I know us intensivists are probably the most highly skilled now in the hospital, but even we aren't afraid to admit that paediatric airways can be challenging. evidence states that the smaller the child, the more difficult the airway. As evidence, the video laryngoscope has so many advantages. For the patient, better success rates on first pass, especially when challenging airway anatomy, less risk of esophageal intubation, less oral trauma, less C-spine movement, and less hemodynamic compromise from intubation. For ourselves, there's been a breakthrough for education, and novices who train with video laryngoscopy are proven to adapt and learn direct faster. I know there's criticism that some video laryngoscopes are associated with increased intubation time, but there's so many emerging on the market that one must use your expertise and experience to adapt your instruments to benefit the patient. Use a different scope. We know blah, 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 blood, excessive secretions in the oral cavity and pharynx will make visualization difficult. But let's face it, it's not as if you can see much with a Mac with a mouthful of blood. Look, I'm not saying throw the direct laryngoscope out, but for me, and first choice for patient care, my vote is for video. Boom, put that in your Mac and smoke it, Simon.
Hello, my name is Simon Jackson. I'm a paediatric ICU trainee based between Belfast and Liverpool. Firstly, for those who can understand the Derry accent, I'm sure they'll appreciate that was a great talk by Seana. Secondly, thank you to Dr. Flannigan for asking us to speak today. I'm here to support the use of direct laryngoscopy for intubating critically ill children. I'm happy to admit I prefer using video laryngoscopy compared to direct laryngoscopy. However, I hope to convince you that it's really important that everybody who intubates ill children should train and be able to undertake direct laryngoscopy. To answer the question, critically ill children should be intubated using video laryngoscopy, I'm going to explain to you, firstly, why we should be intubating critically ill children by direct laryngoscopy, and secondly, that the evidence base tells us there are good boundaries in which to train and perform direct laryngoscopy. So I'm a paediatrician by trade, and I undertook anaesthetic training as part of paediatric ICU training. My anaesthetic training has occurred during COVID times, so we were largely discouraged from using direct laryngoscopy in adults and encouraged to use video laryngoscopy. Video laryngoscopy is an excellent tool for training purposes, and having somebody provide real-time encouragement, advice and feedback is fantastic. I imagine that a large proportion of paediatric ICU trainees and future trainees will train mostly or exclusively with video laryngoscopy, and in the future most patients will probably be intubated by video laryngoscopy. However, heavily training and using video laryngoscopy concerns me. I think it puts a small amount of children at risk of harm. The reason for this is something that we have all experienced, which is that technology can fail. Video laryngoscopes can fail when we need them the most and put your patient at risk and leave you in a tight spot. Direct laryngoscopes can have faults too, but they're easy to check, fix and replace and are a more dependable tool. This is well demonstrated to me last week when I was supervising a trainee using video laryngoscopy for intubating an ill child and the battery failed mid-procedure. As they were less familiar with direct laryngoscopy, I had to take over and complete the intubation. This is something I prepared for. Because my training has been primarily in video laryngoscopy, I recognised I wasn't as good at direct laryngoscopy as I should be. I knew that at some time I'd be in a position where I may be in an unfamiliar ward or environment and I'd have to intubate an ill child without my favourite video laryngoscope being available, and I'll be handed a direct laryngoscope that I may not be well trained to use. That's why I went and reviewed the literature and determined what patients I would train and focus on intubating by direct laryngoscopy. So if you're a clinician who regularly intubates, you need to be able to master the circumstances you're in and be competent in using the tools available. It is your responsibility to keep your patients safe, so direct laryngoscopy is a skill you should be maintaining. So what does the evidence base say about whether direct or video laryngoscopy is superior for intubating ill children? The only paediatric ICU study examining intubation practice was a large retrospective review which occurred within multiple international paediatric ICUs. This assessed direct and video laryngoscopy in ill children and measured adverse outcomes. It was demonstrated that video laryngoscopy significantly reduced less severe adverse events, including esophageal intubation with immediate recognition. However, video laryngoscopy demonstrated no significant difference compared to direct laryngoscopy in the amount of attempts to successfully intubate or in the occurrence of severe adverse events, which included cardiac arrest. So this sole paediatric ICU study does not persuade me that I would be harming my patients by using direct laryngoscopy. So are there any other studies which may have found direct laryngoscopy causes harm? In short, one cohort study conducted in a single A&E department and a meta-analysis of RCTs on elective, surgical children demonstrated no significant difference in performance or adverse events between devices. So what else is known? Difficult laryngoscopy occurs more under 1 year of age, and that's being reported to occur between 1 in 25 to 1 in 400 cases, so relatively frequently. The NAP4 report highlighted that approximately a quarter of major airway events occurred in ICU or A&E departments. NAP4 noted that paediatric morbidity occurred in anticipated difficult airways and in a small number of unanticipated healthy children. The Paediatric Difficult Intubation Registry and the National Emergency Airway Registry for Children have established risk factors for difficult intubation. These include weight less than 10 kilograms, more than 2 direct laryngoscopy attempts, 3 direct laryngoscopy attempts before attempting video laryngoscopy, history of difficult airway, signs of upper airway obstruction, micrognathia. Other studies have highlighted risk factors including syndromic children, children intubated for cardiac surgery or maxillofacial surgery, and Malin-Patty class 3 or 4. So as a trainee, I've established that I need to train with direct laryngoscopy, but I do not want to put myself or patients at risk unnecessarily. So I've used the evidence to determine when I will use direct laryngoscopy. I believe if I train within these boundaries, when I need to intubate with direct laryngoscopy outside these boundaries, I'll be more likely to be successful. The boundaries I use to guide my practice are: firstly, I automatically try to use video laryngoscopes when I'm outside of my familiar environment of paediatric ICU, or a child is peri-arrest, or there's anticipated difficult airway. Secondly, I automatically try to use direct laryngoscopy in all other patients, but I'm mindful of when patients have only been intubated by video laryngoscopy before, or if a child is less than 1 year or less than 10 kilograms, I still use direct laryngoscopy, but I'm aware failure risks are increased. And I quickly change to my plan B of video laryngoscopy early if the first attempts with direct laryngoscopy are unsuccessful. So in conclusion, whether we like it or not, if you intubate, you have to be able to undertake direct laryngoscopy, because no matter what systems we have to prevent video laryngoscopes not working, these systems can fail, and we need to be able to use direct laryngoscopy to prevent harm to our patients. Anybody who's seen Jurassic Park will appreciate that safety procedures and equipment can fail. Thank you.
Hello everyone and welcome back. This is the final panel discussion of the day, and there is a slight difference. You've heard Seana's arguments and you've heard Simon's arguments. We're now going to give them each a minute to respond to each other's cases, and then we'll have some questions from the panel. Please, still, it's not too late if you're watching, put in the YouTube chat any questions you might have or that you'd like us to put to Seana or Simon. There's still time to do that. It's also worth mentioning that that we have reset the poll for the third time. Keep an eye out on the screen. It is going to come back up, and we'd like you to vote now that you've heard the arguments. So keep an eye out for that. So Seana, I'm going to give you a minute to start to respond to Simon's argument. We'll be quite strict in the time, so I'll give you a wave when there's 10 seconds left, and then we'll stop and we'll go on to Simon. So time starts now.
So I don't really think, having listened to Simon's, I really have much to debate. In his final statement, he said his plan is to use video whenever the child's in peri-arrest or unstable in an unfamiliar environment, when there's a potentially difficult airway, and more than likely when the kid's less than 10 kilos or less than 1 year old. Have you not described the majority of critically ill kids? So is there even a debate here at all? You said that a small amount of kids are placed at harm from using the video because technology fails, right? But what do we do when a ventilator fails or pumps fail? We use a backup. Technology is the future. I mean, the Mac Direct is there, and I'm not saying throw it in the bin, but batteries also die and bulbs also fuse. You know, there always has to be a backup. I also didn't argue about not to learn the skills of direct. My argument is that by using the video, you can learn the direct
10
approach.
seconds.
And from experts, and it's a far superior way and transferable skills. The video laryngoscope is versatile, it's transferable, it creates confidence, and it's significantly proven to cause less severe adverse effects in kids. So our first priority is to do no harm. The video.
Okay, Seana, I'm going to have to leave it there and pass over to Simon. Give him a chance for a minute to come back at yourself. So, Simon, your time starts now.
Thanks, Seana. Very succinct as always, mate. So you went into detail about a variety of videos and blades. Do you have one that you use predominantly, or use a variety for every intubation?
Am I part of your 1 minute, Simon? So I would use. So I would use the McGrath of the CMAC because I have experience.
Okay, so you don't use direct then. What happens when equipment fails? And video laryngoscopes, as I've described, will fail. Technology will fail, and you need to go back to direct. If you can't master direct, you're putting children at risk. children will die.
There's evidence
like,
to
you have
say
to
that
use
people who
backup.
learn. There's evidence to say that people who learn from videos from scratch are better at direct laryngoscope because there's transferable skills. You can use the McGrath, the CMAX direct or indirect. Your argument isn't there.
10
you
seconds.
can use it as you wish.
So you can use directly, but you have to be able to master direct whenever you need it. Your argument doesn't stand.
But you also
Okay,
said
and we'll leave it there, Simon. So thank you. You both had a chance to respond to each other. We don't have any questions such to the chat, although Witch Doctor 101 has said, Simon, they think you've been thrown under the bus. So do you want to respond to that?
Pardon?
Do you want to respond to that?
Oh, thrown under the bus?
Yeah.
No, I still think that I disagree. We all need to be able to use direct laryngoscopy. Video laryngoscopy is beautiful, but there will be times when we're all in a vulnerable situation and we need to be able to use it whenever videos fail, and there's no getting around that. Technology fails. So we have to be all skilled in using the backup, and if the backup, and backup's essential.
I didn't say don't learn direct. I said, would you use
You
video
need to know the
laryngoscopy
circumstances.
in critically ill kids? And
You need
first
to know the
off,
circumstances
I would.
about when to train and use it appropriately.
But
And
that
you haven't
wasn't the
encountered that
debate.
argument.
That wasn't the debate. It was in critically ill kids.
Grant,
Yeah.
I think we do have some questions for the panel. Is there anyone would like to ask Simon or Seana, either both or directly, a question?
I'll ask to both, please.
Yep.
Which do you think is the superior mode of teaching video laryngoscopy for the complete novice? So that includes the fresh trainee anaesthetist and the fresh pediatrician doing their first neonatal shift. What is the superior way of teaching them the basics? Which of the two?
Video laryngoscopy.
I agree. Video laryngoscopy,
Brilliant. Direct.
Brilliant for learning with in a supportive environment.
Until I went to Chris's intubation course, I never quite knew exactly what I was looking for. I haven't done a year of neonatal. Essentially, you get handed a direct blade and a bit of description, but you don't know what you're actually looking for. Whereas video laryngoscopy, you can see the anatomy, the experts can train you. You know what you're doing, where you're putting the tube, and your trainer, your consultant has confidence that you're not doing this child any harm.
So with that in mind, do you think having a VL and access to a VL should be standard for neonatal units everywhere, instead of allowing just the anaesthetist to use it in their armory?
Yeah.
That's essential. Yeah.
Essential.
Okay, so how do we change that? Because it's not the case, is it, in the UK, let alone in resource-limited areas, which we have a lot of the people watching now. So I'm keen to change that. I just don't know how to change that.
I mean, primarily neonatologists don't really go through anaesthetic training like we would do. Perhaps if they had a more structured training program, which included time spent within anaesthetics, they would maybe pick up those skills and take that back to their own practice.
Yeah, I agree.
Peter, I know, and sorry.
No, it's okay. Sorry, go ahead.
Okay. I was going to say, Peter, I think you had a question as well that you were hoping to ask.
Yeah, I would just say that, as medicine gets more complicated, whenever we're not sure what to do, we bring everything back to first principles and to basics. And with equipment, it's exactly the same. If things don't work, we tend to fall back on what we're more familiar with. And what you guys are saying is that video laryngoscopy should be our first line. Therefore, by default, the suggestion that you're making is that the standard practice across the country right now, which is for direct laryngoscopy in the vast majority of people, what you guys are therefore saying is that we're all doing it wrong. Do you think you're qualified enough to say that?
No, I mean, what the argument I think I'm making is that I think video laryngoscopy is a great tool to be used in the right circumstances. However, there's an absolute role and need for knowing how to use that. But we need to know when to use it appropriately and safely. And there is evidence, as I've said, to support when we should be using it and training with it.
there is heavily supported by companies a lot of the time, you know, and I think we need to look at evidence and look at what our standard practice is and what do we normally do to stay safe? Because when we reflect on things that go wrong, which we do a lot of the time we forget to reflect on why things go well. And part of the reason things go well is because we have routines and we have muscle memory and we have practice. So therefore, at the moment, direct laryngoscopy works, it keeps us safe. And what you're suggesting is moving away from that practice. Now, it's easy to say that when you're going to win some sort of video scope. Yeah, fine, you know, but I would argue that both of you are slightly biased right now because you have got incentive. You can't, by default, you must be biased. And you're telling us that we're all wrong.
I'm not telling you you're wrong. I'm not arguing against learning direct. I think everybody needs the fundamentals. When I did my anaesthetics training, I objected to the fact that they handed me a video laryngoscope to do routine lists, etc., because I felt that you do need the skills in both. But what I'm saying, in a critically ill, time critical situation where, you know, you may not be at full point, you may be rise, the patient's unstable, you know, video laryngoscopy, there is a lot of evidence to say it has provided for a better airway.
And there's a lot of evidence that direct works well in critical care, and the evidence for that is hundreds of years of practice.
I know, but you're living in the past. There is a future.
So,
you know, you have to adapt. Ventilators have adapted. Laryngoscopes are now adapting. We're not saying throw them away.
Not always for the better, and that's the caution.
We're going to move on slightly. Just to draw your attention to the fact that the new poll has opened online or on the YouTube chat, so please do cast your vote there for who you think's winning this argument. Tudor, I know you have a question. Do you want to interject?
Yeah, so this probably goes against a debate, but the question is a question about use in critically ill children. And as for a lot of what we talk about in these pediatric emergencies is to use what is familiar. So if you get the older clinician who is quite comfortable and has a huge success rate on using direct laryngoscopy versus the newer trained anesthetic registrars coming in who go for the video laryngoscopy first, surely you want to be using the one that you're more familiar with in a critically ill child and leave the minutiae of the argument to those using something different at a later date. You know, so for the critically ill, would you not be recommending that the person use what they're familiar with over insisting if it's critically ill they use one or the other?
I think that's the underlying thing, but I think that as I said, training, etc., is changing, and there is a way forward. And with the introduction of these video laryngoscopes, people are maybe their best practice is with video laryngoscopy rather than direct. So yeah, obviously, acting the best pit, you're not going to, you know, use a type of video laryngoscope for the very first time on the most sickest kids, but you have to use what you're familiar with. But as I said, teaching, training, everything is evolving, and you know, who's to say in 5-10 years time that video laryngoscopy won't be first line, because that's the way training has developed.
Seana, Stephen suggesting in the chat you might backing down a little bit.
No way.
Oh.
No way.
Ooh.
Any other comments or queries from the panel?
I do think direct is a fabulous skill, but I think video laryngoscopy is the future.
I do have some comments, but I purposely said I would leave them until after the voting, as I'm very biased on this, but I would like to finish after the voting and say a little bit.
Yeah, you do need to think about maintenance of skills as well. You know, if direct is going to be your fallback option, and you decide that how you generally want to intubate critically ill kids is with a video, then that's what you're going to tend to use in critically unwell children, and you will over time lose the skill of direct laryngoscopy in the critically unwell child. So you do have to be careful about, you know, your patient cohort and deciding that yes, you should still be able to do direct, but we think your first line should be video, because if it's as good as you say it is and you're more likely to be successful, then that's what you're going to do, because you're never, hand on heart, going to say, okay, video is slick, video works, my success rate with video is better, but for this patient, I'm going to try what I think is a slightly less successful method to keep my skills up. That's not ethical practice. You can't do that. So you have to think about what your argument is here about keeping your skills up. That doesn't quite fit.
Well, I don't know if I agree with what you're saying, to be honest with you.
Unless you're an unethical practitioner.
No, I don't think that's fair either.
That's right. Yeah.
No, like there's definitely a spectrum of unwellness now.
Yeah, definitely. We're talking about the critically ill.
If we choose, like I'm making my argument, if we choose the patients we want to train in an area where not well skilled, we can do so in a safe way as long as we're aware of our boundaries and we know what we're skilled in going back to. Now, if we're choosing the wrong patient, Peter, then that is unethical. However, we have to remember that it is unethical to not be skilled in how to use the backup methods. And if we're called to a resus on a surgical ward where there's no video laryngoscope available, then that child is going to come to trouble if we're not prepared and know how to use the backup methods, which I say backup method, maybe I mean by that direct laryngoscopy, if that is the way things are. But it's not unethical to prepare and train within the guidelines and within the knowledge base.
So can I put cat among the pigeons? 20 years ago, the gold standard of putting central lines in was blind using surface anatomy. Now the gold standard is using ultrasound. No one is worried whether I'll go to ED and not have an ultrasound there and I have to do it blind, and that's unethical. Okay, so this is exactly where we are now with the video laryngoscope. Yeah, so the more people advocate for its use, the more available it's going to be. The technology is now old enough that it's becoming increasingly more affordable, even in lower and middle income settings. Therefore, if it's superior and more safe, I would suggest that's the direction everything is going, much like how central line insertion has gone over the last 20 years.
Costas, can I?
Sorry, go ahead, Simon.
Oh, sorry, Chris. Costas, in my sort of talk there, I sort of mentioned that the one sort of ICU study hadn't demonstrated any significance in severe adverse outcomes between direct and video. So I do appreciate your argument, but using ultrasound for centralized, but it is still comparing, pigeons with I don't know, crows. You know what I mean? Like it's two different arguments there. But
you said that there was less adverse outcomes with video laryngoscopy.
No,
yes, you did.
No, let me clarify. In less severe incidents. No, yes. So severe episodes, there was no difference. So
I would rather my check had an adverse.
There's a lot of evidence to suggest increased first pass success for using video laryngoscopy, and this is what we're looking at. No, not the adverse outcomes. It's how successful are you at putting the tube in the right place the first time, and VL for that is superior with trained people, and that's what we're looking for really.
Stephen, last comment, and then we'll have to wrap up.
Does anybody work in centres where instead of it being on a small video screen, it's displayed for the entire team to see? Because one of the benefits might be in that the whole team gets to see what happens. They're more aware of this critical procedures happening, and me as the leader of the resuscitation who's not intubating knows that it's in the right place. I can crack on with everything else. What's your experience with that, Costas?
Yeah, we have it. We have the Storts monitor on a big screen and everyone can see what we're doing. And it's great for me as a teacher to teach the trainees because I can see what the trainee can see. So it makes it from a very lonely sport at the top of the business end of the head to a team sport where I can see what the trainee can see, and therefore I can tell him or her how to manipulate the blade or any airway manipulation that might be needed in order to optimize the view and thereby getting better success. And a big screen, I'm a big fan of. I much prefer it to the one that's on the actual handle.
Yeah, that too, and it works really well, as Costa says. It won't stop me training people to do direct as well, where I can't see, and I accept that because I still have a responsibility to educate people. So both work. Both are appropriate educational approaches.
Okay, and I think in the interest of time, we're going to have to draw to a close. Yeah, Seana and Simon, I'm going to
I think what we should do, Ben, is we've asked people to wait until we ask them to vote. There may still be some people waiting. So I think, can we give everybody 30 seconds? Would you mind timing that to get your vote in now?
Yeah, we can give 30 seconds to give the vote. I was going to see whether Seana and Simon wanted sort of 20 seconds each as a final defense of their argument while the votes are going in. So if everyone can vote while Seana and Simon give us a final pitch for their stance. Seana?
I don't really think there's much more to say. Video laryngoscope, we've talked about it. It is superior at teaching, it's superior view. The children are more stable. In the critically ill kid, it's proven that first pass, you have higher incidence of first pass rates. You know, it's the future. There's not much else to say.
Simon?
I think the same argument I made earlier still remains. We cannot guarantee always having video laryngoscopes available. We need to be able to master our circumstances and be able to use direct laryngoscopes. We need to train and look after children appropriately. And there will be the 1% or less patients whenever we need to be able to rely on direct laryngoscopes and when videos fail. So there.
Okay, thank you. So Chris, hand over to you in the vote, and then.
Yep. So I think it's fairly clear. Seana is the winner. Congratulations.
Oh,
yeah. I think Simon did a great job though, because he was completely losing, and to have brought it back to 66-34% is incredibly impressive. So Seana, you're the winner of the AirTrack camera range of AirTracks, and we'll throw in one of the mannequins as well. So you can practice at home as long as you make sure to bring it back to the intubation courses when you're teaching on them. I purposely said I wouldn't share my opinion during the debate because I didn't want to influence things, but I would like to share my thoughts, so that's okay. I am a strong believer that critically ill children should be intubated with video laryngoscopy. The big reason is most critically ill children, I think, are intubated by a general anaesthetist. And with small patients, and I think, as Peter said in his talk, using a Miller blade to lift the epiglottis is not what I think you should be doing. And I would have agreed with what Peter said previously before the advent of video laryngoscopy. Stick with the curved blade that you're used to. You don't need to lift the epiglottis directly. You'll get 9 out of 10 times out of 10, you'll get a good enough view to intubate the patient. You're probably getting a grade 2 view. It's not a perfect view, but you'll be able to intubate the patient and using a tool that you're familiar with. With the advent of video laryngoscopies, and particularly now with COVID, I think things have changed. More patients are being intubated with video laryngoscopy. So the general anaesthetists are intubating their adult patients with video laryngoscopy. If you use a traditional shaped blade, such as a Macintosh shaped blade, it is absolutely no different intubating that neonate with a Mach 1 blade compared to intubating the bigger patient with a Mach 3 blade. The technique is exactly the same, and I think that is going to lead to a higher rate of success in critically ill children. When we go out and the anaesthetist hasn't been able to intubate the child, most of the common time it is actually a grade 1 airway, and it's just that unfamiliarity of using the Miller blade has caused the problems. So that would be my thoughts on it. The other thing is video laryngoscopy fails. I've had it fail a number of times. I'm doing 99% video. It's failed on me a couple of times over the last few years. And in those situations, direct has rescued me. So you have to still keep your direct skills up. You're going to go down to the ED and cardiac arrest, and you're not going to have your video laryngoscope. But the question was critically ill children. So I think as a first thing, you should be using video laryngoscopy. For less unwell children, keep your direct skills up. Because you can't lose those. They're going to rescue when video fails. That's my thoughts. You can see why I didn't give it beforehand.
So I think Simon was thrown under the bus then. Is that what we're in agreement for?
The thing, Simon threw himself under the bus because he had the choice and he picked to go with that one. So it was very brave. Maybe a bit stupid though.
Oh, no, I know Seana needs some help there, you see.
Yeah.
Listen, Seana and Simon, thanks very much for putting the time in the debate and for putting yourselves in the firing line. Appreciate it. And I'm just going to hand over then to Chris to bring the day to a close.
Yeah. So first of all, I just want to thank a few people. Firstly, I'd like to thank everybody who gave a talk today. I think they were all of really high quality and I really enjoyed them. As well, I'd like to thank everybody on the panel. We added a little bit more time this year. In fact, we doubled the time for panel discussion. I think it was really worthwhile. I'm privileged to work with all these guys on Paediatric Emergencies, and I think the panel discussion was great, and look forward to having this on a yearly basis. I'd also like to thank our sponsors. They were a big reason we were able to put this on for free. Without them, we would have had to charge a fee for the equipment. So thank you to them, and a particular thank you to AirTrack for sponsoring the prize. The big reason we do this event is we're hoping that some of the knowledge we have shared with you, somewhere along the line, you're going to use it to help a critically ill child. If you do that, please get in contact with us and let us know. You'll find my address over in the Paediatric Emergencies website. After last year's event, very shortly after, only a few weeks, I was contacted by somebody who had listened to Dr. O'Sullivan's talk. It was a metabolic case, and they had used what Dr. O'Sullivan taught them to pick up a child with hyperammonemia and save that child's life. I fed that back to Dr. O'Sullivan, and she was absolutely delighted. That made all the work she had put into that presentation, all the work I had put into getting this together, completely worthwhile. So if you do something like that, please let us know, because I'll feed it back to the individual speakers, because it means a lot to us that we're actually sharing knowledge and you're using it. The other thing, if you haven't made a donation to Helping Hands, please do that. The reason we've done this for free is we're hoping to provide a bit of a donation to the charity in lieu of any course fee. If you're thinking of not making a donation, please just donate £1. You can do that anonymously, and that will make a real difference and help us to meet our target. The final thing, we've been getting a lot of questions in the chat about certificates and feedback. What I'm going to do, I'm going to head over to Tudor now to give his thoughts on that. Tudor has been great over the last few weeks. He's done an awful lot of work getting you some CME accreditation and revamping this whole system. So I'll let him share how you're going to get that.
So guys, I posted the link to the feedback form in the chat. It's also at the bottom of this, of the YouTube description. You can go ahead, select as many of the talks as you've watched. Please be honest, because it's you're declaring which videos you've partaked in, which discussions you've listened to, and you finish the feedback form and you can get a certificate. If you are wanting to come back and watch the videos individually at a later date, Chris will be putting a live page with all the talks on it. The one from today will go off the website, and the page will be replaced with a talk with all the individual talks. Below those is a link to a MCQ question bank for each of the talks. This is because you haven't been there on the day, you're doing it at a later date. You have to complete the MCQs. If you get 80% or more on those MCQs, you'll be forwarded to the feedback form for that talk. If you complete that, you'll still get a certificate for that individual talk, and you'll need to do that for each of the talks that you go through. We do ask, if you're doing multiple feedbacks for different talks at a later date, please only give us your demographic information, just for where you are, what job title that you have, etc., for the one talk, so that we don't duplicate in our feedback multiple attendances. I hope that's clear. If not, you'll see it on the webpage. It will just say, click here to get your certificate. Okay, thanks very much for participating, and thanks for all who have already given us feedback. So great, thank you.
Okay, thanks very much, everyone.
Chris, before you close, can I just say a special thanks to you as well on behalf of the Paediatric Emergencies team. There's a huge amount of hard work goes on in the background in terms of the IT, recording the talks, editing the talks, and I know you put hours and hours into it. So you've thanked other people, but it's important that we thank you as well for all the effort that's gone into making today the success that it's been. So thank you.
Okay, thank you. Okay, that's great, everyone. We'll end it there, and we'll maybe see a few of you next year on our intubation course, and we'll see everybody else at the live stream next year.